to keep us in loop. Let me introduce our first session moderator, Dr. Abdulaziz Al-Qahtani, consultant, clinical pharmacist, ambulatory care at King Saud University Medical City, chairman of ambulatory care, Saudi Society of Clinical Pharmacy. Welcome, Dr. Abdulaziz.
السلام عليكم ورحمة الله وبركاته. صباح الخير عليكم جميعا. Good morning, everyone. It's a great honor and privilege to be in Higher region, and I would like to take this opportunity to thank all the organizing committee and also scientific committee for making this event an exceptional in life medicine conference. We'll kick off our today sessions with exceptional and distinguished speaker. The first speaker is Dr. Ali Jar'atli. Dr. Ali Jar'atli will talk about stress and weight problem. Dr. Jar'atli is American Board of Psychiatry and Neurology, head of section of psychiatry at King Fahd Medical City in Riyadh. Welcome, Dr. Ali.
You cannot hear.
Bismillah ar-Rahman ar-Rahim. Thank you very much for this nice introduction. My name is Dr. Ali Jar'atli. I'm a psychiatrist in King Fahd Medical City. So I always like coming to Ha'il. It seems to have very nice weather, very nice people, and very relaxed atmosphere. So thank you very much for having me here. This is my second contribution this year. Last year I was here also. So Bismillah ar-Rahman ar-Rahim. As a psychiatrist, we always like to say there is a lot of commonality between mental illness and every part of life. So I was talking with my friend Zamel, and he said we always have to have more psychiatrists. We have to deal with a lot of psychiatric problem in our life. So let's start here. We look at the brain as a psychiatrist as we have three brains. So that is very essential because the brain is the main function of the brain is mental health and mentation. So the brain consists of three brains: the midbrain or the essential brain or the survival brain, and the limbic brain, which handle our emotion and our dealing with daily life in terms of emotion and feeling. And then we have the frontal lobe, or the PFC, prefrontal cortex, is the part of the brain that is responsible for our thinking and behavior and making decisions. Also, the role of the frontal lobe also is to control the other part of the brain. So we call it the babysitter of the other part of the brain. So our frontal lobe is our babysitter of life. And as you can see here, the whole three brains work together to form who we are. So if we feel somebody who is very anxious and irritable, that means they are using the lower part of the brain. If he is more thinking, he is using the front of the brain. And the brain works very well together to form who we are. So inside the midbrain, what we call the old brain, we have something we call the ventral tegmental area, or the survival brain, which is inside the midbrain. Although we have very complicated brain and deal with a lot of complexity, which is very difficult organization of our life, the midbrain still take a major role in our life and play a major things in our life, despite having all of these complicated frontal lobe. So the midbrain still play a major part in our life, despite all of that. So when we look at these things, we have to talk, when we talk about depression, addiction, any aspect of life, we have to talk about what we call the reward system. And the reward system is a very important part in our life. and it consists of the ventral tegmental area, which is located in the midbrain, and the nucleus accumbens, which is located in the striatum. So what happened, this reward system, we call it in Arabic, jihaz al-mukafa'a. So what happened in this area of the brain, the ventral tegmental area, is the most important part in what we call the reward system. So for example, when I eat, when I use drugs, when I sleep, when the patient have intimate relation, when they eat food, all of that will increase dopamine in this area of the brain between the ventral tegmental area and the nucleus accumbens. They call it the reward highway or the pleasure highway on the brain. It was discovered by a neurosurgeon many years ago. When he touched on this part of the brain, he noticed that the patient felt so good. And that's why they discovered the reward system in the brain. So the more dopamine we have in this area of the brain, the happier we are. So when you feel somebody excited and happy, that means he had a lot of dopamine secreted in this area of the brain. What happened is anything that increased dopamine can cause us to have some addiction. For example, if you use drugs or if you eat a lot, then the reason why we like to eat, the reason why we like food, the reason why we like drugs is because they increase dopamine in this area of the brain. Anything that increase dopamine make us feel good, make us feel relaxed, make us feel more calm and happy. So feeling good is part of that, because when we feel good in the frontal lobe, where we feel that good feeling, that means it's coming from that ventral tegmental area, which is the primitive part of the brain. And this is what drives our behavior. So always we like to have this happiness, so we look for anything that make us feel more reward and more relaxed. On the other hand, the ventral tegmental area is located in the primitive part of the brain, which is called the primitive brain. What happened is, what is the relation between food and addiction and stress? So we said food, for example, because we're going to stay away from the real addiction. We're going to concentrate on food and obesity here. So food, when I eat biryani, when I eat kabsa, when I eat anything that make me feel happy, then that food will increase my dopamine in the frontal lobe and in the ventral tegmental area and the nucleus accumbens. That's what I feel great, and I feel more relaxed. Then what happens is, if I'm stressed out, for example, when I am stressed out, then my dopamine, instead of being up, it will go down. So anytime when I am stressed out, my dopamine will go down. So what happens is, if I have very stressful life, for example, as a physician or as anybody who had a lot of stress in his life, his dopamine will be low. Stress will lower your dopamine. To compensate for that, we start eating a lot. So a lot of people, we call them emotional eater. So emotional eater happen when your dopamine become a little bit low, below the homeostasis level you are used to, and then to overcome that homeostasis level decrease in the dopamine, you compensate by eating a lot. So eating a lot is a way to deal with the stress of life. So anytime I am stressed out, I need to feel good, so I need to increase my dopamine. For example, instead of eating one dish of kabsa to make me feel good and reach my level of dopamine, which bring me happiness, then I have to eat 2 to get the same level of happiness, because my homeostasis level has went down with the cortisol level, and I start, when I eat a little bit more, to get the same level of happiness. So I need to eat to feel normal, not to feel happy now, just to feel normal again. I need to overeat to do that. So what happened is, we have this area of the brain, which is called the ventral tegmental area, and the nucleus accumbens. And as you can see here, food can increase dopamine in this area. As you can see here, for example, kabsa will increase dopamine a lot more than cucumber. That's why we never invite somebody to eat a cucumber or tomato with us. We invite them to have very what we call it, not healthy, well, let's say fat food, because the more calories in that food, the more dopamine is gonna have in my nucleus accumbens, and the more happy we are. So food is a way to make us feel happy and joyful, and stress will make our joyful a little bit lower. Then I need to overeat to get the same level of happiness. We call that homeostasis. And this is why we always look for reward. And then our brain will be able to see which food is more important, and then we'll say this capsa is more important than cucumber because capsa is more important for survival. And that's the part of the midbrain we said, which is the survival brain, which can tell us which is better for survival and which is not good for survival. So here, because capsa will release more dopamine in the frontal lobe, more dopamine in the nucleus accumbens, and more dopamine in the ventral tegmental area, our unconscious mind put a very important things for capsa that it is important for survival, because the midbrain's role is to keep me alive. And the midbrain will tell me, look, Ali, cucumber is okay, but capsa is very important for our survival, so I want you to concentrate on capsa. It will make the frontal lobe look for that things that make us have more reward and more feeling of happiness. So what happened is when I'm stressed out, we said when I'm stressed out, my dopamine will go down, and then I need to get that dopamine back up, so I will go immediately either to food as a reward, or some people will go to drugs and alcohol to get back their normal life, to get back to the normal level of dopamine they get used to before they have this. So the problem with stress is the stress will lower our dopamine. And when we don't have dopamine in our frontal lobe, not only we are not feeling rewarded, but we feel miserable. Without dopamine, normal dopamine is what makes my frontal lobe function very well. The more dopamine I have in my frontal lobe, the more rewarded I feel, the more accomplished I can do. So the frontal lobe's job is to make us make decisions and make things in our life normal. So the frontal lobe is the part of the brain that make me who I am. And that frontal lobe need a lot of dopamine to function. And when my stress level is high, my dopamine is low. So to make my frontal lobe function again, my nucleus accumbens become very sensitive for that food, and we crave that what we call the junk food, and we crave that cake. The cake here's job is to make my frontal lobe function again in better way. That's why we call that better for survival. So basically, when we are stressed out, our frontal lobe will, our nucleus accumbens will crave that unhealthy food to get my dopamine level high. It becomes very sensitive to the dopamine need, and it will need a lot more dopamine to get normal. For example, Mona Lisa is here. Mona Lisa, if she is stressed out and start eating, she will be like this, because she will crave a lot of dopamine, and she will eat a lot of junk food to get back to normal life without the stress. So apparently when he drew her, she was not under any stress at that time. So what happened is our brain always have balance. So our brain always have a balance between the midbrain, which require that food, and the frontal lobe, which tell the midbrain that we need to balance. We don't want to eat too much. We need to keep what you call it, keep you under check. So you don't want to overeat or undereat. So the role of the frontal lobe, especially the anterior cingulate cortex and orbitofrontal cortex, which is very essential part of the frontal lobe, is to balance that between the need of the midbrain, which require us to survive on Earth, and the ability to function normal so we don't overdo things. So this balance is very essential to our life. That's why I don't eat too much. If I want to crave cake, I will eat tiny little piece of cake, but I will not eat the whole cake. The problem in some patients who have addiction or who have what we call emotional eater, or they overeat, is their frontal lobe is not functioning very well. So we call that failure of the top-down control of the frontal lobe over the midbrain. So the frontal lobe failed to control that midbrain. And that's what happened when we are emotional eater or when we are addicted to drugs or alcohol. The problem, stress means cortisol level is high. And when we have high cortisol, we disrupt that function of the frontal lobe to overrule the midbrain. So cortisol will lower that ability of the frontal lobe to control that midbrain. And that's why when we are stressed out, we eat a lot, because our frontal lobe will not be able to control the midbrain, because the frontal lobe under stress will not be able to function very well. Under stress, the frontal lobe tells us that we need our reward right now, and our frontal lobe is dysfunctional, and the patient starts eating without realizing what he is doing, because the frontal lobe will be out of touch because of that stress level. Okay, so cortisone, and by the way, testosterone also do the same thing, will lower that frontal lobe ability to control our midbrain. So as a physician, and this is one of my friends, I call him Dr. Z, our life is very, very stressful. And a lot of doctors, you see, they used, and a lot of health workers and a lot of stressed people, they use drugs they use food as a way to handle this daily life or stress. And that's why a lot of physicians, a lot of people who work very hard, who are very stressful, they start eating a lot to overcome that stress, to lower that cortisone, and also to increase that dopamine to make us feel, not feel good, just to feel back normal the way we should be all the time. The problem is we go into vicious cycles. So stress makes us eat a lot. When we eat a lot, we feel guilty about eating. So we feel more stressed, and then we start eating to overcome that stress. So we call that a vicious cycle. So in treatment of those patients, I try always to break that vicious cycle, try to improve that frontal lobe, and try what we do is self-awareness. We tell the patient, you are doing this to overcome your stress, and we try to explain to him how we can break that vicious cycle. Because especially when we deal with women, and most of a lot of my patients are women in this category, what they do is when they start eating a lot, it will destroy their self-esteem. Because women, when they gain a lot of weight, it will destroy their self-esteem. Why? Because the male gaze always look at the complexity and the what we call the feature of the woman. We concentrate a lot about that. So when they gain a lot of weight, they become unattractive for male. And that is really devastating for them because the way male look at things is at the visual things of the woman. While women, on the other hand, always more pragmatic. They look at the frontal lobe of the man. They look at man more in his accomplishment and his frontal lobe ability to deal with the stress. They look at the features, but mainly will look at the gaze of the woman. So we said here, then the survival brain or the midbrain is very essential for our survival. And under stress, it will take over our brain. So that's why people under stress will concentrate more on the survival brain. So I will always give this example to my student. Let's say you are stranded on an island and you have a new ship coming. You wish that ship will carry broccoli or cupcake. And the survival brain will always choose the cupcake over the broccoli because the midbrain or the survival brain feel there is more calories in that survival, in that cupcake, much more than the broccoli, and he will always choose the cupcake because it has more calories. That means it's very good for survival. And this is what happened to us under stress. Under stress, we always try to eat the food with high calories because we want to bring that dopamine back up to feel normal again. And we say dopamine is so essential, not only for our function, but always for the complexity of the function of the frontal lobe. We say the frontal lobe or the PFC is the part of the brain that work us with our daily activity. Without dopamine, we'll be like this guy here. We'll have no motivation. We cannot get out of bed. We feel like we are about to die. So usually when we are like this, the midbrain, the ventral tegmental area and the midbrain will send a message to the frontal lobe. Look, frontal lobe, we are dying. We need that dopamine back. And that's what happened with people who are addicted to alcohol or drugs when they abruptly stop using the drugs. When you have bariatric surgery, when you stop eating a lot, then the midbrain will send a message to the frontal lobe. Look, frontal lobe, we are dying here. We cannot get out of bed. We are unmotivated. And that's why when I see patients after bariatric surgery, they have like a couple of months with very severe depression, severe agony, because that loss of the dopamine in the frontal lobe caused them to have almost no meaning of life. Their frontal lobe will not function. Now the question is, when I counsel my patient, including my counsel myself, I said, look, alcohol is bad for you. Smoking will kill you. Same thing, junk food will be bad for you. And all of these ads throughout the last 50 years, they didn't help. They put on the cigarette will kill you, the alcohol will kill you, but nobody listened. Why? You see a lot of this campaign and you explain to them, but nobody listened. The reason is, the problem is not in the frontal lobe. When you say alcohol is bad for you, when you say junk food will kill you, smoking will kill you, you are talking to the frontal lobe. The frontal lobe here is not the problem. The frontal lobe knows that obesity is bad. The frontal lobe knows that alcohol will kill you. The frontal lobe knows that cocaine will damage your heart and your brain. But the problem is nobody listens. Why? Because we need to talk to the midbrain. The problem is not in the frontal lobe. The problem is in the midbrain, and you need to help the patient go to the midbrain or the survival brain. That's why all of these ads throughout the year did not work at all to change anything in our life. So, and we see the midbrain is unconscious. The problem with the what we call the limbic brain or the midbrain is much, much faster. So we always use our midbrain before we use our frontal lobe. Always the midbrain comes first. So, for example, when I have something problem, the fear always comes before recognition. So if I see a robe here in the middle of the desert, my limbic system will say this might be a snake, so I need to be careful. Then my frontal lobe will realize that it is just a rope, so I'll be fine. But always the first reaction will be in the old brain, the limbic brain, because this is the brain we have for a long, long time, and we get used to it. While the frontal lobe or the new cortex is new, we don't know how to use it. So the role of psychiatrists here is to teach the patient how to use this nice piece of tissues, we call that the frontal lobe, to help us deal with the problem. So always, for example, when I see the pizza, when I see the biryani, when I see the kapsa, my frontal lobe will say something, then my midbrain will say, look, this will increase our dopamine very high, so shut up, frontal lobe. By the time the frontal lobe interferes, the pizza is already in your stomach and you already feel guilty about it. So what happens is, we need to teach the patient how we use that frontal lobe. So part of treatment of eating disorder, addiction, obesity, depression, anxiety, they all have the same mechanism in general, is they are not using that frontal lobe well. They are not utilizing this nice piece of brain called the frontal lobe. And that's what we do in something we call cognitive behavioral therapy, where we teach the patient how to use this new brain he had instead of keeping it in his brain without any use for it. So why we don't use it much? Because our brain develop usually from back to the front and from down to up. So most of us will use our first and second brain because we have them for a long time. We get used to them for a long time and we know how they work. We need to teach the patient how to use this third brain called the frontal lobe. And by using that frontal lobe, we always can make better decisions. If we see patient very anxious and overeating and using addiction, that means he is relying more on the survival brain to get survive on earth. And that is not a good way to deal with life difficulties. So I always use what my teacher used to say, Joseph LeDoux from New York, and he resembled this. I like this slide a lot because what happened is, let's see here, you are in the jungle and you see a snake here. The snake is recognized by the thalamus that is very dangerous creature. So immediately the amygdala, which part of your limbic system, will immediately make you jump. The amygdala have ability to connect with the heart and the muscles and make you jump out of the dangers. While the frontal lobe is not aware of that, the frontal lobe will know that later. So the frontal lobe, after you jump from the snake, the frontal lobe said, great job, mashallah alaik, you did very good job. The frontal lobe did not interfere here because the frontal lobe takes time to work. Same thing happened, this is to protect you. So amygdala here is like your mother, is the part of the brain here that to protect you. It's called the amygdala, it's part of the limbic system, part of the survival brain. The same thing happened when you see, let's see, when you see that pizza, when you see that alcohol. If you are addicted to pizza or you are having some eating problem, then when the amygdala see the alcohol and see the pizza, the same amygdala which protect you from the snake, from the danger, is the same amygdala that wants you to get that pleasure of the pizza, the pleasure of the alcohol that increase in dopamine. So you go and usually use that pizza and alcohol, and then the frontal lobe tell you, you did poor job, you should have not done that. But the problem is the frontal lobe came to the picture a little bit late in this domain. So we need to really teach the patient how to use the frontal lobe. So this is very important in the therapy. Okay, we are about to finish. So why it's very difficult to stop eating? Why it's very difficult to stay away from the high calories food? Why it's very difficult to stay away from alcohol, and why it's very difficult to stay away from cocaine in those addicted patients? Because the more drug you use, the more memory you're going to have in your hippocampus, the memory center of the brain. So if you look at somebody who is very morbidly obese, the memory of that junk food, the memory of that hamburger are very strong in their hippocampus. So when they stop using the food or the drugs, it's going to take a long time for us to get this memory down. It takes 6 to 7 months. Same thing when you love someone. I remember one of my patients who was a doctor who was in love with some lady, and after she left him, she dumped him for some reason, and he became so depressed. It took him 6 months just to get over that memory. Why? Because the memory of loved one, and loved one can be a woman, can be a man, can be a bottle of alcohol, can be a cocaine, can be a capsa. All of these memory are engraved in our system. Very strong connection. It takes a long time before the memory to sub down, to go back to be normal again. And that's why it's very difficult. After we stop using the drugs, after that loved one is gone of our life, we feel so depressed, we feel so empty, we feel so angry, because our midbrain will start telling us we need that person and we need that nice food. So the problem is after we eat, this is Dr. Lamol from, I think, Paris, he talked about this. He said, we have what we call the payback time. And I have many stories about this. So after you drink alcohol, the next day you have what we call hangover. After we eat 6 or 7 pieces of chicken and capsa, after that you feel bloated, you feel angry, you feel sad, because the frontal lobe start looking at you and you said you did poor job. It's the payback time. You need to counsel you and you need not to do this again. We call that the payback time. What happened is when I eat that food, I have what we call high feeling, because that peak of dopamine is what makes me feel happy. After that peak of the feeling, I will have another time where the dopamine, which goes up, it will go down, and then you feel guilty, and you feel sad, and you feel angry at yourself, because the frontal lobe starts grilling you about what happened, and you eat all of that food. So always we need to look at the patient at the payback time where they feel angry and irritable. And that's really the time where we need to counsel the patient here. Okay, so most of us, after we do that, we use a defense mechanism. Always as psychiatrists, we need to know what defense mechanism this patient is using. So we use undoing. Undoing is after I eat heavy meal, so I will try to walk and do exercise to make my frontal lobe more happy with me, so it will not criticize me again. For example, after this is undoing, we use it with our spouse. So after you neglect your wife for a whole year, you invite her on Valentine's Day for a nice dinner to undo all the guilt you did with her throughout the years and make her feel a little bit more happy after that. So this is what we call undoing. So I'm trying to do that. So some people might use food as when they get sick, when they have all of these problems, they use that as punishment for themselves.
1 minute, please.
What?
1 minute, please.
Yeah, almost. Okay. So this will be my last slide. I'm sorry. So what happened is, in general, we need to make the patient use their frontal lobe. In general, we need to teach the patient how to eat healthy. The reason that we have something in the anxiety and depression will make us feel miserable, because we have some called microbiome in our guts. And when we are anxious and when we are depressed, our microbiome will be different than healthy people. We need to understand that the brain and the guts are intimately connected through the vagus nerve, and what happens in our brain will affect our guts, and what happens in our guts will affect our brain. So our food can make us depressed, and our brain can make us unusually using our health food. Thank you very much. The question will be after. Okay, thank you.
Thank you, Dr. Ali, for your presentation and informative talk. Actually, your talk is very interesting, and it has many information, need longer time, but we are limited with the scientific schedule. Moving to the second part of today, this session with Dr. Robin Tiger. Robin Tiger will talk about stress prevention and management. Dr. Tiger is outcome-oriented pioneer with a focus on reducing chronic stress and anxiety, overwhelming and imbalance. Powerful advocate with high emotional intelligence, catalyzing change and transforming life through connections, improve self-worth, enhance resilience, and also renewed sense of purpose. Please, Dr. Tiger will be joining us virtually, and she will deliver her talk through the online streamline.
Hi, I'm Dr. Robin Tiger. I'm a double board certified physician in diagnostic radiology and lifestyle medicine. And it's an honor to be presenting to you today on the topic of stress management for your 3rd annual Lifestyle Medicine Conference in Hail, Saudi Arabia. Let me share my screen and we'll get started. Okay, so my topic today is on stress prevention and relief. For disclosures, just a few. I serve as lead faculty and subject matter expert in stress management for the American College of Lifestyle Medicine Board Review Manual, which I co-authored. I have a stress management practice with CME, including programs, coaching, podcasts, and retreats. For this presentation, I'll define stress. We'll discuss the relationship of chronic stress and the other lifestyle medicine pillars, the symptoms and health effects associated with chronic stress, and what I call the bottom-up, top-down approach to stress relief. So, what is stress? There are 3 different types of stress. There's eustress, which is the good stress. That's motivating or inspiring situation type stress. Then there's eustress, which is neutral stress. That's any information that's perceived by you as inconsequential. You hear about something, but it's not really affecting you. And then there's distress, and that's what we consider to be the bad stress. It's often labeled just as stress. And it's a negative, threatening interpretation of an event. And that event may be real or imagined, something that your brain's just offering you, a thought. And it's the distress that is really what's dangerous. That's the chronic stress that we're concerned about, not the eustress or the new stress, but it's the distress, which causes dis-ease and disease in our bodies. And stressors alter the balance or homeostasis in the body. And there are many different types of stressors. There are psychological stressors, physiological stressors, social stressors, and bioecological stressors. And stress is an international health problem, and it's affecting strongly the healthcare profession. Job stress is the leading cause of adult stress. And so the problem lies twofold. At the level of the workplace, since we know that job stress is the leading cause of stress, among other stresses, and then the level of the human. And although we can't necessarily go and fix all the problems in the workplace, what we can do, what we have the power to do, is work at the level of the human. Working at the level of the human to prevent and relieve the stress. So the problem is the chronic stress, but the solution actually lies in lifestyle medicine. And so lifestyle medicine has 6 key pillars. We have healthful eating, a whole food plant-based eating pattern. We have physical activity, movement of the body, managing stress. We have forming and maintaining relationships, that's social connection. We have nourishing sleep, making sure you're getting enough quality sleep at night. And then avoiding risky substances, which I also like to include escapes, those things that you do to avoid the feelings and emotions that you don't want to have. And then we have the 7th unofficial pillar that my dear friend and colleague also presenting here, Dr. Melissa Sunderman, talks about, and that is nature, right? So we have 7 essentially pillars of lifestyle medicine. And I like to think of these pillars as really having this bidirectionality with respect to chronic stress, right? So chronic stress and nutrition, exercise, sleep, social connection, external substances, and nature really have this bidirectional pattern. They focus and direct each other back and forth. Stress affects the other pillars affect stress. And here's my puppy. And he looks pretty stressed, right? So this is what he looks like when I am leaving to present at a conference or going to work, right? And he's an example of stress and chronic stress. Here in this situation, we'll use my puppy. And the bidirectionality with nutrition. So when you're chronically stressed, you're not grabbing for healthy fruits and vegetables, right? You want to eat things high in added sugar and processed foods and chemicals and saturated fats, right? And then when you eat those foods, well, food creates mood and it makes you feel more stressed and anxious. When you're stressed, you're not sleeping properly. And when you don't sleep well, it makes you feel more anxious and stressed. When you are stressed, you're likely not exercising correctly. That could be not exercising enough or sometimes over-exercising. And when you don't exercise properly, that can make you feel stressed. When you feel stressed, you're not connecting with others. And the lack of social connection, isolation, loneliness causes more stress. When you're stressed, you're most likely not getting out in nature. And not getting out in nature causes you to feel more stressed. And when you're feeling stressed, you're more likely to reach for external substances, smoking, drinking, doing drugs, and I like to include escapes. And then when you're doing drugs and drinking and smoking and doing all those escapes, you are feeling more stressed, right? So we see this bidirectionality between chronic stress and the other pillars of lifestyle medicine. And I think of stress, chronic stress, really as being the umbrella under which these other pillars live: nutrition, exercise, sleep, social connection, nature, external substances, and escapes, unhealthy habits. They really live under this umbrella of chronic stress, as stress determines your behaviors with respect to these other pillars. How do you feel when you're stressed? Probably kind of like this individual looks, right? And even look at the cup. The cup is even stressed. We all know what that feels like. What are the symptoms of stress? Well, there are many: palpitations, dyspnea, sweating, irritability, tiredness, fatigue, loss of appetite, overeating, dizziness, nausea, headaches, excessive worry, tremors, unusual emotional feelings or mood swings, difficulty sleeping, night sweats, indigestion or diarrhea, irritable bowel syndrome, feeling unwell, unable to relax, low self-esteem, and depression. Right? And you may think, well, yeah, I can handle the symptoms. But what can't you handle? The health effects of stress. The health effects of stress are many: impaired immune system, increased inflammation, decreased bone density, problems with memory, increased appetite, weight gain, fat deposition in the abdomen, increased insulin resistance, increased blood sugar, cholesterol, triglycerides, blood clotting, impaired wound healing, poor sleep, increased sensation of pain, fatigue, worsening of mood, and adoption of those less healthy habits. And what else? Well, causes hypertension, diabetes, adult onset type 2, heart attacks, strokes, cancer progression and growth, dementia, and it shortens the lifespan because it prematurely shortens our telomeres, those protective ends of our chromosomes. So I like to divide categories of stress relief tools into 3 main categories, right? So what can we do to relieve our stress quickly, effectively, efficiently? And I divide them into breath, body, and mind. And we have 60,000 thoughts per day. Brain is full of thoughts, right? So full of thoughts. And so we spend our time being mindful. That's 2 words. Like the image on the left, the adult there has a brain full of so many thoughts versus the dog on the right, which actually is mindful. 1 word is seeing what's in front of the dog, the trees and the sun, right? And we want to move from mindful to mindful. And so I see stress relief, the tools, as being both top-down and bottom-up approach. But we start with the bottom-up approach. And that's because it's hard to work with your thoughts when you're dysregulated in your nervous system, right? So we want to first regulate our nervous system, our sympathetic nervous system, bring that into homeostasis, and then we can work with our thoughts. So, breath. We start with body-based tools and breath. And so when working with your breath, we want to focus on the physiology of breath, understanding that our inhale increases heart rate and our exhale decreases heart rate. So our exhale breath is the key to our relaxation response. So focusing on lengthening the exhale breath allows you to feel calmer. The second component of breath is the location of breath. Chest breathing is stressful breathing, that's sympathetic nervous system. Abdominal breathing is calming breathing, that's parasympathetic nervous system. So we want to direct our breath down deep into our bodies, into our abdomen, to increase vagal tone and to feel calmer. The second category of stress relief tools is body. What can we do with our bodies? And that has to do with movement. Moving in a way to relieve chronic tension and create freedom in your body. And so stretching doesn't work. You may have noticed this. You try and stretch all the time and it feels really good, but it's not long lasting. And why? Why doesn't it work? Well, you see all the rubber bands on this individual here. You can think of your muscles like rubber bands. And when you stretch a muscle, it is just spinal cord reflex. It sends a signal to your spinal cord, tells you the spinal cord that the muscle stretched, and the spinal cord sends a signal back to your muscle and says recontract. That's why I say sit up and I pull your shoulders back and I say relax. You're going to come to how you were before. And we can do that all day long, right? So stretching doesn't work. It just temporarily increases the muscle resting length, but it doesn't last. Somatic movement works. It's a different type of movement. And it is due to pandiculation, which is eccentric contraction. That's contracting into a tight muscle and slowly releasing it. That's the opposite of stretching. And interoception. Interoception is that first person sensation inside your body, really focusing on how your movements feel as you do the movements. 2 key components of movement, opposite of stretching. What about the mind? Well, there are 2 components in the mind for stress relief tools. We have meditation and we have life coaching. Meditation is amazing because meditation causes neuroplasticity. Neuroplasticity, which actually changes the shape of your brain for the better. Research shows that the cerebral cortex becomes thicker, and that improves your attention, your memory, and your processing of information, as well as decision-making. Neuroplasticity affects your amygdala. It decreases your amygdala. Decreases your amygdala. Your amygdala is like your smoke alarm in your brain, which means you'll have less anxiety, less of a stress response, and less negative thoughts. Neuroplasticity with meditation shows that your hippocampus thickens, and your hippocampus allows for emotional regulation, learning, perspective, and self-awareness. So meditation is amazing, creating neuroplasticity in these 3 key areas of your brain. Now, what about the top-down portion of stress relief? So far, everything has been body-based. So top-down means that we're working with our brain through life coaching. And life coaching is mind management. Mind management means that a life coach is a thought partner. It's actually a personal trainer for your brain, because your thoughts determine how you feel, how you act, and the results you create in your life. We know this from cognitive behavioral theory and therapy, and therefore your thoughts create your results. Your thoughts create your results. So after you've done all the body-based bottom-up tools to bring homeostasis to your sympathetic, parasympathetic nervous system, then you can work from the top down with your thoughts and do life coaching. Okay, so I hope that you were able to start building out your stress relief toolbox. I invite you to think about these different ways to relieve your stress, both your body-based tools as well as your mind-based tools, and start learning more of these tools to help you feel calmer, to improve your overall health and well-being, and those of who you support in your life, your family, your friends, your patients, your staff, your community. And move from feeling stressed to feeling relaxed as much as possible so you can increase your health span. That's how long you live healthy on this earth, as well as increasing your lifespan, how long you live on this earth, both increasing health span and lifespan by focusing on preventing and relieving the stress in your life. Thank you so much for having me. I greatly appreciate being here and presenting for your conference. Thank you.
Recording in progress.
Sorry. Moving to the third talk of our session, after we talk about stress and how to manage stress, moving to third talk about lifestyle and headache disorder. This talk will presented by Dr. Faisal Al-Swaidan. Dr. Al-Swaidan, a consultant of neurology, critical care medicine, neurological and neurosurgical critical care, master in e-health management, head of neurology division, security force hospital program MOH, and neurology clinical lead MOH. Please join me to welcome Dr. Faisal.
السلام عليكم ورحمة الله وبركاته، وأسعد الله صباحكم بكل خير. سعيد بوجودي معكم في هذا المؤتمر القيم وما شاء الله المتميز بالتنظيم والمحتوى العلمي للسنة الثانية على التوالي. كذلك سعيد بحضور المحاضرتين السابقة اللي تتكلم عن stress management. So I'll do this in English. So I'm delighted to have been invited for the second year to this great conference, and I'm also lucky to have two distinguished speakers talking about stress before my presentation, as they will make my presentation easier. I will be talking about lifestyle and headache disorder, and I would like to emphasize that headache by itself is not a single disease, rather than a symptom of many diseases. And if we look to patient presenting to our clinic or the emergency department complaining of headache, we have to know the roots of this painful disorder. What brought them to the emergency or to the clinic complaining of headache? This is a simple Before I forget, I have no conflict of interest in relation to this presentation. So this what can a patient come to you with? They will point to an area in the head, and they will tell you that it's painful, either with or without touching this area. And there are many things in the head. As you know, we have the sinuses, we have the mandibular the mandible jaw. We have the migraine. We have also the neck pain that comes from the cervical spine, and we have primary headaches that does not have any relation to the structure, such as tension type headache and migraine headache. And those are basically patients who has no structural problem in their head, but they present to you with headache. And just knowing or trying to distribute or categorize the headache distribution, you will be able to put those patients in a certain category, and then you will be able to establish a diagnosis and probably treat the underlying etiology. Let me start with a simple case, and I will use this scenario in Ramadan, which is very common in Islamic country. Somebody who's otherwise around the year doing well, and then when he starts fasting in the first week of Ramadan, he discontinued his fasting due to severe headache associated with nausea and vomiting. He had to go to the emergency department, and he was given IV medication because he was not able to take oral medication. The emergency department consultant called you, and he asked for an urgent appointment. He did the imaging of the brain, and there is no pathology or no structural disorder in the head. And the question comes now: how can you help him during the rest of Ramadan, and how can you prevent such thing in next year? Because we have something here specific. As you know, Islamic countries during Ramadan, they have changed the lifestyle. Their daily practice change. So they will be fasting during the daytime. They will have late prayers, Salat al-Taraweeh and al-Qiyam. And they will probably change their social habits. So they will be doing spending nights, socializing, and probably will change their exercise habits. And also they will probably have limited access to water because they're fasting. And when they break their fast, they're not getting enough of water because either missing last meal in Ramadan, which is suhoor, or probably not drinking enough. So this is I would say a micro example of lifestyle change during Ramadan in Islamic countries. And with this kind of changes, we expect some breakthrough headaches. It is well known that we have an impact from change in sleep, change in diet, and also our working hours, along with our genetics and predisposition and comorbidities, as well as the psychological factors that contribute to the headache disorder, specifically migraine attention type. So this I would say interaction between our genetic and comorbidities, along with our habits and psychological components, will lead to either worsening of our headache or probably even treating the headache. We can stop the headache and prevent it by adjusting the modifiable risk factors, such as our sleep or probably diet, or probably treating underlying psychological disorder, or preventing it if you can, along with controlling comorbidities that the patient may have. I would like to emphasize the biopsychosocial model of the management of migraine, and I believe it's one of the most successful non-pharmacological approaches to headache disorders, specifically migraine. How common is migraine? Migraine is probably the commonest type of headache, and probably it's not far away from epilepsy in neurology. It contributes to the disability adjustment life years by causing the patient or the affected personnel to be absent from work, or probably having limited activity and productivity at work. Even if the patient is a housewife, a mother, she will be affected, and her family will be affected with her headache. So we have to keep it in mind that headache disorder, even if it's very benign, is still carries an impact and a burden in the community and in the patients themselves. If we go and focus on the lifestyle, I have highlighted 4 components. So stress probably is one of the most important triggers for headache, specifically migraine. Hormonal changes, and that is very common in the childbearing age ladies. Also changes in weather, which is also common in extreme part of the planet, in northern area of the planet, where there's a long winter and long nights. And also sleep disorder, which is, I'm going to show you a study done in the Gulf region that shows how much is the impact of sleep disorder in our community. It's also an important factor contributing to the headache disorder. Let's start with depression and anxiety, which are probably related to the previous 2 talks before my presentation. And to be honest with you, I have found in my practice over the last probably 15 years in neurology that at least 1 out of 3 patients with headache, they have psychiatric symptoms, which is underdiagnosed or undertreated. They're either having depression, and with the depressive attack, they get headache, or probably they have an anxiety, and we see this in college students in high school during the exams. So they come with severe headaches to the emergency department, and their exam is normal, the CT brain and the MRI is normal, and we forget to treat the underlying anxiety. For depression, I have seen this in patients who are probably still in our community shy to go and seek attention from psychiatric clinic, and they have already clear symptoms of nightmares, withdrawal, social isolation, and some of them had death wishes as well. And they come to neurology clinic complaining of the secondary symptoms, which is chronic headache. Now, if we fail to recognize a headache, unfortunately, with time, it's going to turn to be a chronic headache. And it's going to be more frequent, more disabling, and more costly to manage because we failed to recognize and manage early on when it was less frequent and episodic. And that was, I would say, this is the best time to treat patients with headache, when it's early on in their life, by recognizing the risk factor and managing it properly before it turned to be chronic headache, or probably change to something else called medication overdose headache because of excessive access to over-the-counter analgesia. Our therapy, we have 2 classical way of treating headache. We have the acute abortive treatment, and we have the preventive treatment. And both of them are usually driven by pharmaceutical industry. However, nobody focuses about the alternative treatment, which is probably related to lifestyle medicine and change and habits as well, which is, as you know, more efficient, safer, and probably under-utilized. We'll go back to our case. So in a nutshell, this patient has something called fasting headache, which is a mimicry of migraine headache. And it's considered and classified as one of the disorder of homeostasis. And you have to keep in mind fasting headache is something also well recognized as first of Ramadan headache. So it happens usually the first week of Ramadan because of the change in eating habit and also sleeping time. There are other communities and religion who share the same disorder if they have any practice related to fasting. However, in our Islamic country, it was recognized with the first of Ramadan headache, and usually we try to educate patients about it. It's really related to delaying meals and skipping suhoor. So it's basically if you're late in your futur or breakfast meal, and you don't take the suhoor, which is the last meal before fasting, you are prone to have this headache disorder, which is very annoying and probably lead to nausea and vomiting as well. And it's related to the duration of fasting. So we expect this headache to be more frequent if Ramadan in summertime and less frequent if it's in winter time because of the daytime or the fasting time. There are also an association between hypoglycemia, and I have to focus on that. If we have somebody who's diabetic and his insulin or oral hypoglycemic medication is not adjusted for the fasting period, they're prone to have headache related to hypoglycemia. And also the third type of headache that can happen is dehydration headache. And this is something we see in athletics who are not taking enough water, or patients who are on dialysis, or probably they have diuresis post-alcohol consumption, or any form of diuresis, such as diuretics given and Lasix given for cardiac patients. They will have tension type like headache. And we have to be careful about that, because we need to make sure that we can differentiate dehydration headache from migraine headache, which is usually unilateral and is preceded by aura, while dehydration headache is not. And this is something you have to be careful about while taking history, and what was the preceding factor for that headache, or what are the changes the patient had done lately in his activities. Caffeine withdrawal. I'm sure somebody's gonna probably after this session will go and grab a cup of coffee. Keep an eye on the consumption of coffee you're taking every day, and this is very crucial also in Ramadan. And we have observed those who are frequently grabbing 1 or 2 cups of coffee in Ramadan, they get caffeine withdrawal headache in the first week as well, because they don't have access to coffee during fasting. And there are many symptoms of caffeine withdrawal, and specifically we have caffeine withdrawal headache. So we're not short of names. We are in neurology, we're able to figure out a name. We call it caffeine withdrawal headache. And again, we have to be very careful with this, not to be misled about other life-threatening headache disorder. And interestingly, as you know, caffeine itself is a treatment for migraine. So it's two-edged sword, that probably we will have headache if we don't, or if we have excess access to coffee and then suddenly stop drinking coffee, we'll have the headache disorder, which is caffeine withdrawal. And in fact, if you have migraine, a decent amount of coffee, which is acceptable as daily consumption, can be used as a treatment for migraine. Caffeine by itself is labeled as a potential cause of medication overuse headache, and overconsumption is dangerous not only for causing headache, but it causes other cardiovascular diseases as well. And here's the list, our menu. What does where does caffeine exist? Now, if you focus on the hidden areas, I would say that probably few people would know that energy drink is full of caffeine, and also chocolate as well. There are significant amount of caffeine there, and both of them. And you have to be very selective on what you take, and you have to keep in mind when to take those privileges or chocolate. I would say avoiding excess and measuring the amount, estimated amount of caffeine is very essential, especially for, I would say, our community where we have majority of young, active population, and probably you see everybody coming in the morning to work with a cup of coffee in his hand. So this is a study I told you about in the beginning, the sleep disturbance in the Gulf area during Ramadan. The red area has the worst sleep disturbance, and the green has the list, and you see Saudi Arabia in the middle. This is a study done in 2015. It's not new. However, it indicates what happens to the region during Ramadan, and the habits of gathering and celebrating this month with meeting families. And this happens more frequently before Eid as well. And you see what happens during Eid vacation. You get more patients coming complaining of fatigue or headache because they did not sleep in the night before Eid vacation. Diet, before we forget, is very important. Usually patients with migraine headache can't tell you exactly what provokes headache. So healthy diet is good for everything, and a bad diet is bad for everything. This is a fact. I would focus on certain component with evidence. Let me move to the next slide. Yes, the monosodium glutamate, which is something available in many items in either restaurants or home-made meals. And there is a lot of talk about this component. Is it a trigger for migraine or not? And this is a study. I'm going to present the evidence that yes, it is associated. You see, it is noticed that this is a study for migraine retention type headache. and they realized that there is an impact to chocolate, coffee, and food rich in monosodium glutamate with statistical power, along with instant noodles, which is also rich in this component, as well as soft drinks as well. So their statistical power, those are dairy products and food items that can provoke tension type headache. And this will probably answer many questions, because I would say there's, if you go to younger generation, adolescent specifically in our community, you will notice that there's instant noodles is probably a fixed item in their, if not daily, probably weekly meals. And this is to keep an eye on. We have to focus on our consumption of those processed salts and items, specifically at younger generation, which may help us controlling probably headache in the future when they grow up. Our final recommendation, we need to have regular scheduled meals. We need to make sure that we have good hydration along the day, along the year, and try to avoid caffeinated beverages if not necessarily, especially late in the evening. We need to make sure that we have consistent sleep schedule every night, every week, and we have to plan our day in Ramadan as well, not to have the first week of Ramadan headache. Relaxation training is very important and very simple, and we have to know our body, what is the need of our body and soul, by knowing when to take a break during working hours and also during the weekends as well. Cognitive behavioral therapy, including stress management and coping skills, it's not a secret. Over the last 15 years, I have referred many patients directly to the psychologist for those exercises to have them trained on cognitive behavioral therapy and stress management so they can practice that at home. And I have remarkable results. This is my individual experience, with a success rate of 100% recovery from headache. That was my last slide, and thank you very much. I wish I was with you in Hail. Probably next year I'll do, and thank you very much.
Thank you, Dr. Faisal, for your presentation. And now we'll move to the interactive session. Please join me, Dr. Ali, and Dr. Faisal, you will be joining us through virtual.
Sure, I'm with you.
Thank you all for listening and attending this interactive session. We have 3 talks today. 2 of them talk about stress. The third one talk about the lifestyle and headache. We have a couple questions. Due to limitation of time of our session, we will take the most common questions that will be directed to Dr. Ali. We have the first question. What top tips would you give us in order to control our emotion?
Yeah, actually, there was the last slide I didn't present it, but the most important part is the sleep. So sleep is very essential in controlling our emotion, because we said about when we are emotional and irritable, that means our neurotransmitter in the brain are not functioning well. And in order for neurotransmitter in the brain to be stabilized and go to homeostasis, we need to have good night's sleep, because good night's sleep is what stabilizes those hormones and those neurotransmitters. So important of sleep and diet are the most 2 important in stabilizing our emotion. The third one is to be in touch with therapists, psychologists, or psychiatrists to teach you how to train yourself how to control the emotion and where is the emotion coming from. So most of us, when we have irritable emotion, that means these emotions are coming from some feeling in our unconscious mind. And in order for us to control that, we need to have an expert to help us dig in that emotion and tell us where they are coming from.
Thank you, Doctor. As we know, we are in an era of obesity medication. And emotional eating or stress related to emotional eating, now it's increased, and it's the most common problem in our society, not in national level, even though in international level. What's the best strategy to control our emotional that lead to bad eating habit, and what's the role of a new innovation medicine in obesity management? We can see about Mounjaro, Ozempic, and other medication that control obesity.
So this is a question.
Yes. The question, what is the role of new medication related to obesity management?
I'm not expert in the medication for obesity. That I will leave it to the obesity doctor. But remember, we said stress will lower your dopamine. So we overcompensate by eating a lot. يعني الأكل العاطفي هو مجرد ردة فعل على الستريس الموجود عندنا. كل ما زاد الستريس كل ما زاد الايتنج هابت تبعنا بسبب الايموشنال ايتنج. فاول شيء انتم لاحظوا انه من خلال السنوات الماضيه there are a lot of increase in obesity and weight problem in the world, not only in Saudi but all over the world. There is increase in obesity بسبب الستريس، لانه قلنا انه الستريس هو اللي lower our dopamine, and in order for us to get that dopamine back we overeating and we use drugs and alcohol. So first we need to get rid of the stress, or the bad stress, as we said, not the regular stress, the bad stress. That's what make us eat a lot. So handling the stress is very important, besides using the obesity medication. So using the obesity medication is a part of the solution, but the other part has to be in dealing with the emotional part of obesity, which is related to the excessive stressful life we are dealing with.
Thank you, Dr. Ali. We understand that stress is the major problem that derives many diseases and many complications. That one of them is eating habit, and also from other bad habits that affect our physiology system. We have another question for Dr. Faisal, Sweden. Dr. Faisal, what is the cut-off limit of caffeine that in daily consumption to avoid any withdrawal effect that end up with headache or trigger the headache in general?
If you take more than 200 milligrams per day for 2 weeks and then suddenly interrupt it, you're going to have caffeine withdrawal headache. It depends actually on the concentration each privilege. So probably I would say if you take a cup of coffee with espresso, for instance, which is highly concentrated, double shot, is not like taking I would say decaffeinated coffee. So there is differences in the concentration, but the estimated cutoff is more than 200 milligrams per day. And you have to know the component of caffeine in each privilege. And I would say each privilege has this written in the external food facts. However, if you go to a coffee, you need to know how many grams they're using in each shot. It depends on the I would say barista who's doing the coffee for them.
I see. Is there any way to consume decaf coffee that avoiding reaching to the more than 200 milligrams of caffeine?
Yes.
It is a good strategy to prevent interruption of caffeine daily need and to avoid the headache?
Usually, yes. If you go to low caffeine containing privilege, I would say like going to green tea or other less containing privilege. If you're trying to shift from high containing caffeine privilege to lower containing caffeine privilege, I would say it's a good strategy to shift to decaffeinated coffee for some time, just not to change your habits. However, unfortunately, if you notice that if you drink decaffeinated coffee, which I did for some time, you will never have the same, I would say, feeling. So probably we'll go grab another cup of coffee with caffeine, unfortunately.
I see. Thank you, Dr. Faisal, and thank you, Dr. Ali, for
Thank you for having us.
Making this session is more interactive and informative. Thank you, the audience, for being here and listening our talk. Now we can come up with ending of the first session, moving to the second session. نشوفكم على خير. الله يعطيكم العافية.
شكرا كثير. السلام عليكم.
Thank you,
Thank you very much. Goodbye. مع السلامة.
Thank you, our speaker, for valuable lecture. Dr. Dr. Abdulaziz, could you please join us on the stage with your speaker for honoring? Dr. Ali, thank you so much. Dr. Robin and Dr. Faisal, thank you so much.
Yeah, thank you very much. Thank you. I wish I was with you.
Thanks so much.
Hopefully إن شاء الله next year بإذن الله عز وجل نتشرف بالتواجد معاكم. كل عام وانتم طيبين.
Thank you so much. Dr. Ahmed. Dr. Ahmed Al-Rashdan, could you join us to honoring Dr. Abdulaziz?
I would like to thank you, Dr. Abdulaziz, for coming and sharing with us.
Thank you so much, Dr. Abdulaziz. It's not the events of our life that shape us, but our belief as what those events mean. Welcome with me with Dr. Ahmed Rashdan for our session, next session. Dr. Ahmed. Dr. Ahmed Rashdan is a pediatric consultant, associated professor, College of Medicine, University of حائل medical director of urgent care department at حائل cluster. Welcome, Dr. Ahmed.
Assalamu alaikum. Sabah al-khair. Good morning, everybody. As we are going on, there is a lot of challenges that we are facing. And with the challenges coming the success story. Now we will speak, or we will highlight about one of the challenges that facing Ministry of Health. As you know, Kingdom is widespread country with around 2.5 billion square. And there is the largest network of facility, of hospital and PHC, which is exceeding more than 2,200. And it's very hard to have all the specialty and subspecialty in this hospital and PHC. But the Ministry of Health is committed that to give any patient his right of good care on the right time and right place from right people. So with these challenges came the idea of creating a virtual hospital, which called Sahha. Virtual hospital, or the Sahha, is the largest, one of the largest virtual hospital in the world. And it's the first virtual hospital in the Middle East. It's containing of around 30 specialty and more than 75 subspecialty. Around 20 doctors running the show in this hospital, 24 hours, 7 days a week. So with this challenge, there is a team, creative team behind this. Let me introduce, or I am honored to introduce one of the stakeholders in the ministry and creative for Sahha is Dr. Yahya Dhafar. Yahya Dhafar, he is a consultant, family medicine, and he is the general director of the Sahha Virtual Hospital in the ministry. Welcome, Dr. Dhafar.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. حياكم الله جميعا. شكرا جزيلا للجنة المنظمة واللجنة العلمية على إتاحة هذه الفرصة لي للتحدث أمامكم عن مستشفى صحة الافتراضي. وأيضا نسعد ونفخر كوننا من الرعاة لهذا المؤتمر الرائع. For our international speakers, you are most welcome here in Saudi Arabia. And we are in Ministry of Health for proud for your participation in our great conference. إن شاء الله تكون محاضرة خفيفة وبسيطة، وسأبسط الشرح فيها قدر المستطاع عن مستشفى صحة الافتراضي وعن أبرز الخدمات التي يقدمها هذا المستشفى، بحكم كونها محاضرة تعريفية أكثر من كونها محاضرة علمية. طبعا جاءت مشاركة مستشفى صحة الافتراضي في هذا المؤتمر الفريد من نوعه، حيث أن من أبرز أهداف مستشفى صحة الافتراضي تعزيز جودة ونمط الحياة للأفراد تحقيقاً لمستهدفات رؤية المملكة 2030. كيف نعزز ونزيد من جودة حياة مناسبة وملائمة لجميع أفراد المجتمع؟ بتسهيل وصولهم إلى الرعاية الصحية عن بعد، وحصولهم على أعلى معايير الجودة في الرعاية الطبية المقدمة لهم. أيضاً تعتبر مستشفى صحة الافتراضي رائدة في مجال الابتكار في الرعاية الصحية، حيث قمنا بتدشين الساند بوكس، وهو البيئة الحاضنة للأعمال والابتكارات الحديثة الطبية والتقنية على مستوى العالم، بالتعاون مع 20 جهة داخل المملكة العربية السعودية لتقييم الحلول التقنية المبتكرة من العلماء والباحثين، حيث يتم في المستشفى تقييمها، اعتمادها، ومن ثم طرحها وتدخل سوق العمل. سأبدأ حديثي بنبذة عن مستشفى صحة الافتراضي. مستشفى صحة الافتراضي يعتبر مستشفى متخصص موجود حالياً في مدينة الرياض، مرتبط بعدة مستشفيات تابعة لجميع التجمعات الصحية في المملكة العربية السعودية، عن طريق أحدث التقنيات العلمية المبتكرة في مجال الرعاية الصحية عن بعد. تقريباً بدأت الأعمال الرسمية لمستشفى صحة الافتراضي في شهر يونيو 2021، وكان التدشين الرسمي للمستشفى في شهر فبراير 2022، أي ما يقارب من عامين. يعتبر المستشفى الأكبر من نوعه على مستوى العالم والأول في الشرق الأوسط. سعيدين بأن حصلنا على الاعتماد الكندي من الفئة الماسية كأول مستشفى افتراضي على مستوى العالم. أيضاً حصلنا على عدة جوائز، آخرها كانت جائزة زمام الرقمية كأفضل حاضنة أعمال في مجال الابتكار في المنطقة العربية لعام 2023. رؤية مستشفى صحة الافتراضي بأن تكون نموذج عالمي لتقديم خدمات الرعاية الصحية عن بعد، وأيضاً رسالتنا تهدف إلى تقديم هذه الرعاية داخلياً وخارجياً ولله الحمد بأفضل التقنيات الحديثة، لنساهم في تطوير واستدامة مجال الرعاية الصحية. أبرز أهداف مستشفى صحة الافتراضي تمكين جميع الممارسين الصحيين، بل أفضلهم وأفضل الخبرات العلمية والقامات المتخصصة، باستخدام التقنيات الحديثة لتقديم أعلى معايير الرعاية الصحية، بتوفير جميع المتطلبات اللازمة لهم، تسهيل تقديمهم للخدمة، أيضاً تسهيل حصول المستفيدين على هذه الخدمة لتحقيق التميز المؤسسي في جميع القطاعات الصحية في المملكة العربية السعودية. هنا نتكلم عن أبرز قيم مستشفى صحة الافتراضي، والتي تكمن في الرعاية الصحية الافتراضية: تقييم التميز فيها، الابتكار، التعاون مع جميع القطاعات الصحية كما ذكرت، وأيضاً الاستدامة في هذه الرعاية. طيب، بشكل مبسط، كيف يتم تقديم الخدمات في مستشفى صحة الافتراضي؟ يوجد لدينا حالياً ما يقارب 20 تجمع صحي في المملكة، توجد فيها أكثر من 250 مستشفى تابعة لوزارة الصحة. جميع هذه المستشفيات فيها نقص في عدد من الاستشاريين المتخصصين في عدد من المجالات، وبالتالي يتم تقديم طلب الارتباط بمستشفى صحة الافتراضي عن طريق بعض الأمور النظامية والرسمية في الحوكمة. بعد ذلك يتم تقييم التخصص المطلوب في هذه المستشفيات، بعده يتم تقييم الدعم التقني لكيفية الارتباط، يتم توفير الاستشاريين المتخصصين في المجالات المطلوبة في هذه المستشفيات، وبعدها يتم الإطلاق الرسمي للخدمة. أبرز الخدمات الرئيسية المقدمة في مستشفى صحة الافتراضي تكمن في 6 مسارات رئيسية. المسار الأول مسار الرعاية الصحية الحرجة. المسار الثاني مسار العيادات الافتراضية المتخصصة. المسار الثالث مسار اللجان الطبية متعددة التخصصات. المسار الرابع مسار الخدمات الطبية الصحية المساندة. بعد ذلك الرعاية الصحية المنزلية، وأخيراً الاستشارات الطبية الفورية والعيادات الافتراضية. أبدأ بأول محور من محاور الرعاية الصحية الافتراضية، وهي الرعاية الصحية الحرجة. طبعا تندرج تحتها قسمين رئيسيين. القسم الأول الICU، العناية المركزة بجميع فروعها Adult Pediatric Neonatal ICU. أيضا الرعاية الصحية لمرضى الجلطات الدماغية. أيضا بشكل مبسط توجد تقريبا ما يقارب أكثر من 25 مستشفى في المملكة مرتبطة فيها أقسام العناية المركزة بمستشفى الصحة الافتراضي. يوجد لدينا تيمات مخصصة، كل تيمز يتكون من طبيب استشاري متخصص في العناية المركزة، وأيضا كثير منهم تخصصات دقيقة، بالإضافة إلى ممرض مع الشخص المسؤول عن التنفس الريسبيراتوريست. بعد ذلك يقومون بعمل راوند صباحي ومسائي في جميع المستشفيات اللي نحن مرتبطين فيها. يقوموا في طبعا روبوت، مثل روبوت أو جهاز موجود حاليا في أقسام العناية المركزة في هذه المستشفيات. صباحا يقوم الفريق الطبي الموجود في الأقسام الطبية في العناية المركزة في المستشفيات بتشغيل الجهاز، الارتباط وتجهيز الحالات مع الفريق التمريض في مستشفى صحة الافتراضي. بعد ذلك يبدأ الراوند على جميع المرضى. يتم في الراوند نقاش الحالات مع الفريق الطبي الموجود في المستشفى المستفيد من هذه الحالات مع الاستشاري المتخصص. تكون الحالة بشكل كامل تحت تصرف الطبيب الاستشاري، يعطي الخطة العلاجية، يعطي المانجمنت بلان كاملة. أيضا يتم بالتواصل فيها مع المريض، والحمد لله حققنا نجاحات كثيرة بالتواصل مع أهل المريض، أيضا طمأنتهم عن حالة مريضهم، وبالتالي يعني رضا المستفيدين زاد بشكل كبير جدا، حيث يقوم طبيب استشاري متخصص موجود في مدينة الرياض بتقديم استشارة لمدينة طرفية لا يوجد فيها استشاري. فالحمد لله كانت هذه سبب في طمأنتهم في كثير من الحالات. حققنا أرقام كثيرة في الرعاية الافتراضية للعناية الحرجة، حيث قللنا مدة المكوث في المستشفيات. كان الافريج لللينث اوف ستاي للبيشنت تقريبا من 8 إلى 10 أيام، نزل إلى 4 إلى 5 أيام. القسم الثاني هو قسم الجلطات الدماغية، قسم الستروك. أيضا يوجد لدينا تقريبا 45 مستشفى مرتبطين فيها لتقديم خدمات التطبيب السكتات الدماغية. الآن أي مريض تظهر عليه بعض أعراض الجلطات الدماغية يتجه مباشرة إلى الطوارئ. الطوارئ اللي نحن مرتبطين فيها في مستشفى الصحة الافتراضي يتم فيها تفعيل الكود ستروك. توجد نيرس موجودة على مدار الساعة 24 ساعة في مستشفى الصحة الافتراضي. بعد تفعيل الكود ستروك يتم التواصل مع الاستشاري، يتم تقييم الحالة بالجهاز الموجود في قسم الطوارئ، يتم فحص الحالة حتى يتم النظر إلى بؤبؤ العين للمريض. بعد ذلك يتم عمل الCT سكان إن دعت الحالة، ويتم إعطاء الخطة العلاجية كاملة خلال وقت قصير. الفترة الذهبية لإعطاء المذيب الجلطات الدماغية TBA يعتبر تقريبا 60 دقيقة، ولله الحمد في مستشفى الصحة الافتراضي وصلنا إلى رقم عالمي وهو 28 دقيقة من وقت دخول المريض إلى باب الطوارئ إلى وقت إعطائه المذيب الجلطات الدماغية. القسم الثاني وهو قسم العيادات الافتراضية المتخصصة، ويقوم فيها الطبيب الاستشاري المتخصص في عدد كبير جدا من التخصصات بالتواصل مع المريض عن طريق الطبيب المعالج في المستشفى المحيل عن طريق نظام إحالتي الموجود في وزارة الصحة. يقوم بالتواصل مع المريض، تقييم الحالة وإعطائه الخطة العلاجية as a shared clinic مع الطبيب المحيل في المستشفى. يوجد لدينا حاليا 29 تخصص رئيسي و73 تخصص فرعي في جميع مسارات الطب. المسار الثالث وهو مسار اللجان الطبية متعددة التخصصات. يوجد لدينا لجان متخصصة في القلب Cardiology Committee and Tumor Board. يقوم طبعا في الأسبوع الواحد يقوم فريق القلب بالاجتماع مرتين، مرة للأدلت كيسز ومرة للبيدياتريك كيسز. يقومون بنقاش الحالات الطبية المحولة من جميع التجمعات الصحية حتى يتم الحمد لله تقديم الخدمات ل4 دول حاليا خارج المملكة العربية السعودية. يقومون بتقديم الاستشارة الطبية لهذه الحالات ونقاش الخطة العلاجية لها بمختلف تخصصات القلب. قدمنا ما يقارب 516 حالة تم نقاشها في لجان القلب، وأيضا قدمت 19 عملية جراحية عن طريق اللايف ستريمينج. في لجان الأورام أيضا يتم نقاش الحالات المحولة من مراكز الأورام المتخصصة في جميع تجمعات المملكة، ويتم الرد وعمل تقرير طبي خاص بهذه الحالة خلال 24 ساعة فقط. المسار الثالث وهو مسار الخدمات الصحية المساندة، وتتمثل في خدمات الراديولوجي أو الأشعة، وأيضا خدمات EEG اللي هو كهربائية الدماغ. خدمات الأشعة بشكل مبسط نرتبط بجميع مستشفيات المملكة حاليا، نقوم بتسهيل كتابة التقارير للحالات الطبية الموجودة لديهم، حيث تفتقد كثير من المستشفيات استشاريين متخصصين في الراديولوجي لكتابة التقارير. نقوم بكتابة التقارير خلال 4 ساعات فقط للروتين كيسز، وتقريبا نصف ساعة إلى ساعة للإمرجنسي كيسز. المسار الخامس وهو مسار تقديم الرعاية الصحية المنزلية. أيضا يقوم فريق متخصص موجود في المستشفى يتكون من تمريض على الأغلب بالتواصل مع المرضى وهم في بيوتهم. نقوم حاليا بتقديم الرعاية الصحية لمرضى مستشفيات إرادة، مستشفيات الصحة النفسية، وأيضا لمرضى فشل القلب، وأيضا لمرضى الغسيل الكلوي. المسار الخامس لتقديم الخدمات في مستشفى الصحة الافتراضي يتمثل في الاستشارات الطبية الفورية، وتقدم عبر 3 منصات رئيسية، والأغلب ممكن جرب الخدمات هذه. خدمات استشارات طبية في 937 الخط الساخن لوزارة الصحة الهوت لاين، وخدمات الاستشارات الطبية الفورية في تطبيق صحتي، وأيضا خدمات الاستشارات الطبية في منصة إكس. الحمد لله كانت هذه الخدمات الملاذ الآمن لجميع المواطنين والمقيمين خلال جائحة كورونا. كان يوجد حظر تجول، جميع الناس متخوفين من الأعراض المصاحبة لكورونا، كان على طول يتصل على 937 يأخذ استشارة طبية فورية عاجلة. الطبيب الحمد لله يعطي التوجيه الطبي المناسب له، والأغلب تقريبا 70 إلى 80% من الحالات كانت توجيه طبي فقط وتثقيف، ولا داعي لزيارة المراكز أو المنشآت الصحية. لدينا ما يقارب 600 طبيب موجودين في جميع التجمعات الصحية يقومون بالرد على خدمات الاستشارات الطبية، وأيضا في نفس المستشفى يتواجد 70 طبيب يقومون بتجويد خدمات الاستشارات الطبية بسماع المكالمات إما لايف أو ريكوردد بتقييمها وفق معايير وزارة الصحة لتقديم الخدمات. أيضا الخط الآخر لتقديم الاستشارات الفورية وهو عبر منصة الاستشارات الفورية في تطبيق صحتي. الآن أي مواطن أو مقيم أو حتى زائر يستطيع الدخول إلى تطبيق صحتي، طلب استشارة فورية مع الطبيب، يقوم بتقييم الحالة إما صوتيا أو عن طريق الفيديو أو عن طريق الشاتنج، وأيضا يقوم بوصف أو إعطائه وصفة طبية عن طريق نظام وصفتي الموجود في وزارة الصحة. المسار الثالث وهو العيادات الافتراضية الموجودة حاليا في التجمعات الصحية، وأيضا قدمنا خلال هذه العيادات أكثر من 9 مليون موعد افتراضي. هذه أبرز الأرقام الموجودة في الاستشارات الطبية. كما ذكرت أكثر من 9 مليون موعد افتراضي في العيادات الافتراضية، أكثر من 29 مليون استشارة طبية قدمت من أكثر من 1000 ممارس صحي أو طبيب، بمعدل رضا تجاوز 98% ولله الحمد. وأيضا awaiting response time تقريبا وصلنا إلى 11 ثانية فقط للرد في الكول سنتر. من الخدمات الجديدة أيضا في مستشفى الصحة الافتراضي خدمات الانبيشنت كونسلتيشن، وأيضا نقدمها عن طريق استشاريين موجودين في المستشفى يقومون بالتواصل مع المرضى المنومين في المستشفيات المرتبطة معنا بجميع التخصصات الطبية المذكورة أمامكم. خدمات الرأي الطبي الثاني بالتعاون مع مجلس الضمان الصحي، نقوم باستقبال الحالات المختلف عليها، نقوم بتقديم رأي طبي محايد لهذه الحالات عن طريق الاختلافات مع شركات التأمين، نقوم بتقديم الاستشارة الطبية لهم في جميع التخصصات المذكورة. أهم الأرقام التي ذكرتها في جميع الخدمات المقدمة، مرتبطين حاليا ب 170 مستشفى في جميع قطاعات المملكة ب 29 تخصص رئيسي و73 تخصص فرعي. السعة السريرية لدينا 480,000 سنويا، أي ما يقارب سعة سريرية المستشفى 500 سرير. عدد اللجان التي تمت 515 لجنة لحالات القلب. أيضا كما ذكرت الوقت الذهبي لإعطاء مذيب الجلطات الدماغية 28 دقيقة من وقت دخول المريض إلى أقسام الطوارئ إلى وقت إعطائه المذيب الجلطات. أيضا كتبنا ما يقارب 171,000 تقرير طبي عن طريق الأشعة، وأيضا قدمنا هذه الخدمات في مواسم الحج وأيضا في مواسم الكوارث كما حصل في زلزال تركيا. قدمنا جميع الخدمات هذه افتراضيا. ختاما أشكر لكم حضوركم، وأشكر لكم يعني اهتمامكم وتركيزكم معي. هذه نبذة سريعة ومختصرة عن خدمات مستشفى الصحة الافتراضي وأبرز الخدمات اللي يقدمها. أتمنى أن لا أكون قد أطلت عليكم. أتمنى أيضا بتعاونكم أن نقدم رعاية صحية مبتكرة بإذن الله تعالى، نكون رائدين في مجال الرعاية الصحية على مستوى العالم. نسعد أيضا باستقبال أي استفسارات أو تساؤلات عن مستشفى الصحة الافتراضي في الجناح المقدم من المستشفى خلال الفترة المسائية. شكرا لكم.
Thank you very much, Dr. Yahya. Really, I have a great experience with Saha in my specialty over the last 3 years in contacting you for certain subspecialty which is not available in the region. Our next talk will be about one of the pathway that Dr. Yahya spoke to about it, which is the virtual health clinic. One of my colleagues, he said that my mom is hypertensive, and when she is getting the appointment, her blood pressure is controlled. But when she is that day getting appointment to the hospital, her blood pressure is shooting up. So he is asking me, what shall I do? I said, easy. Just request from your physician is to have either home visit or virtual hospital clinic. I just go through the health cluster. They are closing around more than 20,000 appointments virtually last March and April. So it's a huge number. They are utilizing this facility in our region. Our next speaker will be Dr. Ibrahim Baharith. Dr. Ibrahim Baharith, he's from the great expertise in the ministry. He's the Executive Director of Quality in Sahati Hospital, Virtual Hospital. He will speak in the next 20 minutes about the virtual clinic. Welcome, Dr. Ibrahim.
السلام عليكم. السلام عليكم ورحمة الله وبركاته. وأسعد الله صباحكم جميعا بكل خير. بداية أشكركم على إتاحة الفرصة لي للمشاركة في هذا المؤتمر الرائع الذي يضم نخبة من المتحدثين والخبراء المتميزين. ودعونا في هذا المؤتمر الرائع نحيي التمريض بمناسبة اليوم العالمي للتمريض، إيمانا بالأدوار الجليلة والأعمال التي يقومون بها هذه الشريحة في صحة الفرد والمجتمع. So good morning, colleagues and participants of the whole of the حائل International Conference of Lifestyle Medicine. I am delegated to join you virtually today to explore the cutting-edge topic that it is transforming the landscape of healthcare. I will talk today about the virtual healthcare. As Dr. Yahya mentioned in his previous presentation about the importance of virtual healthcare and the experience of the Saha Virtual Hospital, which is the largest virtual hospital globally and the first hospital in the Middle East and in North Africa. Today, I will guide you through a comprehensive exploration of virtual healthcare and lifestyle medicine. As you can see in my screen, we will cover the overview of lifestyle medicine to understand the principle and significance of lifestyle medicine in promoting health and well-being. And then I will talk about the virtual healthcare practices internationally and nationally in Saudi Arabia to see some of the applications of virtual technology to deliver healthcare services. Then I will move to the link virtual healthcare with lifestyle medicine, which is our topic today in the conference. And then what is the key area of lifestyle medicine that we will identify to see the aspects of lifestyle intervention that it is linked with or we can do it or implement it in virtual health. Finally, we will see the future direction and opportunity of the virtual healthcare. So lifestyle medicine, as defined by the American Board of Lifestyle Medicine, it's a branch. It is a branch of medicine which is evidence-based therapeutic approach to prevent and treat and reverse the lifestyle-related chronic disease. As you can see, the principle of lifestyle medicine, which is the core principle, I put it the fourth, that it is linked to the virtual, so the assessment or the comprehensive assessment, then the behavior change, which is central to lifestyle medicine, which is, I think, covered in the first session, the communication, which is the core also for the virtual healthcare, and finally the digital health. Lifestyle medicine, of course, use and implement digital technology like mobile apps and wearable device and telehealth to enhance patient engagement and support. And these tools, as Abdul yesterday mentioned, is the future of the medicine. I will not speak a lot of what is the difference between the confidential medicine and lifestyle medicine, but just in brief, this you can see in the table that we are always focused on the lifestyle medicine to active the patients and to put the patients as a partner of care, and this is what I think the virtual healthcare standardized as. So what is the importance of the lifestyle? The importance of lifestyle medicine is to risk reduction and for chronic disease, which is maintaining the healthy diet, engaging in regular physical activity, and avoiding tobacco and excessive alcohol consumption, and managing stress and getting sleep well, also the enhanced immune function, then improve mental health and well-being, and finally longevity and the quality of life. One of the virtual health clinic in Saha Virtual Hospital focus on mental health and the quality of life, and this is one of the, I think, behavior needed change in for our lives. Lifestyle medicine settings also I will cover it because we have to understand that lifestyle medicine can be implemented in a lot of settings, in primary care settings like cardiac center, oncology centers, and diet center, outpatient clinic, and it can be also the clinic practice and the group therapy session, which can be delivered through individual consultation or group therapy sessions, and it can be also virtually. Lastly, the telemedicine and virtual clinic, and here we have to understand that the medicine or lifestyle medicine can be delivered remotely through telemedicine platform to allow patients to access consultation, coaching, and education from anywhere. And to move to the virtual health practice, the Saudi Vision 2030 put one of the goal that to improve the quality of life and increase the life expectancy through giving access to all the patients, whatever is the region or place or the time, to access the specialized care and to get it 24 hours, as Dr. Ahmed said, and to enhance the access to medical care and improve patient outcomes. So here, just to give you a brief, what is the definitions of digital health and virtual health and telehealth and telemedicine? Some of the people, they are not aware of this. So digital health, the scope of it is just, it is the all aspect of healthcare technology and innovation, including electronic health records and remote patient monitoring, health-related mobile app. But the virtual health, it's cover the remote healthcare services delivered through digital platform, including consultation, monitoring, education, support without the need for in-person visit. The telehealth is also a wide range of healthcare services provided over distance, including consultation, monitoring, education, and telecommunication technology. Finally, the telemedicine, which focus on clinical healthcare services delivered remotely, including virtual or second opinion prescribing management and specialty referral. This is the history of telemedicine. It starts from long time, but the evaluation of the evaluation of the telemedicine starting from 19. Which they start the transfer of radiologic imaging by telephone. However, the COVID-19 pandemic in 2020 accelerated the adoption of telemedicine globally. The healthcare system tried to deliver care while minimizing in-person contact. This is the lesson from the COVID-19 pandemic, which is give us the advantage of behavioral change from the pandemic. So the telemedicine saw a surge during the pandemic with primary care appointment in the UK increasing from 19 or 15% to over 90 being conducted remotely. As Dr. Yahya mentioned, we reach more than 9 million in Saudi Arabia to get the care virtually. Patient-centered communication, saving healthcare professionals 2.3 hours per week, and this is one of the advantage of the virtual or telemedicine during the COVID-19. Remote monitoring, which is providing the COVID-19 patients, reduce burden on both patients and healthcare provider. Decentralizing diagnostic by shifting diagnostic to home or virtual setting can lead to faster and cheaper results, enable early disease directions. This is the showcase of virtual health tools that implemented here in Saudi Arabia. We implemented a lot of applications, but I choose these 5 applications, which is 937 Service Center, which launched in March 2017 before the pandemic, and a free direct line providing 24 hours, 7 days medical consultation to answer any inquiry related to any medical field. Also, Saha launched in December 2017, which is mobile health application designed to provide remote services such as teleconsultation. They stop it now, and we use Sahati application. Sahati application is mobile health application to update records and health states, receive medical services, and also for instant consultation and taking appointment from Saha. Wasfati, which is a website enable physicians and healthcare practitioners to electronically prescribe and allow patients to get the prescription at private and public pharmacies. Also, Ana is one of the applications that it is or website that it is provide services and channel for education for health professionals in both governmental and private sector. Sahati application, I will focus on Sahati application because it is the this is the platform that we use it for the virtual clinic. Sahati platform is a unified platform of Ministry of Health, which allowed user to access health information and obtain several health services provided by various health sector in Saudi Arabia. Sahati offered a lot of services, include take-a-step health, immediate consultation, booking and reviewing appointments, remote appointments, easy access to a lot of services like search of medication, digital health vault, and women health dependent service. Also a family healthy family life through the following services, like a doctor of each family, my doctor, which is one of the applications that Ministry of Health implemented this year, record of children vaccination, and a lot of services that you can find it in Sahati application, that you can download it for to get access for these services. Here we can just go through the statistics from the Ministry of Health in 2022. You can see the published information or statistics from different regions. We reach in 2022 that around 14,000 healthcare practitioners using virtual healthcare, and the appointment or the number of virtual appointment what's reached around 2 million or more. Then the number of beneficiaries around 1,100,000. This is the benefits of virtual health care. Virtual healthcare gives access healthcare from anywhere, increase convenience, improve continuity of care, and better outcomes, reduce healthcare costs, and reduce risk of explosion. The innovation in healthcare and virtual healthcare, as you know, the rapidly transformation of the healthcare landscape, improving patient outcomes, enhancing access to care, and optimizing healthcare delivery. You can see on the screen some of the technologies that shape the future of healthcare and virtual healthcare, using the remote patient monitoring, the RBM involves the use of wearable devices and digital sensor to collect real-time health data from patients in their home. And this is implemented in some virtual clinic and also in Saha Virtual Hospital. Artificial intelligence, the AI and machine learning, this is the revolutions of healthcare by using the AI and analyzing the vast amount of patient data to improve the diagnostic, personalize the treatment plan, and predict the outcomes. The telemedicine platform and mobile apps, this is the advanced telemedicine platforms and mobile apps like Sahati enable secure video consultation, virtual visit, and remote care delivery. Finally, the PR and AR. The PR and AR technology are being used for medical training, patient education, and therapeutic intervention. This is the simulation allow healthcare professionals to practice surgical procedures in virtual environment. This is research give us a drive values across 5 key areas of virtual care. So the virtual care can enhance care coordination by about 1 in 2 physicians see improved care coordinations and quality of life through virtual care. The virtual care can improve clinical outcomes by 74% adherence rate on average for heart failure medication through a home-based telemonitoring, enhancing patient and consumer experience. 2 in 3 health plans think virtual health has improved the overall member satisfaction, improved efficacy. Patients save about 2 hours on average per virtual visit compared to physical visit, and expand the consumer and clinical access by more than 50% of the health plan's member encounters are virtual. So to link the virtual healthcare with lifestyle medicine, I will go through it quickly to save time. So the way virtual healthcare can integrate it with lifestyle medicine principle, virtual healthcare can be giving remote lifestyle assessment for comprehensive assessment through the detailed lifestyle assessment to go through the traditional method history. Patients can complete digital questionnaires or covering all the information like diet, physical activity, sleep patterns, and stress level, tobacco use, everything. Consultation for lifestyle consuming. And here, lifestyle medicine practitioners or physicians can conduct telehealth consultation to provide personalized lifestyle consuming and behavior change intervention. Remote monitoring of health metrics, and this is virtual healthcare enable remote monitoring of key health metrics related to lifestyle factor using wearable devices and mobile health app. Virtual group sessions and group committee. Virtual platform can host group sessions and support community focus on lifestyle medicine principle, and this is what Saha Virtual Hospital implemented in this year, which is المرشد الافتراضي, to just give a lot of information for patients who is at risk. Integration with digital health tools and apps. Lifestyle medicine can use the digital health tools and mobile apps to enhance patient engagement and adherence to lifestyle recommendation. Behavior change intervention using virtual reality or VR. Here, virtual or VR technology can be employed in lifestyle medicine intervention to stimulate real-life scenarios and facilitating behavior change. For example, the using of VR environments can simulate the SCORE visit to teach health habits or create impressive experience.
Dr. Ibrahim, please, 2 minutes remaining.
I will go through it. Thank
you.
The empowering self-management and patient education, remote wellness and coaching, and follow-up with patients. The key area of lifestyle medicine, the foundation of lifestyle medicine, explore key area of health and well-being like nutrition, consultation and education, physical activity promotion and exercise prescribing through virtual, stress reduction and practice, sleep hygiene and behavior sleep medicine, tobacco use management and chronic disease prevention and management, and also behavior change intervention and health coaching, and finally community engagement and peer support. What's the future direction of the virtual clinic? There is two, here you can see there is two study that by 2040, a major variation of care prevention and well-being services will be shifted to virtual setting. So healthcare delivery and health management will look significantly different by 2040, according to the participants whose executives in a lot of countries said that they are interviewed them, and they said half of them said at least a quarter of all patients' care, preventive care, and long-term care and well-being services would move to virtual delivery over the next two declines, and even some inpatient care which now take place in physical, they will move to virtual care. Also, the another research by 2030, they said the industries-wide investment in virtual health will increase significantly to reach the 74%. This is also the future direction of opportunity, identify emerging technology and trend shaping virtual healthcare and lifestyle medicine, analyze the potential impact of artificial intelligent telemedicine, wearable devices in the healthcare delivery of lifestyle medicine, and explore the lore of virtual reality, VR and AR and immersive technology to enhance patient engagement and behavior change. Thank you very much. شكرا لكم جميعا واعتذر على الإطالة. شكرا.
Thank you very much, Dr. Ibrahim, for your comprehensive lecture about virtual clinic. Just a reminder to the view that we have the QR for the questioning and evaluation. The next speaker will be Dr. Jihan Al-Hazmi. We heard about in the lifestyle a healthy food and a healthy restaurant and the healthy places. But lately we are starting to hear about healthy cities. So, and now is growing all over the world and even in the kingdom. So Dr. Jihan, she is a consultant OB-GYN, and she is the assistant of Vice President of Medina Cluster for Planning. She will speak about how we accredited cities to be healthy city in the kingdom. They got their WHO accreditation of Medina and other city in the kingdom. So she will give us in the next 20 minutes overview how the city will be a healthy cities. Welcome, Dr. Jihan.
بسم الله الرحمن الرحيم والصلاة والسلام على سيد المرسلين سيدنا محمد وعلى آله وصحبه وسلم. I would like to thank the organizing and scientific committee to invited me today to حائل, which is beautiful city and hospitable people in حائل. Today I'll talk about healthy city, but the conference is the core of my talk today about how to change our lifestyle, how to innovate in our health. Unfortunately, they asked me to speak in Arabic because حائل now under processing for accreditation, and there is a sectors outside the Ministry of Health, and they cannot understand me if I speak English, so I'll speak in Arabic. My slides may be busy slides because I put it bilingual, so you can read it English and I'll speak in Arabic. Thank you so much. So I'm consultant OB-GYN. I am one of the committee member of Healthy City in Medina. I'll talk about definition of healthy city, history of healthy city, and accreditation cities in Medina and Saudi Arabia, and the standard of healthy city in Saudi Arabia. بتكلم إنجليزي برضه. طيب ليه بنقول المدن الصحية؟ المدن الصحية هي المدن اللي بتاخذ بالها من الصحة للناس على الكوكب، إنها تشجع مشاركة جميع المجتمعات إلى السعي وتحقيق السلام والازدهار. تعمل على كل الأشياء اللي ممكن تأثر على الفرد من عدم المساواة، تعزيز القيادة العادلة من أجل الصحة والرفاه وتقييم الابتكار وتبادل المعرفة الدبلوماسية. المدن الصحية تعريفها مو معناها إنه المدينة اللي والله عملت شيء معين في الصحة، ولكن هي المدن اللي عندها الإدراك وعندها الحس إنها تغير للأحسن، حتى ممكن في اعتراف للمدن الصحية بغض النظر عن مستواها الصحي، ما دام هي عندها الإدراك وعندها الخطة وعندها الانفراستراكشر إنها هي تقدر تشتغل على نفسها وتحسن الصحة بالنسبة للمجتمع كامل. يعني هي ما بتتكلم عن زيادة سرور أو زيادة أو فتح مستشفيات أو فتح مراكز صحية، هي بتتكلم عن تغيير كامل للمجتمع ومشاركة المجتمع وتغيير في اللايف ستايل، وإنه الفرد يكون مسؤول عن نفسه، وإنه الفرد يشارك في أخذ يعني تحسين صحته، وإنه جميع الإدارات سواء في الصحة أو خارج الصحة تكون مشتركة، سواء تعليم، سواء تطوع، سواء مياه والمويه والامانه، التعليم، كل شيء موجود في جميع القطاعات الموجوده في البلد. طيب زي ما احنا قلنا ان هي المدن الصحيه هي تعمل باستمرار على خلق خطط لتحسين البيئه البدنيه والماديه والاجتماعيه وتوسيع الموارد الاجتماعيه وعشان تمكن الافراد من دعم بعضهم لبعض. بتتكلم عن الناس وبتتكلم عن الكوكب، بتتكلم عن الاماكن، وبتتكلم برضو عن الامان. بالنسبه للناس زي ما قلنا انه احنا بنستثمر هنا في الناس، في استثمار في راس المال البشري، واعطاء الاولويه للاستثمار في راس المال البشري والاجتماعي كنشء استراتيجي للتنميه الحضريه، تعزيز الادماج وعدم التميز والثقه والمرونه. بالنسبه انه جميع افراد المجتمع يشتركوا في وضع قراراتهم على المجتمع في المكان اللي هم عايشين فيه، كيف يعيشوا، كيف يحسنوا خططهم بالنسبه للمعيشه، بالنسبه للصحه، كيف انهم يقدروا يخططوا لمدنهم، ايش رايهم. فلازم يكونوا مشتركين في جميع الخطط. بالنسبه للكوكب، يعني طبعا احنا عارفين ايش هو الكوكب، يعني انه احنا المكان اللي بنعيش فيه المكان اللي بنعيش فيه كيف احنا نقدر نصممه بطريقه حضاريه، كيف نقدر نزيد المساحات الخضراء، كيف نقدر نخلي المكان امن، كيف نقدر نخلي الناس تستفيد من الاماكن وتخطيط المدن. بعدين الاماكن طبعا احنا فيها المدينه الصحيه بيئه اجتماعيه، ان نرجعها لها بيئه اجتماعيه وجسمانيه وثقافيه يسهل الوصول فيها للخدمات، وقائم على انها النهج مو قائم على الاحتياج قد ما هو قائم على التنميه والتخطيط، ومتحور حول الانسان ودمج الانصاف والاستدامه في مجال الصحه والتنميه. بالنسبه للامان طبعا انه هي المدن الصحيه لازم تكون هي المدن الاكثر امانا في جميع اعمالها، وانه هذا الموضوع لازم يكون موجود في سياساتها الداخليه والخارجيه. طبعا ال WHO متى بدأت، أو هيئة ال WHO بدأت إنها تبدأ تتكلم عن المدن الصحية في تقريبا في سنة 1986، لما لقوا إنه في كثير مشاكل صحية بسبب التحضر، وعشان يحاولوا يحطوا إنه المدن الصحة والمدن الصحية في أجندة أصحاب القرار السياسيين في كل بلد. بدأوا إنهم هم بدأوا عملوا سكيل صغير في أوروبا، تقريبا في 45 بلد في أوروبا. بدأوا حطوا خطط خلال 5 سنين إن هذه الخطط تعمل على أساس إنها هي يغيروا إنهم يبدأوا يغيروا على إنها تأثر على التعلم والتكيف والتغيير، تهدف إلى رؤية المدينة الصحية من خلال الجمع بين القيادة السياسية والرؤية الصحية والتغيير المؤسسي والعمل المبتكر. عملوا بروفايل معين على اساس انه هم كيف يقدروا كل مدينه صحيه كيف تقدر تحط مؤشراتها والمؤشرات الصحيه وتشتغل عليها. فبداوا يشوفوا ايش المؤشرات وكيف يشتغلوا عليها ويدوها لكل مدينه انها كيف تقدر تساعدها في انها تغير الخطه الصحيه بالنسبه لها. طبعا الفكره بدات في اوروبا، لكن بعد كده بدات انها تصير فكره عامه وكبيره، فعشان كده بدات تمتد الى كندا وامريكا واليابان ونيوزيلندا. بدات الفكره المدن الصحيه تروح تكبر، وبعدين اوروبا بعد ما كانوا 40 مدينه صاروا 90 مدينه، وكانوا 30 نتورك، ودخلوا فيها تقريبا 1400 مدينه صغيره وكبيره للمدن الصحيه. طيب بالنسبه في السعوديه البرنامج بدا 1998، بس للاسف احنا كلنا ما سمعنا عنه، كان في وزاره الصحه ما سمعنا عنه. بدا بعد كده يطلع، بداوا اول مدينتين اعترفوا بهم البكيريه والمندق، مدن صغيره. بعد كده على 2015 بداوا ال WHO حطوا ستاندرد معين للاكريديتيشن، تقريبا 80 ستاندر او ممارسه. وكان بدأ برنامج المدن الصحية في المملكة، كان يهدف إلى تحسين الوضع الصحي لسكان المدن والمناطق التي تتطلب مزيد من الاحتياجات الأساسية. إعطاء الأولوية لتطوير الخدمات الصحية والبيئية والاجتماعية في المدن. برضو حطوا التركيز على نشر ثقافة حول القضايا الصحية والبيئية، استقطاب ودعم ومشاركة المجتمع في معالجة مشاكله وإعداد الأنشطة والمشروعات، دعم وتعزيز قدرات المحافظات والإمارات في التصدي للمشاكل الصحية والبيئية. حطوا تقريبا 6 مقومات للبرنامج. أولها كانت وجود التزام تجاه قضايا الصحة والبيئة، وعلى أساس أنه مشاركة أفراد المجتمع كله في تعزيز الممارسات في أنماط الحياة والاستفادة من الخدمات الصحية المتوفرة، وإبداء الرأي، لأنه إحنا بنديهم الخدمات الصحية من ناحيتنا، بس إحنا ما نعرف هل هم راضين عن الخدمة أو لا، أو إيش عندهم أفكار جديدة ممكن تساعدنا في صناعة القرار والتخطيط. كان الهدف الثاني عندهم تشجيع صانعي القرار والسياسيين دعم البرامج المتعلقة بالصحة والبيئة. إحنا عندنا كثير برامج متعلقة بالصحة والبيئة، في بعضها ماشي في بعضها مو ماشي، فالبرنامج هذا عمل على دعم هذه البرامج عشان نقدر في النهاية نصير مدينة صحية. إيجاد خطة عمل بين مختلف القطاعات، زي ما إحنا قلنا إنه هي مش القطاع الصحي بس، هي تحت كل القطاعات اللي موجودة في المدينة لازم تشترك، ولازم يكون لها إنبوت في الموضوع عشان نقدر في النهاية يعترف بنا كمدينة صحية. برضو الاهتمام بمشاركة المجتمع، وهذا بيرجعوا يعيدوه إنه الاهتمام والempowerment of the population. التجديد والابتكار، يعني معناها انه نفس المجتمع لما يجي يشترك معنا في عندهم افكار جديده وفي عندهم افكار مبتكره، عندهم مشروعات ممكن تحسن البيئه الصحيه في المدينه وتدعم الفرد. فعشان كده هذا واحده من المقومات حقت المدن الصحيه، التجديد والابتكار. وإيجاد الأماكن الصحية في مختلف أنحاء المدينة، يعني زي الممشى، زي الأماكن الخضراء، زي الجناين، زي كده، اللي تكون هي صحية وآمنة لنفس المجتمع ونفس الأطفال، وتقدر الناس تروح وهي ما هي خايفة. طبعا البرنامج ماشي مع أهداف التنمية المستدامة اللي هو رقم 3 ورقم 11، اللي هو ضمان تمتع الجميع بأنماط عيش صحية وبالرفاهية في جميع الأعمار، وجعل المدن والمستوطنات البشرية شاملة للجميع وآمنة وقادرة على الصمود والاستدامة. ماشية مع رؤية 2030 اللي هو مجتمع حيوي واقتصاد مزدهر ووطن طموح. ماشي مع تمكين حياة عامرة وصحية، إن إحنا نعزز الأنشطة الرياضية وتحقيق التميز في عدة رياضات إقليميا وعالميا. برضو في الرؤية نفسها الارتقاء بجودة الحياة في المدن السعودية، الارتقاء بجودة الخدمات المقدمة في المدن، تحسين المشهد الحضري، تعزيز حصانة المجتمع تجاه المخدرات. برضو ماشي مع الرؤية في ضمان الاستدامة البيئية من الحد من التلوث والأخطار الطبيعية وحماية وبيئة المناطق الطبيعية، وضمان الاستدامة البيئية نفسها، حماية الموارد الحيوية للدولة، ضمان تحقيق الأمن التنموي والغذائي. فكلها ماشية مع الستاندر حق رؤية 2030. بعدين رفع مستوى تحمل المواطن المسؤولية اللي هي تفعيل العمل التطوعي. عشان كده بنقول إحنا المواطن لازم يكون له إنبوت في الموضوع على أساس هو يقدر يدينا رأيه ويقدر يجتمع معنا. طيب، ونفس الشيء بالنسبة ماشية مع أهداف التنمية العاشرة للبلد اللي هي جودة الحياة وقدرات الشباب، الأمن الاجتماعي بالنسبة لكبار السن والحوامل والأطفال، التكامل الاقتصادي. بعد 2018 بدأت بعد ما حطوا الستاندر أول مدينة اعترفوا بها اللي هي الدرعية وجلاجل، وبعد كده دحين احنا عندنا 15 مدينة في المملكة الحمد لله معترف بها. المعلن 11 مدينة اللي هم تقريبا الدرعية والمندق وجلاجل والجموم وعنيزة والمدينة والطائف، جدة، تبوك وشرورة والرياض الخبراء. احنا في برنامج المدينة المنورة كان عندنا شركاء، عشان اوريكم الشركاء كثير، كان في وزارة الصحة، وزارة النقل، وزارة التعليم، الحج، الدفاع المدني، الشرطة، الهيئة العامة للرياضة، اللي هي الجامعة، الهلال الأحمر، الأشياء يعني كل السيكتور سواء عام ولا خاص مشترك معانا كانت حطوا لنا هم 80 معيار، بس احنا في المدينه المنوره زودناها خلينا 97 لانه كان في عندنا مشاريع نبغى نسويها للمدينه، فدفيناها شويه مع المدن الصحيه عشان نقدر نحققها، وكل معيار تحته ممارسات. عملنا فرق معينه من الصحه، التعليم، البلديه، الامن، المتطوعين، وبعد كده عملنا الفريق حقنا في المدينه برئاسه مدير الشؤون الصحيه. درسنا المعايير اللي ادونا هي، وبدينا نشوف ايش المعايير اللي هي خاصه بينا، ايش المعايير المشتركه مع الادارات الثانيه، ايش المعايير اللي ما هي لينا خالص وشلناها. بعدين بدانا نعمل، طبعا هم اعترفوا بحيين في المدينه الخالديه والازهري، واحد كان يعني مستوى التعليم فيه قليل، وفي واحد كان مستوى التعليم فيه عالي. فهنا الاجتماعات، فطبعا كمدن صحيه لازم يكون عندك توثيق لكل شيء. هذه الاجتماعات مع الاجتماع حقتنا اولا، وبعدين في الاحياء اللي كنا بنشتغل فيها بدانا نقعد مع المتطوعين في كل الاحياء ونشوف ايش افكارهم، بدانا ننفذها، وبداوا كل الحيين يبغوا يتباروا على اساس مين يعمل احسن مشاريع. طبعا احنا عارفين احنا عندنا في المدينه الحج والعمره، هو طبعا المدن الصحيه ما يهمها انك انت تقوم على مؤشرات اللي بتديك يا وزاره الصحه، هي تبغاك تشوف انت في المدينه حقتك انت ايش سويت عشان تحمي نفسك. فاحنا بالنسبه للحج كنا في كثير فرق صحيه بتكون موجوده في المطار تطعم الحجاج، وتشوف اذا اي حاج شكوا فيه ياخذوه يحطوه في الايزوليشن عشان ما يعدي باقي الناس. طبعا احنا عندنا الشيء اليونيك عندنا في المدينه تفويج الحجاج، هذول الحجاج اللي بيكونوا تعبانين وبيكونوا لين يوم 7 و8 موجودين في المستشفى وما بيقدروا يكملوا الحج، فبناخذهم وبنطلعهم مكة. بيكون في إسعافات تقريبا 30-40 إسعاف على حسب العدد، وكل إسعاف مجهز وكل إسعاف مع فريق طبي جاهز إنهم ينقلوهم، وبنوديهم على منى يوم 7 و8 طبعا بالتعاون مع الهلال الأحمر وأمن الطرق والمرور. طبعا هذه الاجتماعات وهذه الصور من المبادرات اللي في كل حي اللي هم الناس اصلا قالوها او الناس يعني حبوا ان هي تكون عندهم في مجتمع الازهري والخالديه. بعد كده هذه كلها مبادرات. طبعا اللوجو هم اهم شيء عندهم في المدن الصحيه، اللوجو لازم يشوفوه في المطار، زي ما امس لما نزلت لقيت اللوجو حق المؤتمر في المطار، يبغوا يشوفوا اللوجو في المطار، يبغوا يشوفوه على المراكز الصحيه، المستشفيات، المدارس، على السيارات الاسعاف، على اي سيارات موجوده يبغوا يشوفوا اللوجو، عشان الناس لما تشوف اللوجو حتسال ايش هي المدن الصحيه، فنبدا نوعيهم، فهذا شيء مهم. هنا احنا عملنا كورس CPR او اسعافات اوليه في الحيين لطلبه وطالبات الثانويه العامه. وطبعا هنا المدينه المنوره الحمد لله اعترفت بها WHO ك هيلث سيتي، وكان الاعتراف مبني على اشياء كثيره، منها نحن عندنا 22 governance وشيرتي ايجنسي، ونحن عملنا الكترونيك بلاتفورم، وكان في عندنا بارتنرشيب مع طيبه يونيفرسيتي. هذه الشهاده اللي اخذناها، ودحين احنا في مرحله الري اكريديتيشن، وهذه آخر أكريديتيشن في تبوك، وإن شاء الله الفال لحائل بإذن الله. شكراً.
Thank you very much, Dr. Jihan, to share with us your steps in accrediting Al-Madina as a healthy hospital, and hopefully Hail will be the next city, inshallah, in the future. I call all the speakers on the stage to take a few questions with the limitation of time as available time. Please, Dr. Jihan and Dr. Ibrahim will be with us hopefully virtually. Have a seat, please. Dr. Yahya, it's coming to my mind and all the audience, the point of transformation in Ministry of Health and changing to privatization. What will be the future of virtual hospital with the transformation and privatization in the future?
ممتاز، يعطيك العافية دكتور، وحياكم الله جميعا مرة أخرى. بخصوص التحول الصحي في وزارة الصحة وفي القطاع الصحي بشكل عام، حاليا مستشفى الصحة الافتراضي طبعا هي تعتبر من أحد مبادرات نموذج تحول الرعاية الصحية وتحقيق رؤية المملكة 2030. حاليا توجد بعض الشركات الاستراتيجية المتخصصة لدراسة وضع المستشفى في الفترة القادمة، حيث كما تعلم وتعلمون جميعا أن وزارة الصحة ستعتبر مشرعة ومنظمة ومشرفة على جميع التجمعات الصحية خلال الفترة القادمة، لكن المستشفى الآن تقدم خدمات بشكل مباشر، وبالتالي سيكون في الفترة القادمة إن شاء الله توجه حيث أي المكان المناسب لوضع مستشفى الصحة الافتراضي بإذن الله.
I don't know whether Dr. Ibrahim with us virtually or not. Okay.
Yes, I am
with us, Dr. Ibrahim.
My voice is clear?
Yeah. Well, they throw a question is the virtual health clinic is available for the private sector?
For now, I think the perfect answer will be from Dr. Yahya, as he's the General Director of the consultation in Ministry of Health. However, I think the Sahati now, it is run by the Ministry of Health, which is the governmental body. I think the private sector, they have their own applications, they have their own platforms, they have their own way to reach their patients virtually. Depend of course, the regulation of Ministry of Health. If they have the licenses, they can do it by their own.
Thank you very much.
ممكن أعقب على نقطة دكتور إبراهيم. حاليا الخدمات المقدمة مستشفى الصحة الافتراضي تعتبر مقدمة للقطاع الحكومي وخاصة مستشفيات وزارة الصحة. في دراسة الآن قائمة في المستشفى لتقديم هذه الخدمات لمستشفيات القطاع العسكري ومستشفيات الحرس الوطني، وأيضا وردت بعض الطلبات من المستشفيات الخاصة في الموجودة في مدينة الرياض. نعمل حاليا على السياسات والإجراءات وحوكمة تقديم هذه الخدمات بالتعاون مع القطاعات المختلفة بإذن الله.
Thank you very much. Now, the other question is to Dr. Jehan. Do they need 100% that you have to have all the standard, the 90, or it's a percentage to be accredited as healthy healthy cities?
I think 80-85%.
Huh?
80-85% from 80. all the initiatives.
Very good. Very good. I would like to thank all the speakers, and if we don't have the chance to take your question, you can meet the speaker after that and ask them whatever you like. Thank you very much all.
Thank you. Shukran.
Thank you. Now just wait, Dr. Jehan, please. Just reward it.
Thank you, our speaker. Thank you, our moderator. Now it's honoring time.
Dr. Jehan. Thank you very much, Dr. Jehan, for participating with us. Thank you. Dr. Yahya. Please, Dr. Yahya. Thank you very much for your effort.
Thank you so much, Dr. Yahya.
Thank you.
Thank you, Dr. Ibrahim, if you are hearing us. Thanks so much for your lecture.
Thank you very much.
Thank you very much for all of you. Thank you.
Now, Dr. Badr al-Shomer will honor Dr. Ahmed al-Rashdan, our great moderator. Thank you so much, Dr.
Thank you.
Now, our fourth session for today will be moderated by our third session will be moderated by Dr. Badr al-Shomer, Assistant Professor at the College of Health University at University of Haiel. Welcome, Dr. Badr.
خليك كذا الماء. السلام عليكم. سعيدين أن نكون معكم في هذا اليوم الثاني من اللقاء العلمي أو البرنامج العلمي لمؤتمر طب نمط الحياة. Our speaker today is virtual, is Dr. Vanita Simth. She's a certified lifestyle medicine professional and a certified from International Board of Lifestyle Medicine, and she has a diploma from American College of Lifestyle Medicine and a chief coach and certified from Harvard Medical School. Also, she is certified as a plant-based nutrition specialist, and she's also instructor at Canadian Lifestyle Institute, Ontario, Canada. And Dr. Vanita speaks many times on different events about the invitation on topic related to prevention and management of chronic diseases. She believes in science and support evidence-based methods for treatment and reversal of chronic diseases. Dr. Vanita will talk about the nutrition for prevention from non-communicable diseases. So, Dr. Vanita, are you with us?
Yes.
Okay.
Namaskar.
So you have 20 minutes for your presentation. Thank you so much.
Yes. Namaskar. I have already been introduced, and I'm delighted to be here, invited here to present on the topic of nutrition for preventing non-communicable diseases. And here are my objectives for this presentation. Let's begin with taking a look at the global prevalence of non-communicable diseases, or NCDs as we call them, and diet as a risk factor. According to data published in September last year by WHO, 41 million people die each year because of non-communicable diseases, and cardiovascular diseases account for highest number of deaths at 17.9 million. 80% of all these diseases could have been prevented because these are linked with modifiable risk factors, and we need to address these risk factors as soon as possible to reduce the NCD incidence. And these top 5 risk factors that cause maximum mortality are unhealthy diet, tobacco smoking, alcohol use, sedentary lifestyle, and air pollution. There is no doubt about the fact that unhealthy diet is a risk for NCD incidence. More than 70% of newly diagnosed cases of type 2 diabetes, as well as more than 45% of total deaths due to cardiometabolic reasons, are attributable to suboptimal diet quality. And if we look at this picture, this data was published in Lancet in 2016. Unhealthy diet causes death, disability. It increases global burden of disease in men as well as in women. There are various factors in the diet that make it healthy or unhealthy. And the biggest dietary risk factors that cause maximum mortality and highest mortality rate are the diet high in sodium and the diet low in whole grains, fruits, nuts and seeds, as well as low in vegetables. Well, there is enough evidence for the role of nutrition in non-communicable disease risk reduction. There are many studies that have proved this down the ages. And let's take a look at a few studies that have proven this, the role of nutrition in NCD risk reduction. And I would like to start with the North Karelia project. North Karelia is a region in Finland. In the late 1960s, there was a very high mortality rate due to cardiovascular diseases, almost up to 700 per 100,000 population. People were dying due to cardiovascular diseases. Dr. Pekka Puska and his team of doctors decided to address this issue. They started by identifying the risk factors. And as you can see on the screen, these were the risk factors: very high smoking rate and dietary risks. This project was implemented in 1972 in the North Karelia region in Finland on a population level. People from the society came forward to participate to make public aware of the risks and how to address them. Healthy kitchens were set up to teach healthy cooking methods and the ways people could eat healthy. And after 5 years, when this project was completed in North Karelia region, mortality rate had fallen down from by 65% in men and 70% in women. Seeing this project was then implemented in whole of Finland. It ran for 25 years and the results were fantastic. In the year 2011, mortality rate had reduced to 100 per 100,000 population. All the risk factors improved, and as a result, blood cholesterol levels dropped by 20% and mean systolic as well as diastolic blood pressure also improved. The second study is the one that was designed by Dr. Jenkins to compare the effect of a dietary portfolio of cholesterol-lowering foods versus lovastatin on serum lipids and C-reactive protein levels. Participants were divided into these three groups. Control group had low-fat diet, including very low-fat dairy and milled whole grains. Statin group got same diet as control plus lovastatin, 20 milligrams per day. And the intervention group got a portfolio of foods that had cholesterol-lowering properties. So they got to eat plant sterol-rich foods like fruits and vegetables, soy protein as in soy milk and soy burgers, viscous fiber-rich foods like vegetables, okra, eggplant, and oats. And of course, almonds were added because almonds have good amounts of sterol as well as stenol, and they are known for their cholesterol-lowering properties. After 4 weeks of intervention, these were the results. Cholesterol, specifically LDL cholesterol, lowered by 30.9% in statin group. And in portfolio, the intervention group, it was lowered by 28.6%, and the difference was insignificant. And this was the conclusion. The difference in cholesterol lowering capacity of statin versus dietary portfolio as an intervention group was insignificant. In 2022, an expert consensus statement on remission of type 2 diabetes was issued by American College of Lifestyle Medicine. It had 3 main points. The first point defined remission of type 2 diabetes as maintaining an HbA1c value of 6.5 or lower for 3 consecutive months without use of any pharmacotherapy or any surgical invasive procedure. Number 2 point was that the diet can be the primary intervention for putting type 2 diabetes into remission in many people. And the point number 3 was that the diet that can put type 2 diabetes into remission is low-fat, whole foods, plant-based diet with avoidance of animal food products. This statement was profound, and it was endorsed, supported, and co-sponsored by various prestigious healthcare organizations. Let's take a look at dietary recommendations for NCD prevention and for maximum health. Many studies have been conducted on this topic, and there is a strong conclusive evidence that there are foods that promote health and foods that promote disease. Foods that promote health are the ones that contain high amounts of minimally processed vegetables, fruits, whole grains, healthy protein sources, nuts and seeds, and herbs and spices. And foods that promote disease are the ones that contain high amounts of saturated fats, trans fats, high amounts of salt, sugar, and again, high amounts of refined food ingredients like refined flour, etc. For example, bakery products or confectionery items are the foods that will promote disease. The evidence for dietary patterns that are based on various macronutrient proportions is inconclusive. So for high fat, high protein, or high carbohydrate diets, there is inconclusive evidence for use to reduce or to bring down the NCD incidence. What about animal-derived foods? Well, animal-derived foods are known to increase inflammation in our body, and therefore they are not really the best foods to be included if we want to bring the NCD incidence down. Now, these are the standard dietary guidelines. And composition of meal should be guided by these figures. But for a person who is not into the field of nutrition or medicine, it becomes a little tricky to follow these guidelines. And seeing this and to make following these recommendations convenient for common population, various healthcare organizations have devised visual food plate guides. So let's take a look at a few visual food plate guides from various organizations. This is the healthy eating plate from Harvard Medical School. According to this, half of your plate should be filled with vegetables, fruits, 1/4 with whole grains, and 1/4 with healthy protein. And healthy protein will be fish, lean poultry, beans, nuts. And it is also advised for the people to limit consumption of processed meat, red meat, and cheese. Cheese because it contains high amounts of saturated fats, and processed red meat because they have a very high carcinogenic potential. It also recommends using healthy oils that are rich in unsaturated fats and limit consumption of oils that are rich in saturated and trans fats. This also advises people to stay active throughout the day. And this is ACLM whole food plant-based plate. According to this, half of your plate should be filled with vegetables and fruits, 1/4 with plant proteins, and 1/4 with whole grains. This has specified that your protein has to be from plant sources. And there is a meaningful line added at the bottom that says add herbs and spices, and rightly so, because non-communicable disease is the various mechanisms by which progression and development of complications happens in non-communicable diseases is through, there are various mechanisms, and out of those, one very important mechanism is increase in oxidative stress and oxidative damage. So we need to consume higher amounts of antioxidants from our diet to counter this effect. And for that, adding herbs and spices in your food is a very meaningful addition. This is a plate from my kitchen. I have tried to translate the recommendations from this AFPB plate to my real-time home cooking. And it is very easy, as you can see. Half of my plate, as you can see, is filled with vegetables, 1/4 with whole grain, and this is white quinoa here, and 1/4 with healthy plant protein source, and this is black lentil curry, to which I added some greens and lots of herbs and spices like garlic, ginger, onion, and plenty of dry spice powder as we do in India. Now, I would like to take this time to speak about some newer concepts that are emerging in the field of nutrition. Nutrition is a vast field, and every day it keeps evolving. And there are a few changes and few newer concepts, and my presentation would be incomplete if I did not talk about them. So please allow me. So we will start with mindful eating. What is mindful eating? Mindful eating is about being in the present when you sit down to eat. It is about paying attention to your food and also to your thoughts and how your food makes you feel. It helps making right food choices, helps your brain read the hunger and satiety signals accurately, and controls mindless eating. Thus, we end up making right choices in how and when and in how much amount we eat. These are certain strategies to help you practice mindful eating. Eat without any distractions from your televisions, mobiles, or radios, and eat when you're sitting down, not when you're walking around or not when you're standing. Eat very slowly so that you enjoy each bite. Chew deliberately and enjoy the taste and the sensations and how your body reacts to this information. And take 20 minutes time to finish the portions on your plate. This is a very important point in this. There have been certain studies that have been conducted in this area. And in this first study, this was designed to see effect of mindful eating on glycemic control in type 2 diabetes. And subjects were divided into 3 groups based on their HbA1c values. A questionnaire, MEQ30, was used to assess the level of mindful eating behavior, and it was found that higher levels of mindful eating were associated with lower levels of HbA1c values and also with lower BMI. In the second study, primary aim was to analyze the efficacy of a mindful eating program for emotional eating in overweight and obese people. 2 groups were formed, mindful eating plus TAU or treatment as usual, and TAU alone group. The mindful eating plus TAU group reduced emotional eating as well as bulimic behavior and increased mindful eating, mindfulness, and self-compassion in the participants. Now about the third study. This was to see effect of mindful eating on weight loss in an online program. Intervention group participants were instructed to live mindfully by following a well laid out, defined process. Subjects in control group lost only 0.3 kilograms on an average, while in intervention group, people lost 1.9 kilograms on an average. It was concluded that mindful eating may help in weight loss. Now, let's take a look at what is time-restricted eating. TRE, or time-restricted eating, is all about eating within a fixed number of hours and fasting for rest number of hours in a 24-hour cycle. 16-8 is the most popular pattern in which all your meals have to be consumed within this 8-hour feeding window, and then you're supposed to fast during remaining 16 hours fasting window. Again, there have been a few studies here. So in this study that you see on your screen, this was a 12-month long study, and subjects were divided into 2 groups, normal diet group and TRE group. In normal diet group, participants had their meals at usual times, that is 8 a.m. in the morning, 1 p.m. in the afternoon, and 8 p.m. at night. They consumed 25, 30, and 45% of calories during these first, second, and third meal, respectively. In TRE group, participants followed 16-8 pattern. They had their first meal at 1 p.m., second at 4, and then last final meal at 8 p.m. during the day, and they consumed 40, 25, and 35% of their calories in their first, second, and third meal, respectively. All the participants ate equal amounts of calories and similar macronutrient profile. Time-restricted eating combined with resistance training in this study was shown to be effective in reducing inflammatory markers and risk factors related to cardiometabolic diseases after 12 months. There is this meta-analysis that evaluated the efficacy of time-restricted eating with calorie restriction on body composition, on weight loss, and cardiometabolic risks as well. The results showed that TRE with calorie restriction reduced body weight, fat mass, and waist circumference significantly. But this study showed no significant benefits on blood pressure, glucose, and lipid profile. And as you can see on your screen, body weight loss was significant in people who followed 16-8 or 14-10 fasting pattern. And now finally about precision nutrition. This is a very new area and not much is known about the fundamentals and how it works. But then whatever information is available, we know that precision nutrition is a method of prescribing nutrition based on a person's health conditions, unique microbiome, genes, and environmental factors such as lifestyle, food choices, etc. It is based on the fact that response to exactly same diet varies consistently across individuals. It is an emerging area of research for which funding has been provided by National Institutes of Health. Since this is a new area, there are not very many studies done in this area, but there is this PREDICT-1 trial. This study aimed at evaluating postprandial metabolic response to food in 1,002 twins and unrelated healthy adults. The authors of this study found large inter-individual variability in postprandial blood, triglyceride, glucose, and insulin response to identical meals. And it was also seen that gut microbiome had a greater influence than meal macronutrient composition when it came to postprandial lipemia. A machine learning model was developed for predicting glycemic and triglyceride response to food intake. This information may help in developing personalized diet strategies in future for addressing non-communicable disease risk. Having said this, precision nutrition is a newer concept, and there seem to be a few obstacles, starting with very high cost of conducting these tests, initial tests, and also the interpretation of the data thus obtained. Even though these are new areas in the field of nutrition, they may have a strong influence in future strategies that we plan to reduce the risk of non-communicable diseases, so they need a consideration. Well, this brings me to the end of this presentation. In summary, we could carry out these activities, and this is a list of reference sources from where I picked material for preparing this presentation. And thank you so much for having me here.
Thank you, Dr. Vanita, for this informative presentation and well-structured presentation as well. Our next presentation is delivered by Dr. Hani Al-Fahid. Dr. Hani is a consultant and associate professor of clinical nutrition and dietetics at Al-Qasim University. He is also a clinical fellow of the Glasgow University Medical School. Dr. Al-Fahid's research focuses on impact of habitual diet and physical activity on metabolic status and energy balance in individuals with enhanced risk for type 2 diabetes. He has also interest in include lifestyle intervention for prevention of obesity in groups with enhanced risk for type 2 diabetes and other chronic diseases. Welcome, Dr. Hani. I think you have to.
السلام عليكم. سعد الله صباحكم كل خير. First, I would like to express my sincere thanks to the scientific and organizing committee for inviting me to give this talk today. It is of the public and research interest to investigate or explore new opportunities for developing healthy and sustainable foods that contribute to worldwide food security. Therefore, today I'm going to give a short talk about our latest research activity on health and metabolic effects of consuming innovative date-based nutritional bar. Okay. We will present today, we will start our presentation today by providing basic background on composition and production of date-based bars, and then we will move to present our study objectives, methods, and results. In fact, that date fruit is considered as a Saudi national fruit, with its consumption being the highest among other countries in Arabic Gulf region and also in the Middle East. Research studies suggest that date palm fruits provide a superior nutritional and health benefits compared to many other fruits. They are rich source for many essential nutrients, including carbohydrates, dietary fiber, vitamins, minerals, phytochemicals, and also antioxidants. The date palm fruits are produced in many countries around the world, and about 10 to 15% of the total production is lost or sold extremely at low prices. Despite these, date fruits have been rarely used as an ingredient in commercially available energy bars or meal replacers. Currently important energy nutritional bars of known brands are composed of mixed dried fruits such as apricots, raisins, figs and raisins, and as main source for carbohydrates, and sold at expensive prices ranging from $3 to $6 each. Therefore, with the reported dates, production leftovers, and their health and nutritional values, it is of interest to provide nutritional products that are based on date fruits to enrich healthy food markets with such selections. In addition, these products would contribute to worldwide food sustainability and security. So we have developed a date-based nutritional bar with 2 bar models that are characterized by being high in energy, where about 380 kilocalories per 100 grams of each product. They are high in protein, where around 23% of energy comes from protein, and they are good sources for dietary fiber. Here, I would like to mention, and this product is not ma'mool. Believe me, this product is uniquely enriched with different sources of protein and dietary fiber. So despite that our newly developed date-based nutritional bar being very nutritious, its health effects and should be tested and maybe compared to other similar products. Therefore, we aimed to, or at investigating the impact of newly formulated date-based nutritional bars, intake on appetite, postprandial metabolism, energy substrate oxidation, and diet-induced thermogenesis, and compare to mixed fruit-based bars. So before conducting our metabolic study, we had to develop a product to compare that, which is that based on mixed fruits, which mimics the commonly available energy bars in the food markets. As you can see on this slide, mainly from this table, we have produced a mixed fruit-based nutritional bar that matches our developed date-based bar, but they differ in food sources used to produce. This table and this slide show the energy and macronutrient composition of the 2 nutritional bars. As you can see that both bars are matched for macronutrient, energy, and weight. However, date-based bar contain higher dietary fiber than the fruit-based bar, and this was due to the fresh dates being higher dietary fiber than other fresh fruits as per weight. This slide shows the sugar profile of the 2 nutritional bars. The table on the slide presents that date-based bar contains significantly less fructose and glucose, but more sucrose than fruit-based bar. These are only considerable or contributional difference between the 2 bars beside the dietary fiber. So now let's move to present our study methods. We have conducted a single blend crossover randomized controlled trial in 30 healthy adult males of whom considered normal body weight between age of 18 and 45 years. Our participants were asked to conduct 2 experimental trials in which they have consumed date-based nutritional bar in 1 day and a mixed fruit-based nutritional bar in the other day, separated by 5 to 7 days in between for washout. We have also measured metabolic rate, collected blood samples, and subjective appetite ratings in the fasted state, and every 30 minutes for the following 3 hours after ingestion of the date-based or the mixed fruit bars. We have also measured subsequent energy intake using ad libidum lunch meal at the end of each experimental day. This schematic diagram shows the study procedure and time points where each measurement took place. In total, we have conducted 420 metabolic rate measurements and collected 420 blood samples and appetite rating scales, and provided 60 ad libidum meals to complete this research project. So moving to our results, we have recruited 30 participants and excluded 3 of them due to being not compliant to our study procedure. As you can see from this table, the characteristic table of our participants, they were below age of 20 years old and had normal body weight. The figures on this slide shows the responses of glucose and insulin to ingestion of the 2 bars. As you can see that plasma glucose and insulin also levels responses were not significantly different between the study arms and time points. Similarly, that postprandial triglycerides were not significantly different between the study arms and time points. So we have measured thermic effect of feeding and energy substrate oxidation rates using quark, RMR, and direct chrometry equipment. This is considered as the gold standard, as one of the gold standard techniques to measure such outcomes. We found that postprandial metabolic rate and average increase above resting metabolic rate were not significantly different between the 2 trials. In addition, rates of fat and carbohydrate oxidation were not different between the study arms and time points. We have subjectively measured appetite using visual appetite scale questionnaires and assessed subsequent energy intake by providing study participants an ad libidum lunch meal containing more than 1,200 kilocalories each at the end of each experimental day. For this, we have calculated differences in energy intake between consumed and introduced food, so the amount of food before and after consumption. And again, we found no differences in composite appetite scores and subsequent energy intakes between the 2 trials. So in conclusion, we can say that date-based energy nutritional bars produce similar metabolic effects as commercially available nutritional bars made from mixed fruits. Our study findings also suggest that date palm fruits can be used either as part or main ingredient in producing energy nutritional bars or meal replacers. Date fruit actually is an efficient economic option, particularly in countries where mass date food production and leftovers, considering their multi-health and nutritive properties. Interestingly, that our findings also indicate that differences in sugar profile when macronutrient composition is matched do not produce different postprandial metabolic effects on metabolism, thermogenesis, and energy substrate oxidation, appetite, or subsequent energy intake. Finally, I would like to thank our research team and volunteers who helped us in completing this research project. Thank you very much.
شكرا دكتور يعطيك العافية. Dr. Vanita, are you here? Dr. Vanita, you're still here with us?
Yes, I'm here.
Yes, actually there is two questions.
Yes.
It's kind of heavy question. Is it really one of the attendees asking about it is really physical or facial microbiota transplantation, I don't know if I pronounce it good, better than the consumption probiotic? Did you get the question?
Can you just repeat the question?
Yeah, they said, is it really facial microbiota? This sounds good for you. Transplantation better than the consumption probiotics?
I guess what the attendee wants to know is microbiota transplantation better than a probiotic? Am I right?
Yes.
Okay, so I would like to say that there have been studies where it has been seen that transplanting microbiome from a healthy person to a person's gut who had type 2 diabetes, there have been positive results. But I believe in natural process of growing healthy microbiome by consumption of whole plant-based foods and increasing your fiber intake slowly so that you get time to adjust to your fiber intake. When you eat plenty of fiber from whole plant-based foods, then you naturally develop a very healthy gut microbiome that helps in many ways to keep you healthy and to reduce your risk of non-communicable diseases.
Okay, thank you. There is another question regarding to the complete of this question. They said, is this production or is approved from FDA?
Which production?
Is that I think they so asking about the facial microbiota?
Actually, about FDA, only a person who is dealing in this in USA will be better able to tell. To the best of my knowledge, I'm really I wonder what FDA is at what level of research as of now to approve or disapprove anything related to microbiota transplantation or any other procedure, similar procedure.
Okay. I think I will continue asking Dr. Vanita because I don't want to lose her. You talked about the concept regarding to some recommendation, I think based on the research that you have, about the impact of the distraction while we are eating on it is not a good way to eat. You say that is a good recommendation for that. Yes. How much this impact of us, and in particular, how it does this impact on the children? Because most children now using their iPad, using the digital platform, or seeing something, we try to distract their attention, or sometimes we want to cut their attention to eat. So is this a good habit? So we can recommend it for mom to do that or not? For the children as well.
Yeah, thank you for this question. And not eating mindfully affects everybody's health adversely. Why? Because the very concept of mindfulness says that you are only focusing on what you're doing and you are focusing only on the present moment. So the moment we divert our attention into multiple things, doing multiple things at the same time, like looking into your mobile and then eating food on your plate and watching television at the same time, maybe talking to somebody on the phone. So all these practices actually divert your attention from away from the main thing that you're doing on that particular moment, and that is nourishing yourself. This definitely has a deleterious effect for children as well as parents. And what parents can do about this is to set an example for the children to follow. So I have seen in many families, parents are working, they come back home, they have their dinner, and then they go and sit in front of TV, or maybe they switch on the TV and they have their dinner plates on the table, they're watching TV and they are eating their meals. So this is a bad practice, and parents are the example that children are likely to follow for their lifetime. So if we want children to inculcate good habits, it will be a good idea to set an example for your children and be their role model. So have good habits, sit on the table with your children and have meals in silence, in peace, and focus on what is there on your plate. Enjoy the color, the presentation of the food, the consistency of the food, and how it makes you feel. Is the food healthy? Is the food not healthy? How hungry are you? How satiated are you? And slowly, children will learn from you by example. You don't need to tutor them. They will just learn on their own by simply observing how parents are behaving about the food.
Thank you so much, Dr. Vanita, for this very nice, actually, presentation and recommendation. دكتور هاني، في كم سؤال باللغة العربية ممكن إن شوي.
تفضل.
طبعا السؤال الأساسي يقول هل هذه المنتجات اللي هو الديت بارز موجودة الآن في المقالات وفي المحلات ممكن ناخذه، ولا هذا بحث فقط مبدئي وانه ممكن ننتج مثل هذا الشيء؟
شكرا على السؤال. طبعا المنتج هذا الان قاعد يمر في مراحل تسجيله في هيئه الملكيه الفكريه السعوديه، وراح يكون طبعا بيعه محدود داخل يمكن نطاق الجامعه، ثم بعد ذلك يتم انتاجه الى خارج الجامعه. لكن احنا قاعدين نستكمل الان بعض الدراسات خاصه فيه. الخطوه التاليه راح تكون عن تاثير الانتي اوكسيديتيف بايوماركرز خاصه طبعا بالمنتج هذا، عشان تكتمل الرؤيه والصوره واضحه تكون عن فعاليه المنتج ومقارنته في المنتجات الشبيهه والمتواجده الان في الاسواق.
وفي منتجات يعني
في منتجات ولكن لا تعتمد في صناعتها على التمور. احنا عندنا بالمملكه العربيه السعوديه صناعه او انتاج التمور عالي جدا لدرجه نسبه الفاقه تتجاوز 20%. فكان المنتج هذا من ضمن مبادرات المملكه ل تطوير الابحاث ومساهمتها في مبدا الاستدامه، من ضمن الاستدامه الزراعيه والاستدامه كذلك الغذائيه والمساهمه في الامن الغذائي. فكان المنتج يعتبر فكره من الافكار اللي ممكن استخدامها. تعرف منتج اذا كان ممكن تخزينه لفتره اطول، ايضا مفيد لبعض الاشخاص المهتمين في التحكم بالمسل ماس او الكتل العضليه للجسم، كذلك التحكم بالوزن. هذه المنتجات اصبحت الان منتشره وشائعه بين الشباب للاستخدام. هذا احد الخيارات اللي تتاح لهم استهلاكها، خصوصا ان طعم التمور مستساغ لدينا اكثر من بعض انواع الفواكه.
نعم صحيح. طيب دكتور، السؤال المهم، هل ممكن ان نشوف يعني الان في اهتمام كبير في القهوه السعوديه في حليب الابن، هل ممكن نشوف هذه المنتجات تاخذ مثل هذا الزخم، خصوصا القصيم يعني طبعا يبيعون المنتج كتمور بدون يعني اعاده تصنيع او تخزين، لكن هل ممكن نشوف هذا المنتج او هل في دراسات تجاريه ان هذا المنتج ممكن ينجح في المستقبل؟ في صعوبات
قاعد تقارنه الان في حليب النوق طبعا.
نعم.
طبعا حليب النوق يختلف.
لا يعني كمنتج تجاري.
كمنتج تجاري طبعا تمور، لو سالتوا الزملاء اللي جونا من برا المملكه وجربوا التمور راح يعطون لكم راي ايجابي. وايضا جربنا سابقا في اثناء دراساتنا في الخارج، التمور لها طعم مستساغ كثير في حتى من الناس اللي ذوقوها اول مره. لذلك متوقع ان المنتجات اللي تحتوي على كميه كبيره مثل هذه المنتجات تحتوي على نسب عاليه من محتواها من التمور. وسبق ان نشرنا دراسه عن نفس المنتج هذا، مدى يعني قابليه المستهلكين له وجوده تقديمه، حصلت طبعا على نتائج ايجابيه جدا فوق المتوقع. لكن لا تنسوا احنا استخدمنا هالمره هذه التمور السكري من منطقه النسيم، هي نوعا ما اغلى بالسعر، ولكن كان الهدف انه نبدا التجربه وبعد ذلك ممكن نشوف باقي او انواع التمور الاخرى ممكن نستفيد منها بانتاج المنتج.
ممتاز. دكتور، ممكن يعني نستفيد من دراسه او هل وجدتوا في دراساتكم ككونكلوجن انه التمور يمكن انها تعادل نسبه اللي هو السكري فيها، استخدام السكر او اقل او اكثر؟ كيف لانه في كثير كلام على انه التمور حتى وان كانت يعني فروت تزيد من نسبه ارتفاع السكري او الجلوكوز بالدم.
طبعا الملاحظ ان كثير من اطباء السكر يحاول كثير يحد من استهلاك التمور لدى المراجعي العياده عنده. طبعا هذا الاساس له انه لان استهلاك التمور عالي عندنا، ولكن اذا جيت كمقارنه محتوى حتى الدراسات السابقه كتحكم في السكري الفروت متشابهه، حتى شفتم من نتائج اليوم تاثيرها على الانسولين، على الجلوكوز، تاثيرها على الترايجليسرايد كان متقارب لنفس الكميات، ولكن لان الشعب السعودي مرتبط دينيا واجتماعيا بالتمور، استهلاك التمور، فممكن هذه تكون احد مسببات او الدوافع الاطباء انهم يحذرون من التمور، ولكن التاثير هو واحد لنفس الكميه حتى لو اختلاف.
لكن كريكومنديشن كم ممكن الانسان يحتاج من السكري، يعني حبه السكري اللي عندنا؟
هو يعتمد على كم تستهلك من الفواكه يوميا. الفواكه اللي عندك تقريبا 5 حصص باليوم، لان حصه التمور عاد اذا كان على حسب الحجم والوزن تقريبا 4 إلى 3 تمرات بالحصه الواحده.
الحصه الواحده يعني 15
باليوم اذا كان فقط على التمور، وهذا ما ينصح لان ما في تنوع من المغذيات.
شكرا لكم دكتور. Thank you so much for this nice presentation from Dr. Vanita and Dr. Hani. We have زميلتنا. شكرا جزيلا.
الله يعطيك العافيه. شكرا.
Thank you so much for our speaker for the third session, Dr. Vanita and Dr. Hani, sorry, Dr. Hani and Dr. Vanita. Dr. Omar Athmali, could you join us on the stage to honoring our moderator and speaker? Thank you, Dr. Hani. Thank you so much. Dr. Vanita, do you hear us?
Hello, yes, I can hear you.
Thank you so much, Dr. Vanita, for your precious lecture.
Thank you so much. Thank you so much for having me here.
Dr. Badr Shomer, thank you so much. Dr. Thank you so much. Thank you. Our fourth session will start and moderated by Dr. Omar Athmali. Dr. Omar Athmali is Associated Professor of Physical Therapy at حائل University, served as a Vice Dean of Academic Affairs, Head of Physiotherapy Department, graduate of Salford University in 2019. Welcome, Dr. Omar.
Thank you very much. So today in session 4, we have our first speaker, is Dr. John McHugh. Dr. John McHugh is the chair-elect for ACOG District, California. He served as department chair at Scripps Mercy Hospital in San Diego and National Medical Director of Accreditation. His interests have always been to improve health and wellness with evidence-based care. He has chaired the Preconceptions Healthcare Council of California, as well as helping found the Women Health Group for Women American College of Lifestyle Medicine, where he was elected Lifetime Fellow. He has spoken and presented on the role of sleep and lifestyle on patient and physicians' health at national meeting of ACOG and ACLM, as well as international meeting of FESGO and FIGO. Let's welcome Dr. John. Welcome to the stage.
All right. Thank you. This is working okay.
And before you start, just a reminder, we have the code for questions and evaluating of our speakers after the sessions. Thank you very much.
Thank you. And the controller is there for the slides. Thank you. Well, one thing I want you all to know that was not in that wonderful introduction, thank you, is that I would really like to learn some Arabic. So I wanted to say, Sabah al-Khair, Hail, is that correct? Sabah. In one more, Shukran li Husan Dabdalik, is that right? Shukran. Thank you so much for your hospitality here. I wanted to talk a little bit, unfortunately the rest of the talk cannot be in Arabic, but I would love it to be someday. talk a little bit about polycystic ovarian syndrome, PCOS, and I think this is a very important condition for everyone to know. I trained, as we said, as an OBGYN. I've also later in my career gotten into lifestyle medicine, but I think regardless of what you do, if you are a woman, if you have a woman in your life, if you take care of patients, this is a very important, very common condition we should all know about. So I'm also chair-elect for ACOG, and I work at the University of Southern California teaching medical students and residents. I wanted to introduce these two organizations because I think that, and I've seen this in a number of our talks, putting together our organizations. We talked about prehabilitation. I think the surgeons should know about that. I think the OBGYNs should know about that. ACOG represents over 60,000 OBGYNs, not only in the United States, but also Canada and Latin America. So as chair, I will not only represent California, but also the nation of Ecuador. We would encourage all of you to get more involved in the work that we do to improve standards internationally for everyone. The Women's Health Group, Michelle Thompson is one of our members of our Women's Health Group right here. We are over 1,500 members, not only physicians, but health educators, nurses, health coaches. We really encourage all of you to become members of this. You're all welcome to join this group. I also have no disclosures to report. So wonderful having this right here. I'd like to cover three things today. Appreciate the rising prevalence of polycystic ovarian syndrome and its relationship to insulin resistance, particularly in a new acronym I learned, MENA, Middle East and North Africa. These countries, this is really rising significantly, as well as in my country, in the United States. I'd also like to talk at least a little bit about something called epigenetics, which a few of us have talked about. I think predominantly PCOS is an epigenetic condition. And then lastly, tie it together with lifestyle change, which we've had so many great presentations on here. Talk about that. So we have a picture here of an ovary, an ultrasound image of an ovary. Those of you who do ultrasound know that fluid is dark and tissue is bright. So we have an ovary with many dark spots in it, many cysts, many follicles. These are follicles which are trying to release eggs, but are stopped. Why are they stopped? Probably by the insulin resistance. The problem with PCOS is there's no one blood test. There's no single test. We have different what we call criteria, and I'll talk about what's called the most common, the Rotterdam, from Rotterdam, Holland, criteria. About 1 in 10 women internationally screen positive. Here in Saudi Arabia, 1 in 6. So this means all of us know people who have this condition. There are other criteria which I won't get into, but let's talk about Rotterdam very briefly. And by the way, I'd like to do this in less than 20 minutes and give some time back for your questions and for my colleagues as well. Number 1, oligo and anovulation. So women that have either no menses or less frequent than once every 30 days. Secondly, some signs of hyperandrogenism, male hormones in the woman. And that usually presents, number 1, by hair growth. Hair growth very commonly on the face in different areas. Acne as well can occur very commonly. And darkened skin patches as well. These things can occur in everyone, in every woman, but they occur at a higher incidence, and there are scoring systems for each of these. And lastly, as we talked about, ultrasound of the ovaries, looking for those cysts, and here are our criteria, more than 12 follicles in each ovary, or the ovarian volume is greater than 10 cc's, so an enlarged ovary. This is a graph looking at the incidence over the last 25 years in MENA, Middle East and North Africa. And as you can see, in every nation, it's increasing. 1 in 6 women in Saudi Arabia. It's the #1 cause of infertility in Saudi Arabia, more than half of all cases of female infertility are polycystic ovarian syndrome. The prevalence is rising. Why? I must apologize, probably because much of the food, Kentucky Fried Chicken and McDonald's, is coming in, unfortunately, and probably related to this rise. Also, sleep deprivation, stress, a lot of Western culture is probably leading to this rise across these nations. So this is a long, lots of information here, but I'll try to summarize it. You've probably never seen a picture of a Mexican cavefish. A Mexican cavefish, and this is one of the most prestigious scientific journals, the journal Nature. This was featured. This is a fish that eats when it floods. It floods twice a year. So imagine having all of your meals for the whole year twice. How do you eat? You eat everything you can possibly fit into your mouth twice a year, and eat as much as you can. This fish adapted to its environment by gorging itself. And probably some of the adjustments that this fish made are similar to what we humans did. Why would a condition which causes infertility and so many problems be in 1 in 6 women? Probably because it was an adaptation. Right now, look at this wonderful conference. We have dates in front of us. We can eat and drink as much as we want, but that's not human nature. Human nature were days, weeks of food deprivation, and not everyone survived. Who survived? Probably the women who knew how to store fat and how to access fat. And how do you access that fat? With testosterone. So these women not only have higher fat storage, but also have abdominal fat deposition. What's interestingly about this disease, and I'll get into it later, but it's not one gene. It's not like sickle cell anemia. It's actually probably a polygenic inheritance coupled with epigenetic programming. Very complex, but we'll talk about this a little bit. And I think it's an important metaphor for so much of what we do in lifestyle medicine, because epigenetics is how we reverse these conditions. Okay, put this into a bigger group of conditions, D, B, C, D. And this is what's important about this condition, because even if you don't do as I do, take care of women as a gynecologist, you probably see patients with D, B, C, D every day. And when you see these women presenting with something as simple as hair growth, maybe you're a dermatologist, you have the chance to recognize a condition that can change the rest of their life. When you diagnose PCOS, you have the opportunity to initiate early management. Anyone who's taking care of a diabetic who's on dialysis, it's very late in the game. But if you took care of them when they simply had hair growth, you might be able to change the course of their life. In pregnancy, these two conditions are very common: gestational diabetes and preeclampsia. But if you recognize it earlier when they presented with infertility, you might have the chance to reverse that. But later in life, if this goes on for an entire lifetime, now you're talking about a risk of heart attack, stroke, diabetes, endometrial cancer. Wouldn't we love to have an opportunity to recognize this early and reverse this condition? I think we would. We all would. So I believe Wayne Dysinger referred to John Kelly as one of the founding fathers of the American College of Lifestyle Medicine. He's going to present at our conference in Orlando on reversing insulin resistance. We're not talking anymore about managing diabetes. We're talking about reversing diabetes, taking patients off those medications. One of our leading lights, Dean Ornish, some of you may have heard of, says there are many presentations, but there's one cure for these conditions. And that one cure is what's going to work for PCOS. It's also what's going to work for type 2 diabetes. This is in the American Medical Association. This is a teaching protocol for all physicians in the United States. So what we'd like to do is to actually reverse insulin resistance. And this is what we'd like to do for PCOS. And I'll talk more about some of the ways in which we do that. Epigenetics, I promised to at least talk to you a little bit about this. The general public at this point now understands DNA, or at least they think they do. They know the double helix, which we have here, unspiraling. And we know that's inherited. Our mother and our father and their sperm and egg come together. But that's not how diseases play out. Because we know with lifestyle, we can modify diseases. And how do we do this? Probably through epigenetics. Because it's not just about having the gene, it's about activating the gene. So there are two things here which we're showing how we activate the gene. One is called methylation, DNA methylation. The gene is unspoiled or uncurled, but the methylation is turning that gene on and off. Just like you may have a light switch, but you have to turn that light on and off. That methylation is telling the messenger RNA to come in and transcribe that gene. In addition, I think we just talked about this recently, talking about the telomeres and the spiraling at the end of our DNA strands, where there are epigenetic factors that tell that DNA to coil or uncoil, activate or deactivate. And that's where epigenetics comes in. DNA, I was trained as a chemist back in the United States, is a really strong molecule. You can study it in the laboratory. These much more subtle epigenetic mechanisms are harder to study, so we're just beginning to understand these mechanisms. But this is probably how PCOS is passed from mother to daughter, or as I'm going to say in a second, from mother to granddaughter. So this is a picture of a pregnant woman smoking. Smoking is one of the lifestyle factors, one of the 6 pillars. I couldn't put a picture of a pregnant woman not sleeping or eating a poor diet, but we know that when that pregnant woman is smoking, that is actually creating epigenetic factors on both a male and a female fetus. But there is also one difference, and it's important to know. Men are creating sperm all the time. There's turnover. But a female fetus's eggs are being developed in utero. So the impact of lifestyle factors is not just on the daughter or the son, but also on the grandchildren as well. So that's very important to know, and we're looking at this now, seeing that epigenetic programming can spread across generations. And we think that with polycystic ovarian syndrome, you may have a genetic predisposition to it, but it's what happens in utero and also later in life that turns it on and turns it off for you. There was a very famous study done during World War II when the Germans invaded Holland and deprived women of food, and how their children came out later with a variety of chronic diseases. One last thing I'd say is we don't know about how epigenetic markers reset. We sort of understand DNA. We're just beginning to understand how epigenetics turns on and turns off, and possibly that grandchild could reset their markers. Okay, so when we talk about health, when I talk to even my very well-educated family members about health, they understand DNA. Well, my mother and my father, my mother had a risk of diabetes, so I have diabetes. They understand pills. I take my pill, my blood sugar is normal, everything's fine, but they vastly underrate what I would call lifestyle medicine, and that's the blue box and the red box. The blue box are the choices we make. What we eat, do we smoke, do we get our exercise every day? And the red box are the lifestyle factors which are chosen for us, what we might call the social determinants of health. Do we live near a freeway with pollution? Do we have secure housing? Do we have stress in our family? Do we have alcoholism in our family? All of those other factors that are kind of put upon us. So it's important to know that when we look at conditions like PCOS, are we actually looking at the lifestyle and the environment to see if we can reverse this condition? So I'll go into a couple things. Unfortunately, in a short period of time, I can't go into all the pillars and all the evidence. There's a tremendous amount of evidence here, but I'm going to just give you a couple highlights and then try to wrap it up. When people ask me, what should I do about changing my diet? I generally say there's one thing. If you could simply get the recommended or even the minimal amounts of fiber from whole plant-based foods every day, you'd correct a variety of nutritional conditions. And most Americans, 95%, don't get enough. I don't recommend magnesium supplements. I think you can get that magnesium from whole plant-based foods, and by following your fiber, you'll get there. I personally tried to get to 60 grams of fiber a day, and I was stuffed. I couldn't eat any more. But secondly, I want to talk about this condition, and particularly in not the food that I'm seeing here, but the food that I'm seeing on my travels to the Middle East, and that is grilled meat. Grilled meat can be a problem. The advanced glycation end products are a problem in many of the foods that we eat, and particularly in PCOS. In this next slide, we'll get into it. These are called glycotoxins. When you have meat at high temperatures, you're combining fats, sugars, and proteins.
Sorry for interrupting,
yes,
Doctor. 1 minute left. Thank you.
I'm sorry?
1 minute left.
1 minute left. Okay. The way in which you prepare the food can be an issue. I won't have time to talk about sleep, unfortunately, or stress, because I do want to get to the most important thing. This is more beneficial than birth control pills. Our summary recommendations are that lifestyle change can make a bigger change, but I really do want to emphasize this. This is a handout made by the American College of Lifestyle Medicine. It's available to all of you, covers all 6 pillars. I can email you a copy, but this can really help you with your patients and create change. And if you'd like to take a quick picture of these 2 resources, the one on the side here is from Australia, tremendous resources on PCOS. And lastly, if you'd like to get in touch with me in any way and ask me questions either here or at the meeting, I'd love to talk to you more. So thank you very much for your time. I appreciate it. And we'll take it from there. Thank you.
Thank you, Dr. John, for this excellent presentation. Our second speaker is Dr. Iman Abdul Karim Rashid. Dr. Iman is specialized in internal medicine and rheumatology consultant. She works in Al-Iskandariya University Student Hospitals as a leader for rheumatology department. Welcome. And just to remind you, don't forget the barcode for questioning and evaluation. Thank you. The stage is yours.
Assalamu alaikum. I would express my honor today to have my first talk here in Saudi Arabia in just a prestigious conference. And I'll start with fibromyalgia-friendly lifestyle tips. I hope this lecture will be light and concise. First, I start with the story of one of my patients. She's 30 years old, female, married, and have 2 children. She's a housewife, and she has no past medical history. Actually, she came with multiple complaints, and actually, I want to say her own word. All my body aches. I have to lie in bed all the day. I feel fatigue all the time. I see my doctor every month, and I took a lot of medication, especially analgesic, and nothing is have benefit. I cry all the time. I have gained weight. I have a migraine, difficulty to focus, anxious all the time, and I can't sleep well. Actually, it's a combo complaint. On examination, nothing is positive. All her joints are normal and nothing specific, just a tender trigger point, but it's not specific. And also her investigation, all are normal, especially the inflammatory markers. So actually it's not an inflammatory problem. So I think about fibromyalgia, which is a chronic illness characterized by persistence and widespread pain and other clinical and emotional symptoms like sleep disturbances and intrusive fatigue. Also, it has impaired cognitive and physical function and psychological distress. But unfortunately, the lack of objective markers of the illness has been a persistent problem in FMS research and management and even social recognition of the disease. And also many patients come after years of pain and they are not diagnosed as fibromyalgia. If we think about the evidence of the etiology of the FMS, there is many theories about this. First is the central nervous system sensitization, where they found that function MRI imaging studies comparing healthy individuals to patients with FMS, they found that similarity in pain-related brain activity, but the difference is in response to pressure pain threshold. Second theory is about peripheral nervous system sensitization, where they found that pain nerve fibers in FMS display abnormal electrical signaling to standard stimuli, and often their number of the skin is reduced. The other things they think about, there is good evidence that experiencing a stressful life course or life events such as major physical and psychological trauma increases the risk of developing FMS. Also, they found that FMS can run in families, and maybe some genetic information increase the risk of developing the condition. But all are theories. Many risk factors for fibromyalgia. If we think about biologicals, the age is mostly about 20 to 40 years old. But even we think about, and we saw patients with fibromyalgia even in younger age, in 18s or 15 years old. The age is, the gender is mainly in females more than males, but it comes in males very aggressive. About psychological, mental health, emotional health, all these influence the occurrence of FMS. Also, sociological, interpersonal relationships, social support dynamics also influence the occurrence of fibromyalgia. So when to suspect fibromyalgia, the Royal College have been publishing alert factors or alert symptoms to think about, and if we found these factors, we can think about fibromyalgia diagnosis. First is widespread pain. And actually, many patients come with widespread pain, non-specific, and not understood diagnosis, like rheumatoid or SLE. Intrusive fatigue, the patient come complaining of fatigue, and she is sleeping all the time, and she can't do anything. Hypersensitivity even to a small stimuli. Longevity of symptoms, actually, according to the recommendation of criteria of diagnosis, it's about more than 3 months. But actually, we have many patients come with years of pain, and they are not diagnosed. Ineffective treatment, especially analgesics, and the patient come overwhelmed with pain, and even the clinician is overwhelmed with their complaint, multi-system complaint, and nothing is specific for diagnosis. The patient also come with poor concentration and poor refreshment from rest. So we have two main questions as a screening questions. Over the past 2 weeks, have your pain have been bad enough to interfere with day-to-day activities, or over the past 2 weeks, have you felt worried or low in mood because of this pain? Also, we have a patient with combo complaint, as I said before, neuropsychiatric, musculoskeletal, GIT, urinary system, chest complaint, all these come together, and the patient complain of them all together. So the American College of Rheumatologists as 2016 have published the diagnostic criteria, and we summarize about the criteria rely upon the presence of pain within the body region, widespread pain index, which is maximal score equal 19. Taken together with an evaluation of associated symptoms like fatigue, concentration, refreshment from rest, and overall symptomatology with maximum score of 12. And these factors are combined in formula to aid in the diagnosis of FMS at the time of the assessment. And this is short for to fill all these questions, and then we have to calculate the score. And the diagnosis is required widespread pain more than 3 months duration, and first widespread pain index more or equal 7, and symptom severity scale score more or equal 5, or widespread pain index is 4 to 6, or and symptom severity scale score is more or equal 9 with pain in 4/5 body regions. And we have to exclude other differential diagnosis for the fibromyalgia before we rush on the diagnosis. So we do many blood tests, actually liver, renal function, thyroid, and vitamin D level. Also, we think about other conditions like sleep apnea, depression, and anxiety. We have to check the patient the medication if she's taking lipid-lowering drugs because widespread pain, and also evaluate any new symptoms that arise while we are diagnosing. And there's many neurological and psychiatric conditions that be considered as a possible differential diagnosis for fibromyalgia, like multiple sclerosis, functional neurological disorders, somatic symptom disorders, also chronic fatigue syndrome, which may overlap with FMS symptoms, and hypermobility spectrum disorders. Also, after recovery from episode of acute infection like coronavirus, and we said, and we saw many patients come with widespread pain after coronavirus, actually, but they are resembling FMS, and we misdiagnose as FMS, but actually after time, their pain goes out. What about management? And this is the main issue of our talk today is according to the EULAR revised recommendation for the management of fibromyalgia is published at 2016. Actually, they published these charts. They consider the history and physical examination first, then diagnosis of fibromyalgia and excluding other comorbidities. And they focus in the first step for management is patient education and information sheet. This is the first step in the management. If this is insufficient, we go to physical therapy, and actually they recommend specialized physiotherapist for patients with fibromyalgia. And this, if insufficient, say reassessment of the patient and tailor other medication if they want. So the first step is patient education and information sheet. May need some pain relief for pain medication, like duloxetine and amitriptyline, and psychological therapy sometimes for depression and anxiety, maybe multimodal rehabilitation program for patients if they want a sick leave or something like that. So our aim is patient education and psychosocial support. And I said to my patient, all is come from here. It's mindset changing and lifestyle changing. First, we talk about diet control. Actually, my patient own word, I eat too much. And I have gained weight in the last few months, and she was very sad for this. In 2022, there is a systemic review about dietary intervention in the management of fibromyalgia. And actually, the results are oxidative stress has been shown to exacerbate neuroinflammatory changes as evidenced in neurodegenerative disorders and may have a similar effect with fibromyalgia. Diet high in consumption of fruit, vegetables have been shown to reduce oxidative stress. And furthermore, dietary interventions such as soy protein, low-fat, low-carbohydrate diet, and GRAP polyphenols have been successful in reducing inflammatory biomarkers, including TNF-alpha and CRP. Consumption of Mediterranean diet resulted in significantly lower interleukin-6 and CRP concentration. So individuals who consume diet high in fruit, vegetables, whole grain, white meat, all found that they are significantly and inversely related to markers of systemic inflammation. While diet rich in refined grains, red meat, and all fast foods have been shown to have significantly and positively correlates with markers of systemic inflammation. But unfortunately, this review concludes that there is insufficient evidence to recommend any one particular diet intervention in the management of FMS symptoms. And this go with arthritis research UK, who also says that no particular diet have been proven to help fibromyalgia. But we recommend keeping patient weight within a healthy range by eating a balanced diet with plenty of fruit and vegetables. So my tips to my patients is the focus on nutrient-rich food to have more energy and avoid other health problems. Also, use a diary to see if any food makes you feel happy or feel well, and you can exercise after this meal. People with fibromyalgia may have low vitamin D, and actually we have to search for diagnosis of vitamin D deficiency and replenish vitamin D. And I recommend to eat fruit, vegetables, drink plenty of water, eat more plants than meat, reduce intake of sugar, and also I recommend for her to avoid caffeine, dairy products, and gluten. What about exercise? Actually, people with fibromyalgia or patients with fibromyalgia often have a love-hate relationship with exercise. Staying active is a powerful way to reduce daily pain, but actually the last thing the patient wants to do when she's feeling achy and exhausted to have to exercise. So my tip to her is be active as you can, not overdo it. Regular exercise is one most effective way to deal with fibromyalgia. It reduces pain and fatigue. Walking and swimming is the best for them. And our aim is 20 to 30 minutes, 2 or 3 times a week. And maybe she can do it in chunks, 10 minutes, and then she rests and then do 10 minutes again. Balanced exercise will help the patient to feel steadier. Also, resistance training can boost strength and overall fitness, but actually we need a special trainer for this. The plan may involve aerobic and strengthening exercise or a combination of them. What about cleaning and housework? Most of our patients are females, and all the time they are thinking about their families and how they can manage all the duty of the day. And when they have a good day and she has come in the morning and she have no pain, she thinks to try to go all the what she want to do in the list all the time and continuously. So my tip to her is to stop while you're still feeling good, or it will end in a terrible flare of pain. Do a small amount of housework every day. So she can make a stopwatch, 30 minutes, and do something or do her housework. Then she get to rest and come again after a rest for 10 minutes or 15 minutes and do 30 minutes again. She have to rest in between. Plan your work and social events so you don't overdo it. Break down big tasks into manageable bites. Also, I recommend for her build in short rest periods between activities. Fibromyalgia can make it difficult to fall asleep or even staying asleep for a long time. So we have some tips for our patient to go to bed and get up in the same time every morning and try to relax before going to bed. May create a bedtime routine like taking a bath or drinking a hot drink every night. Avoid caffeine before bedtime. Avoid heavy meals before bedtime. Regular exercise can help to sleep well, and make sure that the bedroom is comfortable temperature and quiet and dark. Avoid checking the time all the night, and test for sleep disorders. Maybe some patients have restless leg syndrome or sleep apnea. Most of our patients are thinking about their career, and this is something stressful nowadays. So high physical jobs may not be the best for someone who have fibromyalgia. So my tip for my patient is be flexible about your career. It's not the end of the world to change your career anymore. Also, don't compare yourself to normal people. Sometimes patients come and they're around friends come, you are strong, you can do everything, and you can work more, you can overlap your pain and so on. But all these tips for her make her more stressful. So I advise her to focus on things that she can do, or take pride of them, and rather comparing yourself, not compare yourself with normal people. And also don't compare yourself with other patients with fibromyalgia. Actually, you have today many Facebook groups for fibromyalgia, and all of them makes a patient more stressed, more anxious. So I advise my patient to get out from all the Facebook groups of fibromyalgia. Actually, it's a trap, and the patient come more anxious and more depressed when she go on or for all these Facebook groups. Medication must be under close medical supervision, because most of our patients come with a big bag with full of medication, full of analgesic, and nothing is helpful. I advise also my patient to keep a flare journal to look for patterns in what foods, activities, and what not cause the symptoms to get worse. It is very important. And lastly, stress relief, which is a major problem for us, is worry, anxiety, and feeling overwhelmed will drain patient energy. So my tips for her is try to adopt a more go with the flow rather than crisis approach to life. Set priorities. It's no problem to say no if you can't do it your duty. Mindfulness meditation is important, and maybe some helpful approach like cognitive behavior therapy or biofeedback. Also, mind-body practice like Tai Chi or yoga. Actually, reading Holy Quran every day and saying the Azkar is the best thing to relax. It's important to regularly take time to relax or practice relaxation technique, and talking therapy with a consultant or counseling is very helpful to combating stress. So going back to my patient again, after 6 months, management with multidisciplinary team, rheumatology, nutritionist, this last slide.
2 minutes left, thank you.
Rheumatology, nutritionist, and physiotherapy. She came after losing 10 kilograms of her weight. She was happy with that. There is no pain anymore. And even she stops all medication, including amitriptyline. According to her own word again, now I feel alive. I can keep caring of my family, socialize with my neighbors and friends. And thank you. This is my reference.
Thanks, Dr. Iman, for this fabulous presentation. And our third speaker today is Dr. Banan Al-Malki. Dr. Banan is a family medicine consultant and sleep medicine fellow at King Abdulaziz University Hospitals. Welcome, Dr. Banan. And this is as well a gentle reminder, do not forget the barcode for the question and reviewing our speaker. Thank you.
Assalamu alaikum. Assalamu alaikum, everyone. Thank you for having me as a second time in Hail in the Lifestyle Medicine Conference. I hope you enjoy my presentation and you have a good sleep health, but not while I'm presenting, for sure. So, today I will go through defining the sleep and basic physiology of sleep. I will highlight the economic implication of insufficient sleep. I will explore the impact of sleep deprivation on various life stages and providing practical tips for improving sleep habit and optimizing sleep health, well-being, and productivity. So sleep, it's a complicated process. It's not just what we just closing the eyes and counting the sheep. Sleep is an active state of unconsciousness and produced by the body where the brain is in relative state of rest and is reactive primarily to internal stimuli. It's regulated by multiple brain regions, neurotransmitter pathways, and hormones. So the mystery behind the sleep, it's remain unknown, but what we know and what's clear, it's important for our well-being, and we must take it seriously as we take the food and the exercising. So we're gonna have good sleep. It will affecting our mood. So we'll wake up early morning with a positive mood. It will affecting our memory and learning. So taking rest will making the brain to explore what's happening throughout the day and deciding what we need to restore and what we not. When we sleep, by the effect of the sympathetic and parasympathetic activity, so there's a decrease in the blood pressure and heart rate to decrease the risk of cardiovascular disease. When we sleep, it's controlling the appetite. So when we have a good sleep, so we control our appetite and hunger. When we have a good sleep by releasing the growth hormone, so it will help us in repairing the cell damage and building up our bones and muscles. When we have a good sleep, so it will help our immunity to activating the defensive mechanism and fighting the infection and the inflammation. So our sleep is regulated by a circadian rhythm. So it's mainly controlled by the suprachiasmatic nuclei located in the hypothalamus. When we just look to the light, it gives us signals to the suprachiasmatic nuclei to regulating our circadian rhythm, depending on the external stimuli, external environment. So if there's any changes in our external environment, it will affecting our internal clock. Our rhythm of sleeping and working is regulated by two biological processes that work together, as we mentioned before, our circadian rhythm. We called it process C, and our homeostatic sleep, that the urge of sleep during the day due to the adenosine accumulation in the brain. And this is known as the two-process model of sleep. Do you know that blind people, they have bad sleeping too? Yes, 10% of the visually impaired people have no light perception. That means the photoreceptor in the retina that normally signal the brain to regulate the 24-hour cycle aren't stimulated. So throughout the day, there's fluctuating of the hormones that's regulated by circadian rhythm, or some hormones, it's directly affecting the sleep, like the melatonin, as we call it, the sleepiness hormone, that helping us and promoting a sleepiness. The cortisol, it's peaking up after we wake up in the early morning. The progesterone, it's affecting the sleep by decreasing the body temperature, affecting the REM sleep, and increasing the gamma level to promote the sleepiness. Serotonin, the happy hormone, it's to promote the wakefulness. Growth hormone also, it's releasing during the deep sleep, so it's helping us for growing up. The insulin, as we know, it's controlling the blood sugar. So when we have a good sleep and it's spiking in, throughout the sleep, so we are sure that our blood pressure is controlled. The ghrelin and leptin, the hunger and fullness hormones, it's also controlled by the good sleep. Like, while we are sleeping, there's around 4 to 5 cycles of sleep, each cycle containing 4 stages. The non-REM sleep, it's including the light and the deep sleep, and the REM, the rapid eye movement. And each cycle lasting around 90 minutes. Usually we take, or normally we take 30 minutes to fall asleep as a normal individual. The adult usually take around 7 to 9 hours to sleep, and the babies, children, and a teenager, they need more for growing at their development. Okay, for the prevalence in Saudi Arabia, despite it's underdiagnosed and undertreated, but sleep disorders in Saudi Arabia, it's prevalent. There's one study showed that short sleep duration per night was prevalent. It's affecting 1 in every 3 Saudis. Long sleep duration, counting around more than 9 hours, was associated with increased comorbid condition. The prevalence of insomnia estimated around 37% in the general population of Saudi Arabia. The economic cost of insufficient sleep, it's concerning the whole countries, not just Saudi Arabia. United States accounting, sustaining around the highest economic loss due to the insufficient sleep. They are losing around 1 million working day per year and losing around $4 billion due to the insufficient sleep. insufficient sleep, so we will use too much medication or much more medication for sleep. There is a national survey done in United States in 2020 showed that 8% of adults took sleep medication in the last 30 days, almost every day or a day after day. And women show more likely than men to take medication for sleep. And in the same survey, they showed that the men with the highly economic were least likely to use the sleep medication. So it's sleep insufficiency, it's affecting us in various life stages. So it's affecting the growth. As we know, the growth hormone secreted during the deep sleep. And at the peak, it's essential for growth and muscle development. So insufficient sleep, it will affecting the development, the learning, the behavior, and overall the children health. How much does screen time affecting the teenager sleep? Their study shows that it's not about the timing, it's about how and when we use it. Despite that, the American Academy of Pediatricians and American Academy of Psychiatrists, they recommend certain hours for using the screen, but it shows that bedtime use of electronic devices, it's affecting the sleep. It's increasing the risk of short sleep duration, long sleep onset latency, and increasing the sleep deficiency. Being pregnant will affecting the sleep, yes, for sure. With the changes of the hormones, increase the body weight, increase the baby weight, it will affect the pregnant. Estimated sleep disorder in pregnant women around 40 to 70, and with a quality of sleep declining toward the third trimester. Almost 80% of the women in the third trimester complaining of insomnia, and with the sleep insufficiency, it will lead to various complications like gestational hypertension, gestational diabetes, and increasing the rate of cesarean section. How menopause affecting the sleep? By the declining of the progesterone and the estrogen, the melatonin also, it will decline. So it will affecting overall the prevalence of sleep disorder among postmenopausal women around 50%. With various sleep disorder like insomnia, poor sleep quality, and sleep deprivation. Getting older, the worse I sleep, yes, due to many combination of physiological changes in sleep, changes in the sleep-related habit, effect of the chronic disease medication, and increase the rate of sleeping disorder, it will affect the older people. So how to optimizing our sleep? By getting enough natural light. Getting enough natural light will regulating our circadian rhythm, keeping a routine. So we need to know when to wake up and when to sleep. Avoiding nicotine as its stimulant, and it will promote the wakefulness. Relax as much as we can because the stress it will affect the quality of our sleep. Being active as it's recommended. We need to around 150 minutes per week to for maintaining our health. Reduce the stimulation, like scrolling in our mobile before the bedtime, taking daytime nap to boost our energy, and cut the noises by using the earplugs. There was systematic review and meta-analysis shows that napping benefit for long-term memory formation and is a tool for many individuals used to improve daytime functioning. Shorter nap, around 20 to 30 minutes, containing into sleep wave may provide recovery of alertness. When should we exercise for optimal sleep? The exercising, it's non-pharmacological treatment for insomnia. It's characterized by safe, inexpensive, easily accessible to improve our sleep. And also the exercising alone without weight reduction, it will cause moderate reduction in sleep apnea. But the American Academy of Sleep Medicine, they don't recommend to exercise in the evening. It would cause the arousal and disrupting in the sleep. Who loves yoga? There's good news that yoga has potential in reducing sleep onset delay, increasing sleep duration, and improving overall sleep. There's meta-analysis with 5 studies, shows that focus on the effect of yoga on sleep quality for older adults indicate that yoga practice can lead to improvement in sleep quality among the elderly. Food and drinks help for better sleeping, like tryptophan-rich diet, reducing the sleepiness and sustaining alertness in the following morning, like lean chicken, cashew nuts, and milk. Food supplement with melatonin, magnesium, and zinc, improving the sleep quality and getting sleep, quality of sleep, and alertness upon awakening. Zinc-rich food, like it will decrease the time needed to fall asleep and improving the sleep efficiency. The fermented milk drink, it will improve the sleep efficiency and number of awakening episodes. Cherry juice beverages will reduce the insomnia severity, and kiwi fruit, improving the sleep onset duration and efficiency. Does the caffeine the #1 enemy for sleep? No, it's dependent on the consumption. So there's meta-analysis shows the bad caffeine consumption, it would reduce the total sleep time by 45 minutes. The sleep efficiency, reducing the sleep efficiency by 7%, and increasing in the sleep onset latency of 9 minutes, waking after sleep onset of 12 minutes. And the duration of light sleep, it will increase, and the deep sleep, it will decrease due to caffeine intake. So it's recommended to take caffeine at least 8 hours before the sleep onset. Taking a bath before bedtime, it's helpful for relaxation and sleep. There's meta-analysis shows that scheduling a bath, warm bath, not a hot bath, it will increase the slow wave sleep, the sleep duration, sleep efficiency, and significant shortening of sleep onset latency by triggering the melatonin hormone. Reading before the bedtime, reading or scrolling through the social media, for sure reading. Reading at the bedtime appear to reduce the older adult time to fall asleep and increase their sleep duration. Printed or digital, for sure printed. A study shows that 30 minutes of reading in light-emitting ebook prolong the time it takes to fall asleep, delay the circadian rhythm, suppress the level of sleep-promoting hormone, and reduce the amount and delay the timing of REM sleep and reduce the alertness the following day. Sleep tracker, is it benefit? Is there any benefit from the sleep tracker? We use the sleep tracker to record the time when we fall asleep and when we wake up and the time that we spend during the sleep. Sleep tracker, it's help you to establish a consistent routine, but we need to keep attention about the obsession with the sleep data that make a sleep problem worse. And always remember, the best tracker is your own body. Summertime is soon, so a lot of us will travel and we will have a lot of jet lag. So the jet lag, due to disruption of the circadian rhythm due to the rapid transition across the time zone, resulting in asynchrony between the local time and the human circadian clock. So there's multiple steps we can use it to help us to avoid the jet lag by resetting the circadian rhythm before the flight time. So if we are flying to the east, we can earlier going to the bed and sleeping 30 minutes for consecutive days. And if we are traveling to the west, we will delay the sleep onset to 30 minutes consecutive days. Light exposure, as it's regulating our circadian rhythm. Melatonin, it will help for our sleepiness. And using a stimulus like caffeine to promote the wakefulness and decrease the sleepiness, and some sedative drug, it could help. If you are diagnosed with insomnia, so cognitive behavior therapy for insomnia is the first line of treatment, guiding the patient through the series of changes in the sleep-related behavior. Stop counting the sheep. If you have any sleep problem, you can visit us. These are my references, and thank you.
Thanks, Dr. Banan, for this excellent presentation. Our last but not least presenter today is Dr. Mani Al-Shahrani. Dr. Mani Al-Shahrani is a consultant of family medicine and sleep medicine at King Fahd Medical City. He's working as well in the chronic care services line, led at Riyadh Second Health Cluster, and national lead of sleep medicine specialty. Welcome, Dr. Mani, and the stage is yours. this is just a gentle reminder. Don't forget to post questions and evaluate our doctors. Thank you. Sorry for this delay. Welcome, doctor.
It's technical issue.
Assalamu alaikum. Good afternoon, everybody. I hope you are still awake because the circadian rhythm will be down this time. Thank you very much for organizing committee to invite me. Actually, Dr. Banan give you offer of you about how sleep is important for health in general. My talk will be in the negative side. I will talk about how the effect of sleep deprivation in our body. So I try to convince you that sleep is one of the important pillar of lifestyle medicine. I will talk about the definition of functional sleep, offer you about the sleep deprivation. Then I will talk about the effect of sleep deprivation in our body, sleep and cardiovascular, sleep and immunity, sleep and endocrine, sleep and hypertension. Then finally, the second half of the lecture, we will show how the new research or new publication talk about this topic. As you know, sleep is a complex. It is a vital process. It is essential biological function need every day, as like nutrition, respiration, drinking, and every biological function. For sure, sleep is important for restoring energy, emotional and learning, memory, processing, cellular repair, brain development. Also, it is important for growth, and many function has been improved or has been proven by research and the evidence of state of sleep deprivation. It is becoming clear that reduced total hour of sleep has been proven affect all over the system and all over the organ of the body. Several studies have been shown that there is deleterious effect. We will show in the next slide. So sleep deprivation, it is a condition when there is inadequate sleep hours, either due quantity or quality, and can be voluntary or involuntary. It can be either behavioral or pathological. The amount of sleep, actually, it is different from age group, from genders, from age group to another groups. This is the most agreement between all society of sleep medicine. It is, when you look for newborn, they need around 18 hours of sleep. It's coming down with time until they reach the adult sleep. They need from 7 to 9 hours nocturnal sleep daily basis. Now it is estimated that 1/3 of adults in the industrial countries has experienced symptoms of sleep deprivation. The CDC of United States, they report there is 35% of the population, they didn't get enough sleep. Also, has been increased in the adolescent group, as you know. What about in our country in Saudi Arabia? It is prevalent around 46 of adolescents less than 7 hours per night. For sure, it is increased in the adolescent group. So, what is the effect of our sleep loss in our body? Sleep loss or sleep deprivation is affecting all over the system of the body. Subject with the poor sleep quality may be present with the cardiologist with uncontrolled hypertension, may be present with the endocrinologist with uncontrolled blood sugar. Also, they may be visit psychiatrists with the fatigue and symptom of major depressive disorder. Overall, immunity has been affected. We will see the next slide how the study or experimental study proven this concept. What about sleep and cardiovascular? In one of the cohort done by Ice and his colleague, they follow around 71,000 subjects aging from 45 to 65 years without cardiovascular disease. They follow him for 10 years, and they check how there is a link between the cardiovascular and sleep duration. After they adjusting the cardiovascular, we call confounder factor, they found there is a relationship between the undersleeping and oversleeping. That means when they sleep less than 7 hours, they more to develop cardiovascular disease. Also, when they sleep more than 9 hours, they more to develop prone to develop cardiovascular disease also. Immunity also, has been linked proven effect of low immunity with the sleep deprivation. The mechanism, it is related to the increase of the inflammatory mediator like interleukin-1, interleukin-6, and tumor necrosis factor. A study of acute consequence of sleep deprivation that documented there is an increase, as we said, in the lymphocyte activation and overproduction of interleukin-6 and 1 and 17. And this is interleukin increasing lead to the fatigue and lead to anti-oxidative stress and also lead to the cardiovascular events. Short sleep duration is a natural environment, may be a negative effect in the FIFO antibody. As experimental study, they found those patients when they less than 7 hours, they more or less to develop antibody after they get a vaccination. Also, this is an experimental study. They proven how the effect of the sleep duration. They get two groups and they make him sleep deprived and they expose him to rhinovirus. They found those patients, they slept less than 5 hours, they more double to develop rhinovirus infection more than those who get better sleep. Another study done in 11 subjects suffering from chronic insomnia, they found, as we mentioned, there is an inflammation or inflammatory marker, hypersecretion, also cortisol arousal happening during the daytime. And this is why the patient in the insomnia suffering from the fatigue, daytime sleepiness in the daytime. What about sleep and endocrine? There is a strong relationship between sleep deprivation as endocrine, either behavioral sleep deprivation, as you mentioned, or pathological, like what happened those with the sleep apnea patient. Several experimental study and clinical study have shown proven that frequent micro and macro arousal and desetting for those patients with pathological sleep deprivation, like in the sleep apnea patient, that lead to a repetitive surge in the sympathetic activity. Also, there is a fluctuation in the blood pressure reading and blood glucose. As you know, a common risk factor for this patient is obesity. Taken together, pathological sleep deprivation and obesity is the more prone to development glucose intolerance. In one study, also, they check for 9 healthy lean adults underwent baseline sleep study and oral glucose tolerance test, and they give him disturbed sleep for 2 nights and another 3 nights without undisturbed sleep. This disturbed sleep lead to the suppress of the deep sleep we call slow wave sleep. They found there is insulin resistance and more to develop diabetes mellitus. They propose mechanism again. This is related to hormonal upregulation, sympathetic surge, also hypoxemia, like in the sleep apnea patient. A cross-sectional study conducted in a group of African American underlying diabetes mellitus. There was around 161 subjects. They saw there is 7 of participants have poor sleep quality. Also, those with the short sleep duration have high hemoglobin A1C. That means it is not a risk factor for develop diabetes, but also it is a risk factor for poor control hemoglobin A1C for those with diabetes mellitus. Insulin sensitivity also was studied. There is effective insulin sensitivity on insulin release for those patients with the sleep deprivation. What about sleep and obesity? As you know, there is strong relationship between the sleep and obesity. This is one of the studies that follow around 983 patients. They found there is a relationship between short sleep duration and also long sleep duration has been linked to the obesity. In the one of the famous study, which is a nurse health study, they follow around 68,000 nurses for a long time. They found there is a good or a risk relationship between those with the sleep deprivation less than 5 hours. Around 32% with them will get increase in their weight. Also, in the one of the meta-analysis data in this field, they pooled around 26 studies, including around 600,000 adults worldwide. They found there is a consistency increase of obesity among short sleepers. What about sleep and hypertension? This is one of the study done in 1975. They describe as a sleep apnea patient. As I mentioned, it is those with the pathological sleep deprivation. There is a linked to development of hypertension. Also, 80% of resistance hypertension, they have sleep apnea symptom. Also, another study done by Gangwich and his colleague, they followed participants for 10 years, a sleep duration less than 5 hours, significantly increased risk of development of hypertension after they control or risk factor of hypertension. A study in a group of around 238 healthy adolescents, they used her objective measurement of sleep deprivation, which is actigraphy and sleep study. They found short sleep duration with poor sleep quality more prone to develop hypertension. Now we will see the next slide. What is the new publication? As they still convince us the same effect of sleep deprivation, or there any new? This is one of the study has been published in 2021. It is a systemic review, a study about the effect of sleep deprivation and endothelium function of the and health outcome. They focusing how endothelium function affected by sleep deprivation, and they conclude the short sleep duration correlate with the diminished macrovascular endothelial dysfunction. Also, sleep less than 7 hours per night impair microvascular endothelial function. Also, the same effect has been proven for macrovascular function. Shift worker has been negatively affected the macrovascular function. This is another systemic review, talk about the cognitive impairment and depression in the sleep-deprived patient, published in 2020. They're focusing on how the sleep deprivation affect the cognitive function and depression symptom. They conclude the sleep deprivation lead to deficit in the cognitive function and exacerbate symptom. The depression suggested there is a bi-directional relationship between the depression and the sleep deprivation. Also, another systemic review published recently in 2023. They talk about the evaluation of sleep quality, excessive daytime sleepiness, and association factor for medical students. They found, or they conclude, the medical students frequently experience poor sleep quality, excessive daytime sleepiness, influencing by demanding of their study. Another systemic review that is focusing what you call high critical job like military, surgeon, pilot. They study how the effect of sleep deprivation on their cognitive. They conclude there is a relationship, or there is a significant impair of the cognitive performance, particularly in the reaction time, cognitive processing speed, and decision-making accuracy. Actually, this is the function need to be highly in this critical mission job. Another systematic review, they talk about the short and long-term health consequences of sleep deprivation. Also, they conclude the short sleep consequence and the sleep disruption include increase in the stress responsibility, somatic pain, reduced quality of the life, and emotional distress, also mood distress, and cognitive memory and performance deficit. Also, sleep deprivation impact in adolescent, like in psychological symptom, especially in the children group. Also, the long-term consequence, as we see in the previous slide, it is linked to cardiovascular disease, metabolic syndrome, diabetes type 2, and also colorectal cancer. What about sleep deprivation and the neurological disorders? This is a systemic review done published in 2020. They conclude the sleep deprivation disturbs the circadian physiological negative impact on the brain and behavioral function. Sleep deprivation, it is impaired with the cellular clearance of misfolded neurotoxin, which is like alpha-synucleinopathy, amyloid protein, and tau protein. And they found this is a risk factor for development of early Alzheimer's disease. Also, they shown the effect of the lymphatic system, glial-dependent metabolic waste clearance. This is one of the most important functions of sleep. Those patients with the sleep deprivation, this function will be affected, and they're more prone to develop early Alzheimer's disease and cognitive decline. Sleep deprivation affects the immunological system, also affecting the neuroinflammatory and oxidative stress, as we mentioned. What about the sleep and sleep deprivation and autonomic nervous system? Again, this is a systematic review. They conclude the sleep deprivation is a link to significant alteration of autonomic nervous system, and this lead to the increase of the inflammatory, which can exacerbate or contribute to the cardiovascular disease and metabolic disease. What about sleep and metabolic syndrome? Also, they proven what we mentioned in the past slide, the chronic sleep deprivation and the risk factor for development of metabolic syndrome, and they predispose them to the cardiovascular disease. Sleep deprivation can lead to metabolic and neuroendocrine impairment, including obesity, insulin resistance, diabetes mellitus, and hypertension. Also suggest the lifestyle modification by improving the sleep quality. They mitigate this risk. Finally, to keep your weight healthy, your nutrition balanced, your mental system relaxed, and overall healthy lifestyle, keep your eye on your sleep. Thank you so much.
Thank you, Dr. Mane, for this nice presentation. We would like to welcome all the speakers on the stage for the panel questioning. Thank you. So first question is for Dr. Mane. This is a person who's wondering if, putting a legislation against the time of working for restaurants and other shops, so they close earlier, would help in sleeping pattern and helping the lifestyle for population.
Yes, thank you. This is a great question, which is one of the political change we work in the sleep medicine program according to the national wise. You need to change something like what you mentioned, early restaurant, coffee. Also, we're focusing on how the schedule of Ramadan. But there is a multi-stakeholders and what you call like ecosystem and regulation. It is difficult. You need to be agreement of all stakeholders to make this a policy. Yes, it is some international policy has been improved in this, but it's still the main challenge. Multi-stakeholder need to agree to put this policy as a national wise.
Okay, thank you very much. This question for Dr. John. This person is saying, first, I'd like to thank you, Dr. John, for this great presentation on PCOS. I'm wondering what are the most important recommendations that you can provide as a health coach to better support women with PCOS and insulin resistance.
Thank you so much. And this is live. I would really like to, in the context of my other speakers here, really focus on sleep. I think sleep is something which really everyone knows they need to get more of. Simple sleep hygiene can be counseled by a health coach, and a referral to a sleep specialist here is excellent for those who are having chronic obstructive sleep apnea. I'd really recommend to focus on sleep first and foremost for a health coach.
Thank you. This question for Dr. Banan. This person asking about, praying at night, Qiyam al-Layl, and he's wondering if this can help in sleeping.
I didn't hear the question.
So this question is asking if the prayer at night, Qiyam al-Layl, is good for sleeping.
It's a religion question, not medical question, but sure, praying at night will help, inshallah. While you are not doing strength activities that will affecting your body temperature, affecting your quality of sleep, so it will help you, inshallah. Yoga and praying, it's good for the sleep.
Okay, sorry for asking another question. This person is asking, is sleeping good amount of time at more in the morning is similar at if I sleep the same time at night?
It depends on your circadian rhythm. So if you sleep, if you are sleep deprived, as Dr. Mana said, sometimes you can cover the sleeping time that you lose it while you are awake. But it's not matching. It's not matching the amount of sleep. As we say that melatonin is secreted during the night and it's affected by the light. So usually. If there's any add, Dr. Mana, he can add something.
Yeah, let me comment on this. The recommendation it is 7 hours nocturnal sleep. This is the pathophysiology as Dr. Manam mentioned. This is because when they study how the difference between the sleeping in the daytime and the nighttime, they found there is more than 1,000 of genetic has been affected. As we know, Dr. mentioned growth hormones regulated at night sleep. Also, cortisol will be dropped in the night sleep, will be increased in the daytime. Yes, there is a difference between the nocturnal and the daytime sleep. There is a many genetic has been affected when they shift your sleeping from the night to the daytime. Actually, it has been proven those with the negative effect in the shift worker. They found those with the shift worker more prone to develop, I'm sorry for that, not to worry them. It is more prone to develop colorectal cancer and breast cancer. Usually, it is secondary to genetic. So it is the recommendation. It is 7 hours nocturnal sleep.
This is another question for Dr. Banan. In children, is this time of sleeping make difference if they sleep on morning or night for growth hormone production?
So usually growth hormone, it's not affected. Can you just repeat the question?
So this person is asking if he allow his children to sleep at the morning and wake at night, will affect their growth hormone.
So as sleeping physiology for the children, they have to take, as we said, their amount of sleeping during the night and daytime naps until they consolidate their sleeping during the night. So the growth hormone, it will not be affected that much because it will continuously releasing throughout the day and the night, but it will affect more for the adult if they have sleep deprivation.
Thank you very much. This question for Dr. Iman. Is there any studies about omega-3 and SSRI rules in controlling symptom of fibromyalgia?
Actually, about pharma medication is only Duloxetine, which is FDA approved for fibromyalgia. But actually, there is many studies, but not all of them are FDA approved. But actually, we use it in certain person, not all the person. Actually, the patient education and lifestyle changes is the best for all patients of fibromyalgia. This is by experience and is FDA approved again. Also, so medication is a little help, not is the first choice, and is a little help in managing fibromyalgia.
Thank you very much. This question for Dr. John. What type of food should be avoided if I have polycystic ovarian syndrome?
That's a great question, and it's really important to get into that. I did start to talk about especially grilled meats, I think, are really a problem for the glycation products. But I would also say processed foods. I work with a doctor who says, if it doesn't have fiber, it doesn't enter my body. And I think that's a very good, simple rule. Always have foods that are high in fiber and avoid the processed foods, especially the processed carbohydrates and the processed fats.
Okay, since you were speaking about grilled food, this is a question about grilled food. You talked about the grilled food effect on PCOS. Could you please give us some details about it?
So what happens in the process when meat is cooked at high temperatures, especially processed meats, there is a chemical reaction in which products form. And one of the things I didn't talk about, not only is this implicated in polycystic ovarian syndrome, but also in cataract formation, as well as wrinkle formation. And nobody wants wrinkles. So these are foods I think are very important to be avoided if one can. Certainly, if you're going to eat these foods, try to eat them in a less heated way. Personally, I like sushi. I think that's a good way to eat fish without increasing those products that are formed.
Thank you very much. This question is for Dr. Iman. Is it difficult to diagnose FMS? And if we apply depression PHQ-9 scales to all patients, they will diagnose as a depression. So how can we differentiate?
Actually, it's very difficult to diagnose FMS. It's taking a long time of questioning and taking history from the patient, and actually taking time to exclude other diagnoses. Actually, it's FMS not a diagnosis of exclusion, but actually it comes with many comorbidities like rheumatoid and SLE and depression even, or any GIC symptoms and many other symptoms or organic disease. So it's difficult, but it's will if we give the patient more time to question, to take the history, take their complaint, I think it's, we finally took the diagnosis. Actually, FMS is when we apply the lifestyle modification, it will help FMS and help other diagnoses also, like depression and any psychiatric problem. But if we doubt about the diagnosis, we can refer the patient to psychiatrist specialist to make sure of the diagnosis also.
Okay, thank you. This is the end of questioning sessions. Thank you very much for your presentation and fabulous speak. Thank you.
Thank you so much.
Thank you.
The best bridge between despair and hope is a good night's sleep. Thank you, our speaker. Thank you, our moderator. Could you please come for honoring? Dr. John, thanks so much for a precious lecture. Dr. Iman Abdul Karim, thank you so much. Dr. Banan Al-Malki, thank you. Dr. Mani Shahrani, thank you so much. Dr. Zamel Al-Shammari, would you mind to join us on the stage? Dr. Omar Athmali, thank you so much for moderating this session. Now it's a break for 15 minutes. We'll meet you after here. Thank you so much. 20 minutes, sorry, 20 minutes. Thank you. And there is a pointer. You can, yeah. Assalamu alaikum and good afternoon. Welcome with me Dr. Zamil Al-Shammari. Dr. Zamil Al-Shammari is our moderator for the last session. Dr. Zamil Al-Shammari, pediatric, allergy and immunology consultant at Maternity and Children's Hospital. Welcome, Dr. Zamil.
Thank you very much. I would like to thank the scientific committees to invite me to moderate the last session, which is, I think, one of the most attention-grabbing topics in the and I will start. I will start with the first lectures. It's a coping therapy and public health. The speaker, Dr. Fahad Al-Suwaidi. He's a consultant medical epidemiologist and the public health advisor to the ECO and National Center for the Alternative and Complementary Medicine in Ministry of Health. Dr. Fahad Al-Suwaidi. Kindly, please, I will pay your attention regarding the QR, the 2 QR barcode for the questionnaire evaluation, please.
بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. I'll share with you this presentation about cupping therapy and public health. The main focus in this lecture will be on the wrong beliefs. We will go through the other topics or other elements quickly so that we can save time. By definition, cupping therapy is an ancient form of alternative medicine in which therapists put special cups on the skin for a few minutes to create suction and bloodletting. We call it in our Islamic culture hijama. It was documented before 5,000 years, very long time ago, in China, Middle East cultures, all Europe, and many other parts of the world. Prophet Muhammad sallallahu alaihi wasallam was treated with hijama and recommended it. Famous Muslim doctors or physicians and scholars like Al-Razi, Ibn Sina, and Ibn al-Qayyim explained or the effect of hijama and its benefits in their literatures. So why do you think that hijama is still there and did not disappear? First, because it's a simple procedure. There is strong religious and cultural background, and the most important reason is because hijama is effective. If it's not effective, it wouldn't last for the last 5,000 years. About the regulations of cupping in the kingdom, the National Center for Alternative and Complementary Medicine, NCCAM, is the regulating body of cupping and other 5 approved practices: herbal therapy, chiropractic, osteopath, and acupuncture. Cupping regulation and licensing started in 2015. Before that date, cupping therapy was banned by Minister of Health because some studies showed significant relationships between hijama and bloodborne diseases like HIV, hepatitis B and C. There is no global estimate for the cupping therapy practices, but WHO says about 88% of countries use complementary medicine, including hijama or wet cupping or cupping therapy. The practice in Saudi Arabia is around 34%. I'm talking about hijama. The 34% of Saudis practicing hijama, according to this study, and 52% of those who tried hijama said it's effective. Among health professionals in Riyadh region in this study, in 2016, the International Sports Medicine and Nutrition Conference in Abu Dhabi recommended cupping as treatment of pain in athletes. After appearance of Michael Phelps with cupping circles in 2016 Olympics, the cupping therapy went viral, and we saw many celebrities use cupping therapy. Cupping therapy is so common to the extent that dermatology clinics can see complications of cupping almost every day. And it's been used in a wrong way. Some believe that it can be used for anything. And in this sarcastic drawing, we can see here this is celebrity. He did cupping to win the presidential election in his country. So what do we need to conduct or to perform cupping? We need a glass or cup, a mode of suction, and disinfectant. The most common type of cups is the plastic, because it's cheap and disposable. And the lancet pin, the golden one, is the easiest and safest method for doing this scarification. In wet cupping, we need to clean the area, remove the cup. We do our scarification, 6 to 12 tiny scarifications. Then we put back the cups and we apply mild to moderate suction to suck blood. Then we remove the cup and clean the blood and dispose the blood and the cup appropriately. Then we clean and dress the wound. For the dry cupping, we just clean the area and apply cups for 3 to 5 minutes and remove the cup, and no need for bandages, and the bruises will resolve in 2 to 3 weeks. Cupping therapy is used for a wide range of health conditions, mainly for pain, either alone or with a combination of conventional medicine. It can be used for wellness purposes, prevention, and control of chronic illnesses. Where do you put the cups? There are general rules. We should always use the pain points detected by the patient. Adjacent points have nearly the same effects as main points. We should use the least number of points on cups, and no indication for strong suction whatsoever. The largest cup can be used in the interscapular area for systemic disease, and cupping on the face is prohibited unless you want to do light, dry cupping. And of course, the back is the safest place or area for any type of cupping. We should avoid areas where blood vessels and nerves are close to the skin, and the danger triangle of the face around the nose, because of the possibility of transmission of infection to the brain, intracranial infection. and so on. So there are many cupping effect theories, and all of them are controversial and not exclusive for cupping. It can be used to explain the effect of other complementary medicine practices like acupuncture, osteopath, chiropractic, or even massage. We'll go to the last one, which is the hormonal theory. It says pain relief and relaxation after cupping may be due to endorphins and enkephalins secretion. And I think it's all about this theory for cupping effect, because your positive expectation will result in a positive outcome or effect. And this is, I think, the same like placebo effect theory. Is there scientific evidence for cupping therapy? These two systematic reviews reviewed 770 RCTs, 550 from China, because Chinese are the pioneers in the cupping therapy. And both of them concluded there is no significant difference between dry and wet cupping. Cupping has significant short-term effect on pain. There is limited effectiveness on systemic diseases. So why is cupping important public health topic? Because it's simple practice, doesn't require academic qualifications, commonly used by traditional healers who are lacked in basic knowledge in anatomy, infection control, and emergency procedure. So they are high-risk practitioners. It can be performed anywhere, usually in unhygienic places or settings like homes, streets, mobile clinics. And they use usually unsafe types of cups and plates. Cupping has strong religious background, as we said. Prophet Muhammad ﷺ said, indeed, the best of remedies you have is hijama. And some hijama fanatics do not believe in conventional medicine, and they can miss the chance of proper treatment. Malpractice of hijama or cupping can result in serious health risk, hemorrhage, anemia, blood-borne diseases, and so on. So why is cupping important? Public health topic, and it's all about the wrong beliefs associated with it. It can result in severe health complications or increased burden on health system. And the following slides will show common wrong beliefs about hijama in our community. Dry cupping is not effective as compared to wet cupping. There is no proof that wet cupping is superior to the dry cupping. Hijama gets rid of rotten blood. There is no rotten blood inside the body. Hijama can treat any disease. This is impossible. We can't do wet cupping on any area of the face. The face is prohibited for any type of cupping unless you use light cupping for cosmetic purposes, dry cupping for cosmetic purposes. Cupping is absolutely safe. Cupping, like any other intervention, it has its own bad side effects, as you can see. High number of cups increases effectiveness of hijama. A high number of cups will increase the possibility of skin injury and infection. the amount of blood inside the cup is directly proportional to severity of disease and cure level. A high blood amount could be due to deep incision or hemorrhagic disorder. Repeat cupping several times until appearance of yellow color liquid. This is an interstitial fluid. It can appear at the beginning or at the end of the cupping session. Apply strong suction on to suck more blood. Strong suction can cause severe damage to the skin and possible infection. Hijama is indicated in treatment of witchcraft, envy, or evil eye. There is no evidence at all. Appearance of bubbles inside the cup is indication of witchcraft or evil extraction. These bubbles is air leak from under the rim of the cups. Scarifications should cover all the area of the cup for effective cupping. As we said, 6 to 12 scarifications are enough according to the size of the cup. If no blood sucked inside the cup after scarifications, you have to repeat cups. If there is no blood, end the session and ask the patient to come in 2 minutes' time. Disinfection of the skin is not indicated before dry cupping. Dry cupping can cause skin injury and possible infection. And this is why we should use skin moisturizer or any type of oil. No need to dress the wound after hijama. And this is a very important step in infection control. The dressing will decrease or minimize the chance of infection. Hijama practitioner doesn't need any health qualification. Hijama practitioner needs basic knowledge on anatomy, infection control, and emergency. Traditional healers are more skillful than health professionals in doing hijama. It can be true, but they are not safe. Shower following hijama is prophetic sunnah. Water or shower can cause infection. Hijama and blood donation have the same effect. We don't know. This comparison needs more investigation or studies. Hijama can get rid of COVID vaccines from the body. And also here, there's no evidence for that. In conclusions, traditional and complementary medicine, including cupping, is reality, either we agree or disagree. We need more focus on educating societies and regulating the complementary medicine practices rather than banning them. We need more large-scale RCTs on cupping and traditional complementary practices. The WHO calls countries to integrate proved complementary medicine practices with health services systems. The new proposed term for instead of T and CM is traditional, complementary, and integrative medicine. And please remember that dry and wet cupping have almost the same effect and no need for the hassle of wet cupping. Thank you.
Thank you, Dr. Fahad, for this excellent lectures regarding the cupping therapy. Our next speaker, Dr. Thomas Haberbuch, and his lectures is ISO for the quality quality management in the health system. Dr. Thomas, he's a member of the ISO 9001 quality and the ISO 14001 environment standards, and he's a committees of standards committees of the Swiss Association for the Standardization, which is chaired by the ISO headquarters in Geneva. Dr. Thomas.
Yeah. Thank you very much. And yeah, it's a pleasure to speak here about ISO and give you some idea what will come or what will not come. This was also the idea from my friend here in KSA to invite me, that I'm a member of the Swiss Committee for ISO 9001 and 40000. And I told him there's announced since some months, it's announced the ISO 7101. It's for healthcare organization management and management systems for quality in healthcare organization. And I hope it will be not the same like you find in, the industry sectors. This is why I will give you a shortly, oh yeah, thank you. This is why I will give you a shortly overview about my presentation. And if you want to go deeper, you can also contact me, or you can go directly to the ISO committee. As I told you, I will speak about what is actually is ISO related, a short overview, quality management and certification regarding ISO 9001. What does government accreditation means in the frame of ISO? And why it's easier for German or European organization to get ISO certificate? A summary, what is ISO standards or what is related for the organization? And I add some ISOs from the healthcare sector that you can get some idea in which way you can also find some ISOs for the healthcare sector. And I divide my short presentation in two parts. I will give you a shortly, really shortly overview about in which way you can document the ISO. Also, you can include the ISO 7101 from the healthcare sector. And I will give you also shortly overview about the healthcare sector. And Dr. Mara, he told me he will give you the original paper from the ISO 7101. I think is mostly I saw in my career. I'm responsible for the branch from the University of Rome in Germany. That many people speak about ISO 9001 and didn't have read the original paper. This is, I don't know, understand. Anyway, so let me go through ISO. ISO was established by the United Nations in 1947. The idea was from the United Nations to create an organization for national and international standards. In this time, it was a discussion in London and in New York, and the committee decided that this organization should be based in Genoa in Switzerland. So now I will give you a really shortly overview about quality management and certification. Many people speak about ISO, speak about management, speak about quality management, but it's totally different if you speak about that. I gave you in my presentation, which you can use for your practice if you come in contact with ISO 9000 or 7101. So you see, quality management offers organizations a number of advantages through systematic. This is the main purpose why the people use ISO 9001. The difference of the quality management is the certification regarding ISO. ISO 9001 offers also conformity assessments. These conformity assessments are related to the government, at least. Since 15, 20 years, there is established an international accreditation forum. There is an international accreditation forum. This controls the inspection and certification body. I'm a shareholder from one of a certification and inspection companies since 25 years, and a lot of change is since 2010, I can say. So in KSA, this authority called SAC, it's Saudi Accreditation Center. I think it's based in Riyadh. This controls inspection and certification companies, and in each country, on 170 members, there are in the International Accreditation Forum represented is one accreditation body. So in Germany, it's called DAX. In Saudi Arabia, it's called SAC. And you find in each country one accreditation body which controls the certification and inspection company. There is also an ISO that the idea is from the ISO or from the United Nations that all inspection and certification should go through the same schemata, but maybe it's different. Sometimes the culture is different, sometimes the standard is different. ISO is International Standard Organization. You have always to remember it's a standard organization. So why it's easier in Germany? We have a lot laws. If you go to the tax system, we announced 1,700 laws only for tax. This is the same more or less in the economic field. We have in Germany, I think, sometimes doubled or tripled requirements for companies. Some are needed, some are maybe not so needed. But also the government in Germany or in Switzerland as well support the companies in structuring, in innovation and. So what is, for me, it's very important that you get this point. Use the ISO as a guideline, not as whatever it will be used, a guideline. This is written also in each ISO, in the forward, you will find it's a guideline. And please don't forget I tell it, keep it short and make simple if you describe your processes, your design process, or whatever you write in your quality manual or in your documentation for the management system, make it easy and simple so that the people or your employees understand this. I saw through my career a lot of paper. I think some papers are, I don't know for what it's useful, but you find this in the market, you find this in each organization. I don't know why they are doing. Sir, you find some ISO. If you go on the website, it's ISO organization. You find more. I only collect some that you get some idea what is ISO, what ISO is related to the healthcare sector. So now that is my important point, to give you a shortly overview in which way you can document or you can create a quality manual. So this is 10 chapters. These 10 chapters are related to the ISO 9001. ISO 9001 is it's called the high-level structure. And under the ISO 9001, all others are you find all other management ISOs, like 7101 for healthcare sector. And if you go a little bit deeper, you find the chapter 4, context for organization. Here's the quality manual or the documentation starts related to your company. Also, it's one chapter is leadership regulation, planning, support, operation, performance evaluation, and at last but not least, improvement. But when I go to the point 9, you see monitoring, measuring, analysis, and evaluation, healthcare quality indicators, internal audits, internal audit program, internal audit qualification. You have to show if you will go for a quality management, you have to, or for other management, it depends what you want, what you create, or what you want, what kind of management you will establish in your company. You can use ISO, also the ISO 7001 for healthcare sector as a checklist, yes, I would say as a checklist that you can establish your management system. If you go through this paper, you will find a lot of good ideas, but you will find also some ideas it's not needed for your organization. I will show you in the next presentation, in the next step, why it's not needed. This is it's an interpretation, at least, what you have to interpret. This document provides requirements for management system for quality in healthcare organization, as such as target audience in sport, including any healthcare system organization or entirely from the management. I think you can read by yourself, but that is important. If you will have an official certification, then you have to follow the requirements. If you don't have, or if you don't need an official certification from a CAP or from accredited certification body, you can do what you want. And as I told you, use ISO 9000 or 7101 are used in recommend implementation and control the measurement requirements to maintain or achieve a quality management system. If you say quality management, or if you say I will prepare or I will establish a management system, it's up to you. It's no, you're not finding any norms. You have to do this, or you have to name this in this or that. Especially sometimes I visit my friends in Saudi Arabia or in Libya or in Egypt. Yes, you see sometimes papers, as I mentioned before. I don't know why they are doing that. I guess they are doing that for the certification bodies, but it's not needed. That is a service what can be provided from the certification bodies. So, and no, that is for me a session in that. It's important that if you read the ISO 7001 and it's on the second or third pages, it's written as well. It's written in the page. In this document, the following verbs form are used. It's used shall, should, may, or can. So that is up to you. What is your organization? What you will prepare your management system. You will prepare for your better quality, for efficiency, for more effective in your company. It's up to you. Before you start to prepare a management system, that is what I normally do with some companies in Germany or in Switzerland. We sit together and say, what is the goal? What is the target from the management? And if we have a good quality management, it's easy to connect to certification body and apply for the certification regarding 9001 or 7101. Yes, okay. This is important that you always remind that it's never, there's different can, may, should, or shall. This makes the things a little bit complicated if you work on that, but please don't do it only for the certification body. So here you have a little bit overview what is in the norm, but Dr. Mara, he told me he will give you the original paper and send it by the people who are here. Yeah, so, and yeah, if you have any questions, please contact me by email. I will give you the answer. I think that is a good thing, at least as ISO. We can share, we can work faster, we can prepare in a good standards. Also, we can make the certification in its inspection regarding the same level at least. But I think it is have to improve in the next few years. Thank you for your attention. Thank you.
Thank you, Dr. Thomas, for this amazing lecture regarding the ISO. And then our next speaker, Professor Abdul Aziz Al Uthman. He's a professor and consultant of the clinical nutrition, president of the Saudi Society for the Clinical Nutrition, president also of the parenteral and enteral nutrition group SABE. And he will talk about the lifestyle modification. Small change can lead to the big result. Would you please, Dr. And please, can you pay attention regarding the QR barcode for the question and evaluation? Thank you.
السلام عليكم ورحمة الله وبركاته. أسعد الله مساكم بالخير. صعب جدا يكون المحاضرة الأخيرة الناس تبغى تمشي. السلام عليكم ورحمة الله وبركاته. You are most welcome actually to the last talk that will summarize my own experience that lasted maybe 27 years in the clinic, that I use lifestyle modification and prevention of some diseases. I can go. Okay. Actually, one of the difficulties that we face in clinics is referral. When a patient diagnosed with diabetes, the endocrinologist sometimes not refer this patient to the clinical dietitian or food specialist or eye specialist. So this is one of the difficulties to manage such chronic disease. So the same thing with other chronic diseases, for example, obesity or any other diseases. So referral is one of the most important within the medical team. So we need actually to work as medical team to, if we'd like to fulfill the guidelines of treatment of patients. Also, a lot of diseases not assist very well. So I can tell you frankly that unfortunately most of the clinic, they don't follow the guidelines, especially in assessment. For example, in clinical nutrition, we say this patient has malnutrition. Can be accepted, but now, no. What do you mean by malnutrition? What stage? Where I should start intervention? What type of intervention I should start? So you should give me an exact number defining the malnutrition for all diseases. I'm speaking now to the chronic diseases related to nutrition. So again, we should follow the assessment that define and clear, make the diagnosis very clear, and to use the cutoff in diagnosis. Also, personalize our assessment, diagnosis, treatment, intervention, follow-up. So, you know, sometimes we think that this patient will accept our intervention. The intervention is not just medical, it's just not scope of work that you must apply to your patient. Your patient must accept your intervention. If he believes in that, he will follow your instructions. If not, he will throw your medication or instructions when he gets out from your clinic. So we don't want to just to say, okay, this pill in the morning and this pill in the evening and cut rice and cut bread and do exercise. This is not enough. Even if somebody told me this, I will not follow it. I should believe. He should tell me exactly why is that. What is the side effect of this medication? How I can follow this what we call it, the medical nutrition therapy management. Very important to follow the evidence-based practice. Yani, we are talking about updated guidelines should be followed, evidence-based practice, then your opinion, then your experience. So you can apply your experience according to the evidence-based practice. Many people, when they, for example, obese people, they gain weight within 10, 15, 20 years, and they want to lose this weight in 3 months. They are in a hurry. So what they should do, they will say to the bariatric surgeon, don't talk to me about complications about it. I want to lose weight, full stop. What will happen to me, absorption, deficiencies, I need just to get rid of this bulk of fat. And also medications is the same. يعني كثير من الناس يبغى الحل العاجل regardless complications and what's happening in the future. And you know that 80% of those having bariatric surgery regain again. Without changing their lifestyle, definitely they will regain their weight even more. And some of them, they'd like actually to have diets, keto diets, low-carb diets, which is not approved by any association for using in losing of weight. Too many people say, okay, I use keto, I lost 20 kilos. Yes, the sources of energy is fat, carbohydrate, protein. If you change the percentage of this, definitely you will lose weight. But it is a healthy lose or not? What's happening to you? What's the complications? What about the ketones body? So unfortunately, some people think, even some of them health professionals, think that these diets, for example, keto diet, since you can lose weight, use it. Regardless what's the complications, other complications, and one of them is low-carb diet. It's not supported by any association to say this type of diet can be used. To be honest, I don't use diets in my clinic. Diet should be supervised. So should have follow-up, supervised in the hospital, and we can use it for some patients, but for short time, critical time. But for chronic disease, for example, if you'd like to lose weight, I don't think that any diet, healthy diet, non-healthy diet, is efficient. So don't follow any healthy diet. So we need to actually follow the lifestyle management, or lifestyle medicine, or lifestyle practice, all. So it's not the matter of cutting calories. Many people would like to lose weight, cut calories. If you'd like to lose weight, don't eat. If you'd like to lose weight, go and do exercise. Is it enough? The answer is no. You have to fulfill all of this. Even the type of sleeping, quality of sleeping, time, and our colleague talked about the effect of hormones, and also stress and nutrition. And our colleague talked this morning about the effect of stress on health. So we should take it as a whole. We should take the person as a whole. Talk to him, understand his medical background or history, family history. Take his daily time or time of meals, type of meals, who's taking this meals with. Then you can know the right management. So personalized assessment is very important. Mindset is very important. If for some patients I met or in my clinic, I never talk to them about diet, even about obesity itself. For example, young girls or ladies, just talk to her about her shape, her clothes, her health, how she will be after, say, few years. And some people need to talk about their health, sometimes how he can move and what difficulties that he has now in going to a bathroom or using a car or some difficulties. So it's not the matter of 1, 2, 3 steps. It's the person in your clinic should believe in what he's doing. So the type of assessment, for example, in CB, too many people, they don't use this, which is need to diagnose, evaluation, reassessment of what's happening to your patient when they go out from your clinic. What about the follow-up? Yes, taking time. Yes, taking time, but very effective to do the NCB nutrition care process. Don't give ready-made programs for your patients. Breakfast, lunch, dinner, snacks. He will do it. He will follow out, for a few minutes, for a few weeks. But at the end, he will stop or she will stop. Even you can't yourself follow steps or types of diets. Eat an apple in the morning and what is a banana in the evening. Cannot be done. So very important actually to show your clients, your patient, what he can do and give him like options. And these options from his daily meals that you talk to him during the assessment. So sometimes you don't need to focus on the disease itself, because he knows this is his problem or her problem with the weight. But talk about other issues, like what will happen to you after 10 years or 7 years or whatever. You can't imagine how many people in the mosques they have chairs. I think before maybe 10 years or 15 years, we can find chairs in the masjid, 3 or 4 chairs for old people, 80 years old. Now, how many chairs do we have in masjids? We have 30. People with about 40 years, they make salah or praying while sitting. So you need to raise this point. You need what's happening to the future. You don't need to be a burden on others, on your family. So do it now. I can help you actually to do it now, either in cutting of calories or using of diet that's suitable for diabetes. Can I ask you, for diabetic patients, what type of diet that we should for diabetic patients? Anyone who, for patients, diabetic patients? Do we use carbohydrate counting? Do we train our patients? How can they do carbohydrate counting? Unfortunately, most of us say, no, we don't. Do we train our patients to know the effect of glycemic index, or even what is glycemic index or glycemic load? Unfortunately, no. So at the end, the diabetic patient, we tell him, don't eat bread, don't eat rice, don't eat margook, don't drink. What I should eat? Despite there is no diabetic diet. Diabetic diet, we discuss it here. But in front of our patient, we don't have diabetic diet. What is diabetic diet? Low in sugar, high in fiber, fresh fruits, vegetables, and things, more carbohydrate, enough water, many meals, no 1 meal a day. This is the healthy diet that I want myself to follow. So we don't want to have this stigma, this diabetic diet or other diets. I use this. We have to enjoy our life. The quality of life is very important. While we need to get rid of fats or promote the glucose level in your blood, you need to enjoy your life, enjoy your meal, make it fun for you and for your family. So it's not steps or medical steps you have to follow. So many people need to support. They need somebody to listen to them. You need somebody to appreciate what they are doing. Okay, tell me, for example, those teenagers, what you are doing? I'm doing a little exercise. I love to drink cola, and I have some not healthy snacks, and sometimes I eat some vegetables or fruits. Great, this is great. You need to modify it. No change, no big change. No, don't bring a complete ready-made program and apply it to your clients. Listen to him or her and just make little change. And next visit, complete this little change. So if you make 20% change, that be acceptable, and this will yield great results. If they just cut sugar, or if they can do 10 minutes daily exercise, this is great. Let us start with this. Also, some dietitians use food guide pyramid, or say to the patients, you need to have 250 grams from this and 100 grams from. They don't understand this. How I can measure this? So I don't think the food guide pyramid, for example, is effective way for patients. So the easiest way is the eat well plate. What I tell my patient, I tell at the end of the day, just imagine that 1/3 of your meals, vegetables and fruit. 1/3 is carbohydrate, any carbohydrate, eat rice, eat macaroni, but just 1/3. And 1/3 is protein, and enjoy it. Just make any change, and I give them some examples of this. So this is effective, easy. Many options can be done, because some patients, they don't like special, type of fruits and vegetables. I tend to tell my patients, and I'm telling myself even, listen to your organs, listen to your body. Your body is trying to tell you something. So if you have any symptoms, to listen to your body. Your body is trying to shout, to say, please stop, please. And you are just ignoring this. So you have to listen. If you talk about obesity, for example, talk about the health of knees or heart. I mean, this is also be effective. How we can change our kids' choice to healthy food. We have to follow it. Don't talk about your kids about the danger of unhealthy food while you are eating, or smoking while you are smoking. So they don't need somebody to talk. They need to see your practice at home. Do you think our traditional meals or foods are healthy? Who'll say yes? Okay, who'll say no? Oh, too many, maybe. Actually, I believe our traditional foods is healthy, but we need to modify it. But if you see, for example, in lifestyle medicine, if you know gursan, do you know gursan? Especially our friends. Gursan is one of our traditional foods that we have wheats, vegetables, and some meat. So how can we make this gursan, traditional foods, healthy? To have it, for example, gursan. Gursan means wheat. Gursan with vegetables, to make it vegetables with gursan. To increase the portion of vegetables, and that will make it healthy. So again, other foods, because here in Saudi, we tend to have milk from camel and cows, wheat, dates. This is our main foods, main source of foods. We need actually to modify this by adding more, for example, vegetables to the traditional food. Even I've been invited last year in Samira, it's one of the area here in حائل, and they asked me about this way of the traditional food. Is it healthy? I told them, oh, let me ask. Do you think المفطح is healthy? No, because it's too much fat, right? Actually, it's healthy. But we have, 1 minute, we have to eat it as it was. Do you know how we eat this big sheep and rice? The guests will start first, and the guests eat for, say, 10 minutes, and they get up before they feel full. And there is other group will come to eat. Then young people, then the children. So this will be eaten by for group of people. So at the end, you eat, but not too much. Our problem, we eat too much portions. So open buffet has one of options, can be done. Very important to show our kids or people or patients to read nutrition facts on diet and to change the image of healthy meals. I will give you example. For example, burger, I can make it healthy. I can do it at home. I can use my vegetables. So because the kids like it, so I need to just to modify it. I can do it or make it at home. And also the breakfast meal or lunch box can be also very important. As you know, many of our kids, instead of doing exercise, they are playing, games. So we have to also encourage them actually to do some exercises. I will show you just examples how you can attract. The problem, some of our kids, they don't like vegetables and fruits. Why? Because we don't present it in the way that can be attractive like this. This is just examples, and I'm sure that if we do this to our kids, our family, even our patients, they will start to like it. So sometimes some patients with morbid obesity, I told them, do you know why you have morbid obesity? He said, no, because you don't like vegetables and fruits. Oh, yes. Or you're a little bit inactive. Oh, yes. Just, do this too, that then you can improve your health. Finally, this is one of the program that I give to my patients. I told them, don't change everything in one visit. For example, in the first week, just visit your physician or clinical dietitian and find out what is your bad habits. Then try to increase your portion of vegetables, reduce sugar, reduce, for example, the cola or this type of, then reduce or change the type of oil. Little by little, within 8 weeks, definitely your health will be improved. Thank you very much.
Thank you, Prof. Prof. Abdulaziz. And this is for this very amazing and fabulous presentation, please. And we would like to welcome all the speakers to the interactive discussion for the questions panel.
Close to the moderator.
We have a lot of the questions. I think most of the questions will be for the Dr. Fahad. After how many months do you do or do you recommend the cupping again or cupping therapy again?
Per year.
Per year.
Yeah, it's usually within 2 to 3 months separation between sessions. So it can be 5 to 6 times per year.
Okay, so there is
the limit is the healing of the wound.
Okay.
Yeah, that's the indication.
Okay. So I'm asking about the industry of the cupping therapy, whether the communicability of the disease or reputation of the communicability of the diseases, is it affecting this industry at present or in the future or is there any precaution they do it before did the cupping therapy?
Oh yes, indeed. The NCCAM, which I'm representing today,
okay,
put in the past regulations, specific or strict regulations, starting from 2015, stating that the practitioner should be basically health certified practitioner from the Saudi Health Commission. And we do not license the practitioner unless he is physician, nurse, or RT, علاج طبيعي. Okay. So these regulations.
Is he taking a consent? That's meaning if there is any age limitation for allowing for the cupping therapy in the Saudi Arabia.
Yeah, it's prohibited for young children because the skin in young children is fragile, and also prohibited for the elderly as well, for the same reason, fragility of the skin.
Okay. Thank you very much. Thank you. Dr. Thomas, I have a question for you regarding the checklist in the leadership for the ISO accreditation. And outside the Germany, is there any advisory help by the headquarters for those who are applying for the ISO? They can do it for the companies or for any anyone who's applying for the accreditations for that?
Yeah, normally when I told you I'm a shareholder in a company for inspection and certification by TO, and when we have a contact or an agreement with a company, we send at first the checklist. It's that the client or the company or the organization know what we will ask him. So this is a normal procedure. It's nothing. It's you have to ask about the company or the organization. Have to ask about this checklist. I know sometimes it's confident, but no, it's a service. Certification and inspection is it's a service what we can offer or what we offer, and this company are controlled, or all companies in certification and inspection are controlled by the government, by local or local organization like here in KSA, or in Germany we have both accreditation for Saudi Arabia and Germany, and this organization also check the inspection companies that they give this certificate, this checklists or this questionnaire to the clients.
Okay, thank you very much. Thank you. Prof. Abdulaziz, you have a lot of the questions, but I think for the short of the time, I have one question for you regarding you present the little changes in one of the important pillars of the lifestyle, the nutrition. And one of our national problem is the pre-diabetic and pre-hypertension. And can you help us regarding, I don't want a lecture, I'm not expecting you that you will give us a lecture regarding the pre-diabetic changes or the pre-hypertensions, but if there is any, what do you call it, any web or the app store site can help those kind of people, the pre-diabetic and pre-hypertension, for this little changes in their life, because this is a very important for our national problem, this one. Okay. Thank you.
You are right. First, very important actually to educate people about this. Either the pre-diabetes or pre-hypertension. I honestly can tell you 100% that we can control it. We can stop the progress or degradation or complications of patients. And I have many patients, they have hemoglobin A1C was about 6, and now it's less than 5. So give a hope for your patient. Don't make it complicated. Try to add more vegetables, fruit, fresh fruits or fresh meals. Eat 3 to 4 meals a day. Follow the balanced diet. Don't talk too much about healthy diet. So balanced diet is good to actually to help patients to follow. And don't use also exercise, because some people, they say, okay, well, where you should go to do exercise? But we can use physical activity. So I'm sure that if they cut sugar, if they cut white bread or white wheat, just these two, will make big difference in management of obesity and diabetes. And also the hypertension, many people thought that salt can cause hypertension. No. The problem with the hypertension is not the salt we add to food, but is the sodium itself. The sodium itself found in benzoate sodium that we found in canned foods. So I tell the patients, stop eating canned food and try to eat fresh food and do some physical activity. By this, I'm sure that we can prevent them from these complications.
Okay, thank you very much for the all speaker. We would like to welcome all the speaker for the certificate handling for the now. And thank you for the all. I think this is the end of the 5th session for the Okay.
Thank you so much. It was awesome lectures. It's honoring time. Dr. Muhammad Zayed, could you please join us on the stage? Dr. Thomas, thanks so much. Dr. Fahad Swedi. Dr. Abdulaziz Al-Uthman. And finally, our great moderator, Dr. Zamil Al-Shammari. That's all for today. Looking to see you tomorrow. Thank you all.